Healthcare is often provided in busy clinical scenarios where lives are at stake. Decisions are made in a rush. Reports are analyzed on the go. This is where we step in. We search for innovative solutions across clinical scenarios. By rebuilding connections between people, device, space,
Nakikita Good morning, all. And on behalf of the HICS organizing team, I welcome you all for the second day of the 8th edition of Hyderabad Intensive Care Symposium. Good morning, Dr. Sheila. Welcome. And I hope you all had a great learning experience yesterday. Continuing where we left off, to start the day's proceedings, the morning theme is all about how much is too much. We all know that there's a lot of emphasis on not overdoing things, and there are certain important aspects in intensive care where you need to have an absolute clarity about where to draw the line. And to start the first lecture, it's my proud privilege to invite Dr. Sheila Nayan Maitra, Professor of Intensive Care from Tata Memorial Hospital, and she's also the President of IISc. She's going to speak to us about how much is too much with respect to fluids. Over to Dr. Sheila.
Yeah, good morning, everybody. And thank you once again to the HICS organizing committee, especially Dr. Srinivas and team, for giving me this opportunity to speak about a topic that's really very dear to my heart. I hope you can see my slides, the presentation. Can you see the slides?
Yes.
Yes, and you can hear me. Okay. So thank you very much. So over the next 15 minutes, I'm going to be talking about a topic, and that is fluids. How much is too much? Now, as you know, fluids are something that we give very commonly in the intensive care unit. And there's nothing that we have so much wide variation in the way we give as we give fluids. And so it's really important because fluids are also like drugs and we can't just give them very casually. So when you have a patient in acute circulatory failure, one of the first few things that we do is fluid loading for this patient. And we give, we try to optimize the preload. So one would ask that, does it matter whether we give more fluids or not? We know that excessive fluid loading is associated with increased complications, right? But at the same time, if you have uncorrected hypovolemia, that also affects tissue oxygenation. So it does matter how much fluid you give, and we should treat fluid like we treat any other drug in the intensive care unit. Now, I'll try to explain this with a case, okay? So again, we're not talking about a patient who comes with acute bleeding or is severely dehydrated, because that's a no-brainer. You give fluids. You don't have to assess whether this fluid patient is a fluid responder or not. It's after the initial resuscitation that you really have to think, should I be giving more fluid to this patient or not? Because you may not cause benefit, but you may actually cause harm to some patients, okay? So I'll just take you through a case. So this is a patient for an emergency surgery that's come to your ICU from the emergency department, 55-year-old male, CA colon, intestinal perforation. He's had an MI 1 year back, okay? Ejection fraction is 14. He's febrile, elevated white cell count. His abdomen is very tense and distended. Obviously, this is a perforation. And we've intubated him, ventilated him. He's on receiving high PEEP, high FiO2. And almost 3 liters of fluid has been given in an emergency department because, of course, they thought this was septic shock. Heart rate is 120. He's still hypotensive. CVP is 14 and lactates are 4.5. So this patient has already come to you after the initial resuscitation. Now, my question to you is, should we be giving more fluid to this patient or not? So look at the CVP. It's very high, but the lactates are also high. Patient is still in shock. Okay, and this is a patient of septic shock. So should we be giving more fluid? Now, this is really a dilemma that we face when we are in the intensive care unit. Now, are there reasons to give him fluid? Yes, intra-abdominal sepsis, relative hypovolemia, sequestration of fluid in the bowel. We know he has persistent tachycardia and he also has high lactate. Now, are there reasons not to give him fluid? If you look at the CVP, it's 14. This patient has already received 3 liters of fluid in the emergency department. He also has this cardiac history. So determining which patient will be fluid responsive is really a challenge in the intensive care unit after the initial resuscitation. So on one side, you don't want to push the patient to pulmonary edema, but on the other side, you want to give fluid and you want to restore organ perfusion to this patient. So when you ask the question, should I give more fluid to the patient? What you really want to know is, will the cardiac output increase when I give fluid dosing? Because if the cardiac output doesn't increase, then there's no benefit of giving fluid, okay? And you might actually cause harm to this patient. So when I decide to give fluid, I like to ask myself 3 questions, okay? First question is there acute circulatory failure? Okay, you and I may also be fluid responsive, but that doesn't mean that we have to give fluid. We should receive fluid. The second question is the patient fluid responsive. Okay. And the third most important question is, even if the patient is fluid responsive, there should be no major risk of giving fluid. Now, if your answer is yes to all these questions, 3 questions, then you should go ahead and give fluid. Now, the first question is easy to answer. I'm sure you all know how to determine whether a patient is in acute circulatory failure. Let us check how to decide whether a patient is a fluid responder or not, right? So what do you mean by fluid responsiveness first? So it is a state when administration of fluid will result in improvement in the stroke volume and hence the cardiac output. Like I mentioned, if the cardiac output doesn't increase, there's no benefit and there might actually be harm. Now, when you give fluid to a patient, we presume that they are on the steep part of the Frank-Starling curve, okay? Which means that by giving a certain amount of preload, which is on the x-axis, as you can see, there is an increase in the stroke volume. But there isn't one Frank-Starling curve, okay? There's a whole family of curve, again, depending upon how much fluid you've already given the patient, what is the cardiac function. For example, a person with a poor cardiac function, you might give the same volume of fluid, but there isn't enough increase in the stroke volume, and this patient becomes fluid unresponsive, whereas this patient is a fluid responder. Now, what's important to understand is that preload is not preload responsiveness. Today, I'm not interested in knowing how much more fluid I can give the patient or how much more fluid this heart can take. What I'm interested in knowing is that by giving fluid, how much is the cardiac output going to increase or not? And that's what we mean by preload or fluid responsiveness. Now, one of the most commonly used modality is looking at CVP. A lot of people use CVP to assess whether the patient is going to, should be given fluid or not. And this is a meta-analysis. You all know almost 2,000 patients. This comes from Paul Marek. And look at the area under the curve, okay, 0.56. It's almost like tossing a coin. So there's no data today to support the widespread practice of using CVP to guide fluid therapy. And they concluded that this approach of fluid resuscitation should actually be abandoned. I'm not saying CVP is useless. CVP is quite useful for many other applications, but it does not help you assess whether the patient is fluid responsive or not. Another thing that we can do is give fluid to the patient and then check whether the cardiac output increases, okay? And that's what we call the fluid challenge. And you have the more recent modified fluid challenge, updated one from Jean-Louis Vincent and Mauricio Ciccone and Daniel De Becker. And they recommend not very high volumes of fluid, but about 200 ml of fluid over 10 minutes. And then you check whether cardiac output increases or does not increase. And then if the filling pressures don't increase excessively, you can consider giving fluid to the patient. Now, this is a good approach. It's the gold standard. But like I said, if your patient is a non-responder, you would have given fluid to the patient, and you may actually cause, firstly, no benefit, but you may actually cause harm. So you can't take out that fluid, right? So we need a way to predict. That means before you give fluid, you should know whether the patient is a fluid responder or not. Now, if you look at the surviving sepsis guidelines that have just been published, and also the fluid administration, the ESICM guidelines for acute circulatory failure, fluid management, I'm very proud to be a member of this team. Both these guidelines recommend that you should use dynamic over static parameters like CVP to predict fluid responsiveness. So we should be predicting fluid responsiveness, not giving fluid. So what are these methods to predict fluid responsiveness? Now, many are based on heart-lung interactions, using pulse pressure variations, stroke volume variations, IVC, SVC variability. You can always also use some non-invasive methods like pleth variability index or tidal volume challenge that was developed in our unit, or you can use end expiratory occlusion test and other newer methods like lung recruitment, PEEP challenge, etc. Now, all these depend on heart-lung interactions. But there's one test that does not depend on heart-lung interactions, and this is the passive leg raising test, and it can overcome a lot of the limitations of the test based on passive heart-lung interactions. So now I'm sure you must have seen when you put in an arterial line in a patient acute circulatory failure, you must have seen these typical dynamic changes in the arterial waveform during mechanical ventilation, during inspiration and expiration. Now, this is normal physiology, but you will see big swings in patients who are fluid responders. And this is actually the principle that is used when you measure pulse pressure variation and stroke volume variation in these patients. So you look at, for pulse pressure variation, stroke volume variation, what the monitor does is you look at the maximum minus the minimum and you divide by the mean, and you get a value of the pulse pressure variation of the stroke volume variation. Of course, for pulse pressure variation, you don't need continuous cardiac output monitoring. You just need an arterial line, and you can get this value on the monitor. For stroke volume variation, you need a cardiac output monitor, and you can get, so you have cutoff values. So for instance, something above 12 will be a fluid responder, and if it's below 12, it will not be a fluid responder. So how reliable are these parameters? Okay, now these parameters have been extensively tested, and if you look at the area under the curve, 9.4, 9.84, so 3 meta-analyses are there, very, very reliable. The only problem with this is all of these have been tested at higher tidal volume. They're very, very reliable when the tidal volume that you're using for ventilation is about 8 ml per kg. They're not reliable at 6 ml per kg. So very reliable tests, but not reliable when you use a tidal volume of less than 8 ml per kg. And today we know we are not using 8 ml to ventilate patients, not only patients with ALI or ARDS, but even patients with trauma, with patients who come in shock. We use much gentler, we use 6 or even less than 6 ml per kg. So in my unit, we hypothesized that, okay, you have excellent tests, pulse pressure variation, stroke volume variation, very well validated. They work very well at 8 ml per kg, but they don't work at 6 ml per kg. So we hypothesized, and we published this in Critical Care Medicine, a new test, and we called it the tidal volume challenge. And our hypothesis is that, okay, it doesn't work at 8, it doesn't work at 6 ml, it works at 8 ml. So why don't we transiently increase the tidal volume from 6 ml per kg to 8 ml per kg ideal body weight, and then measure the pulse pressure variation or the stroke volume variation. And the hypothesis is that the problem really when you use a low tidal volume is that your pulse pressure variation and stroke volume variation, because of the low tidal volume, you are not able to produce the changes in the intrathoracic pressure that are desired to make these tests work. So you will get a lot of patients with a lower value of pulse pressure variation who are actually fluid responders, but may show lower values because of the low intrathoracic pressure because of using the low tidal volume. So perhaps this kind of test may help you unmask the fluid responders. And we had very good results. And the cutoff values that we got were, not as I hypothesized, it was 8 ml would unmask. We got good values for that, 0.91, 0.92. But what was even better than increasing the tidal volume to 8 ml per kg was the delta. That is the difference between the tidal volume at 6 ml and 8 ml. And that was a better predictor of fluid responsiveness with a cutoff value of 3.5 and 2.5 for stroke volume variation and pulse pressure variation. I'll show you very simply how you could do this test, because many of you may not be familiar with this. See, this is your monitor, and you can see your pulse pressure variation comes as a number with just an arterial line. And this is a patient ventilated with 270. 45 is the ideal body weight, so that's 6 ml per kg. Now I'm going to transiently increase the tidal volume from 6 ml per kg to 8 ml per kg. Okay, so you see from 245, I've made it 360, and you look at the pulse pressure variation. Okay, I put both the screens together. So you can see that the pulse pressure variation, which was 8, has now increased to 10. And you observe this for 1 minute. You don't want to keep the tidal volume at 8 ml for more than 1 minute. Okay, so from 8, it went to 10. From 10, it went to 13. From 13, it's now gone to 15. You do this for 1 minute, and then you bring the tidal volume back to 6 ml per kg. And then you look at the delta, that is the difference between the pulse pressure variation at 6 and at 8. And you see I'm bringing the tidal volume back now to 6 ml per kg. Now we started with a pulse pressure variation of 8. This became 15. 15 minus 8 is 7. And this is more than the cutoff value of 3.5. And this patient is a fluid responder with a good specificity and sensitivity. You see the specificity and sensitivity, and the cutoff value is 3.5. If you're using stroke volume variation, you can use a cutoff value of 2.5. Now, if this was a non-responder, it would have probably not increased, but you saw the increase from 8 to 7. And this test has been validated now. Several studies have been done across the globe. And now we have a meta-analysis that was done by a Chinese group using the tidal volume challenge and assessing the reliability with pulse pressure variation. I won't go into details about this, but they showed that tidal volume challenge could improve the feasibility of pulse pressure variation in patients ventilated not only with low tidal volume, but also in patients influenced by low lung compliance and also moderate PEEP, and it could be used, but you have to be cautious in patients with prone position and in spontaneous breathing activity. So I'm very proud to say that a test that was developed in our unit has now global acceptability, and we also have a meta-analysis. The most commonly done test at the bedside is echocardiography. And of course, you can look at SVC, but IVC variability is what we're looking at. You can also look at the changes in aortic root velocity, but what we commonly look at is the variation. Now, always, a lot of people say IVC is big, IVC is small. what we're looking at when we're assessing fluid responsiveness is the respiratory variations in IVC diameter, okay? It is not the size of the IVC, not reliable and spontaneous breathing. And during controlled mechanical ventilation, you can look at the respiratory variations, and then depending on which formula you're using, whether it's maximum minus minimum divided by the minimum or divided by the mean, these are two formulae and different cutoff values, you can decide whether this patient is a fluid responder or not. Very easy to perform. You don't need any cannulae, however, not very reliable. This is the largest randomized controlled trial, fence multicentric trial, almost, over 540 patients, 500 patients. And they looked at, compared all the different modalities that were used for, echocardiographic variables. And unfortunately, if you look at the area under the curve, not very good results, 0.7, 0.63. Among all the tests, the SVC variability using transthoracic echocardiography was better, but you can see IVC variability was not very good, 0.65. But it's really good as an initial screening tool when your patient comes in acute circulatory failure. And interestingly, if you look at the data more carefully, only 2/3 of the patients, that 66% of the patients were ventilated using heart-lung interaction, were low tidal volume. So the point I'm trying to make that even IVC variability is affected by the heart-lung interactions, unlike what people believe. It's not affected by arrhythmias like pulse pressure variation and stroke volume variation, but even low tidal volume influences the reliability of the IVC variability. So you should take it with a bit of pinch of salt. And these are, since IVC is the most commonly performed, this is a more recent meta-analysis, and you can see again it's 0.8, 0.79. So good, not really as good as the test, but quite reasonable and very practical to do at the bedside. Then we also have the end expiratory occlusion test. Now, this is a very smart test that comes from France. What they do is at the end of expiration, give a 15-second expiratory hold. So what you're doing is you're preventing the next inspiration from occurring. And when you release the button, you have a sudden increase in the cardiac output. And if this cardiac output increases more than 5%, you have this patient is a responder with a good specificity and a sensitivity. And they've also done a meta-analysis now. And if you look at it, a 5% increase in cardiac output during end expiratory occlusion test reliably predicts fluid responsiveness with a good specificity and sensitivity. The only problem with this is 5% is very small number. It's almost the margin of error. So you cannot do this using echocardiography because it's not very reliable. 5%, you need at least a 10% difference for echo to be reliable. So you need continuous cardiac output monitoring if you're using a 5% cutoff to assess fluid response. That's the only limitation. Others, very, very easy test to perform at the bedside. So these are the tests that I mentioned now, looking at the heart-lung interactions. I talked about pulse pressure variation, stroke volume variation, tidal volume challenge, end expiratory occlusion test. Some more tests are there, but more in experimental phases. Cutoff values need to be determined. Now, all of them depend on heart-lung interactions, but the one test that doesn't is the passive leg raising test. Very easy to perform, again, coming from the French group. And if you look at this, there's some important points you should know about how to do this test accurately. First, you start from semi-recumbent position, not from flat position. And then you move the bed and not the patient. If you lift the legs, you'll have tachycardia, and then you don't know whether the cardiac output is increasing because of the patient, the fluid responder, or because of the sympathetic stimulation. And you need real-time, cardiac output monitoring. That's one of the limitations. So the test is very easy to do, but you need real-time cardiac output monitoring, and an increase more than 10% predicts fluid responsiveness for this patient. And you're mobilizing a lot of blood, not only from the lower limbs and and also from the pelvic area when you start from the semi-recumbent position. But now, instead of cardiac output monitoring, you can also use echocardiography, because the cutoff value for PLR is 10%. And this is again a meta-analysis from the group that is shown that you have a good threshold. So more than 10% increase in cardiac output is reliable. So with pulse pressure variation, you can also use echocardiography. You can also use a drop in pulse pressure variation, as has been recently shown. So this test is quite reliable, simple to perform, but you need continuous real-time cardiac output monitoring. Now, this is a meta-analysis of which has recently been performed of all the tests assessing fluid responsiveness, but again at low tidal volume. So this was a systematic review and meta-analysis. And if you compare the tests, I was really, really happy to see the tidal volume challenge, the test that comes from my unit, fared very well. Stroke volume variation, end expiratory occlusion test. But if you look at even the delta IVC, or you look at the PLR, all of them are very reasonable. The area under the curve is pretty good. Now, people always argue that, okay, All these tests will help you assess fluid responsiveness, but there's no difference on mortality. And this is a very nice meta-analysis that has recently showed that incorporating the dynamic assessment of fluid responsiveness, these tests, into a goal-directed therapy. Okay, so this is a systematic review and meta-analysis has actually showed that when you incorporate this in an overall goal-directed therapy for assessing fluid responsiveness, there is associated reduction in mortality, ICU length of stay, and duration of mechanical ventilation. So coming to the end of my presentation, I said you should have acute circulatory failure. You should be able to, the patient should be a fluid responder. You should have yes to both these questions. And the third most important question is that there should be no major risk of giving fluids. Because even if this patient is a fluid responder, if there is a risk of giving fluid to this patient, then I would not give fluid. I would actually go up on the vasopressors. So just because the patient is fluid responsive using the test that I've just alluded to, it's not a reason to give fluid to this patient. So how do you assess whether the patient is at a risk of giving fluids or not? So you can use common modalities, your X-ray, a patient with a bad ARDS, you can use lung ultrasound, a lot of B lines, echocardiographic variables. You have this tool at the bedside where you can assess cardiac function really well. And these are things that give you some objective assessment that this patient may be at a risk of getting fluid. Now, I want a word of caution. Just because a patient is has a low ejection fraction or cardiac dysfunction, it doesn't mean that you don't give fluid to this patient. Okay, it just alerts you, it just cautions you. There's a risk benefit, relative risk benefit that you have to assess. Even if a patient is in pulmonary edema, it doesn't mean that you shouldn't give more fluid to this patient. It just, is something that alerts you. So it's never an absolute no. You have to evaluate the risk benefit. More objective way of doing it is using transpulmonary thermodilution parameters like you have PICO, and you can use, EV1000 monitor, and you can use transpulmonary thermodilution. And this, of course, needs a femoral line, and you also need from the manufacturer, and you also need a central line, and then you can get various variables. I don't want to go into details, but it can give you various readings like your intrathoracic thermal volume. From this, you can measure the pulmonary thermal volume. When you minus the two, you can get the global end diastolic volume, which is the difference between the first and second cartoon. So this is the volume in the four chambers of the heart and gives you a good idea of the preload. And then you have a constant with which you can multiply the global end diastolic volume, and you can get the intrathoracic blood volume. So all the blood that's in the thorax and in the heart. And if you minus this from the first image, it's just showing you how it's all done. It's all very complicated. You can get what we call the extravascular lung water index. And this is a very good parameter that you can get from these monitors. So these are the kind of parameters that you can get, including the cardiac output, cardiac index. Global end diastolic volume, again, is a static parameter. The normal values are 600 to 800. So if the value is 400, it means the preload is low. Again, it's not a parameter of preload responsiveness, but you can look at the extravascular lung water. The normal cutoffs are anywhere between 7 to 10 is going on the higher side. So patient with, say, a 12 extravascular lung water index is someone whose lungs are getting flooded. And I would be very, very cautious about giving this patient fluid, even if they're a fluid responder. You have other parameters called pulmonary vascular permeability index. The normal values are in the range of 1 to 3. So for instance, if the pulmonary vascular permeability index is 4.5 or 5, these are very, very leaky kind of capillaries, and you're going to, this is showing that you're heading towards trouble. So this gives you an objective assessment of risk. A patient whose extravascular lung water index remains high for a very long time. I don't have time to show you the papers, but there's actually increased mortality in these patients whose extravascular lung water index remain high. So you can use these kind of parameters to assess the risk, and then you can decide whether to give fluid or not. I like to end by saying that use dynamic over static parameters to predict fluid responsiveness after your initial resuscitation. These are the common tests that you can use: pulse pressure variation, stroke volume variation, IVC diameter, tidal volume challenge, and expiratory occlusion test, PLR. They're the commonly used tests that are validated. Now, what's important is incorporating the dynamic assessment has been shown to reduce your days of mechanical ventilation, ICU stay, and mortality benefit is also there. Now, most important, like I showed you, assessing fluid responsiveness, you're using these tests, but doesn't mean that you have to give fluid to the patient. It's only one part of the question. So even if a patient is fluid responsive, do not give fluid to the patient if the risk of giving fluid, as I've shown you, is more than the benefit. And most importantly, no tool is perfect. So you need an integration of all these various diametric tests along with your clinical assessment to decide on whether the patient is fluid responsive or not, and whether there's a risk of giving fluid to this patient. So I'll end with what this very wise man said, that there's a lot of tests that we know, a lot of numbers that we know, but not everything that counts can be counted. And not everything that can be counted really counts. So there are a lot of things we really don't know. There are a lot of things that we know that may probably be useless and not very important. So we still have a long way to go. But until then, we can use these parameters to decide whether how much more fluid we should give and whether there's a risk of giving fluid. Thank you very much for your attention.
Thank you, ma'am. It was really very good discussion about fluid responsiveness. And it was also telling us exactly how much is too much fluid in the patient who is getting treated in the critical care. So our next session will be done by Dr. Krishnan Sriram, who is a prominent speaker from Chicago and who is also founder of HICS2023. So over to you, sir, Dr. Krishnan Sriram. If any other questions will be there, we'll let you know, ma'am.
Friends, I'm very happy to share my thoughts about calorie requirements in critical illness.
Hi, this is Sriram here.
To discuss how much is enough
We're supposed to show the
to
video.
avoid overfeeding and underfeeding. First, let's discuss about what are the sources of calories. It could come from carbohydrates, which is traditional 4 calories, 4 kilocalories per gram, fat 9, and IV fat emulsions, 10% fat emulsions usually have 1 kilocalorie per cc. Proteins, 4 kilocalories per cc. But don't forget that medications such as propofol also contain fat calories. The fiber, even though it's thought to be inert, can actually provide up to 2.5 kilocalories per gram. Now, in terms of parenteral nutrition, please also remember that the calculation is 3.4 kilocalories per gram because it's a hydrated form of glucose that is added to parenteral nutrition solutions, not the traditional 4 calories per gram for solid glucose. And in parenteral nutrition solutions, glucose is actually in high concentrations of 50 to 70%. Now, in many of the calculations for energy requirements, the dilemma is that they are all based upon weight. But weight is a problem. Pre-admission weight is not often known, or it may not be accurate. Weighing patients in the ICU is difficult and inaccurate. Actual, ideal, estimated, or adjusted body weight, which one do we use? The so-called ebb and flow phases of critically ill patients is no longer accepted, so we cannot use these predictive equations too. Fluid status, edema, and the use of diuretics and dialysis confuse the weight-based estimations. Nutrition therapy is also dose-related, so we need something to go by. So the choices remain. Do we use predictive formulas? Do we use just the rule of thumb? Or do we use indirect calorimetry? I can summarize my talk, which I can present in a few minutes from this slide, which I'll show you at the end of the presentation. The energy requirements in critically ill patients can be well accomplished by just a rule of thumb. 12 to 25 kilocalories per kilogram of ideal body weight in the first 7 to 10 days. Do not use predictive formulas. Indirect calorimetry is not practical or even cost effective. When higher protein requirements are met, the survival is the same whether you use hypocaloric or eucaloric, like 30 kilocalories per kilogram per day or 23. After decades of research, the correct answer as to how many calories you need to give a critically ill patient is unknown. So we have to do the best that we can, and that's the purpose of my talk. But remember, permissive underfeeding for extended period is not justified. It is only a starting point because protein goals are more important than the calorie goals. The low trophic enteral nutrition actually attenuates the stress response, maintains gut defense, facilitates pre-morbid microbiome. And the complications such as hyperglycemia, GI intolerance, refeeding syndrome can be avoided. As the patient improves, we keep on increasing the calories and the protein intake so that we avoid death. It's very clear, shown from this slide, that if you look at the prescribed energy of 1800 calories, and the energy received from enteral feeding starts on day 3 or 4 and it's gradually increased, you will find that as calorie debt increases, there's a longer ICU period of stay, increased days on mechanical ventilation, increased complications, and the mortality also goes up. So we have to avoid calorie debt as much as we can. But if we go on the other side and we look at problems with overfeeding, it is even more dangerous. Hyperglycemia, enteral feeding intolerance, too much of feeding, bloating, gastric emptying is not very good, about which we won't spend too much in this talk. Refeeding syndrome, hepatic steatosis, and possible effects on respiratory quotient. These are some of the points of problems of overfeeding, which I'm going to discuss with you. Now, in excess calories, when we give either enterally or parenterally, hyperglycemia is inevitably a problem. And increase in calorie intake aggravates the stress-induced hyperglycemia in both non-diabetics and diabetics. The glycation of collagen affects wound healing. Glycation of globulins and albumin have deleterious effects on the body. Interference with functions of platelets, lymphocytes, and neutrophils, QT prolongation, osmotic demyelination syndrome, and increased wound and systemic infections, especially fungal infections. In parenteral nutrition especially, it is very dangerous to give too much of calories because the complications of any kind, like septicemia, acute renal failure, cardiac, and death, increases when parenteral nutrition is given and glucose levels are not monitored. In addition to phagocytic dysfunction, impaired leukocyte chemotaxis, and an increased inflammatory cytokines. Refeeding syndrome was described many years ago. A little nutrition is good, but too much is bad. And it was described many decades ago as a syndrome in a chronically malnourished individual on nutrition therapy, resulting in fluid and electrolyte imbalances, metabolic derangements, GI and cardiorespiratory dysfunction with significant morbidity and mortality, but it is preventable. A few things have changed of late. A patient does not have to be chronically malnourished, even though the risk is higher. Even in acute malnutrition, this can happen. And in 2020, the American Society for Parenteral Nutrition redefined refeeding syndrome. Whenever you have a decrease of greater than 10% of serum levels of at least one of the following electrolytes, potassium, magnesium, and or phosphorus, and or any organ dysfunction because of the above, manifestations of thiamine deficiency, that patient qualifies as being suffering from refeeding syndrome. When you give too many calories, again, we have myosteatosis with parenteral nutrition calories. What happens is we want to give parenteral nutrition to prevent sarcopenia, to replete the muscle. But what actually happens is when parenteral nutrition is given with or without exercise, what happens is more fat is accumulated in the muscle, and it is actually not protein. So I hope I've convinced you that giving too many calories is dangerous. In addition to that, you can have hepatic steatosis and also cholestasis. It occurs both with parenteral and enteral nutrition, especially when it is continuous. When you give continuous feeding, glucose levels are high, therefore insulin levels are high, therefore fat gets deposited in the liver. And this, of course, can be due to other mechanisms in parenteral nutrition, such as bacterial overgrowth or the composition of fat emulsions. But what can happen is when continuous enteral or parenteral nutrition is given, you can have irreversible damage to hepatocytes. Hypercarbia can occur because of too many calories. As you know, the respiratory quotient for glucose is 1, O2 divided by CO2. But when too much of glucose is given, after conversion to glycogen in muscle and liver, it is stored as fat. Lipogenesis has an RQ of over 2. Too much carbon dioxide is produced. But this occurs only when very high carbohydrate calories are administered, which is not the current practice. You need to give almost 3,000 kilocalories as glucose in 24 hours in a 70 kilogram person. And that is the reason why pulmonary formulas are no longer recommended. Now, there is a discrepancy between body mass index, actual or ideal body weight, as shown in these two diagrams. The spots that you see there, compared to the 65% of resting energy expenditure as determined by indirect calorimetry, and compared to the ideal body weight or actual body weight, as seen on the left graph, is completely scattered. That means there is no connection between body mass index on the one hand and body weight on the other, and energy expenditure. So using weight becomes an absolute problem. Then you look at predictive equations. Not only do predictive equations depend upon weight, but the equations are counterintuitive because you have wide fluctuations day to day. And the weight is maybe inaccurate because some of the medications that we give the patient also may affect the predictive equations. Beta blockers, neuromuscular blocking agents, sedation, and analgesia. In addition to weight, predictive equations are inaccurate because of age-related issues and genetic differences between different ethnic groups. Here is a study which compared 23 predictive equations, and they compared 11 fixed weight-based factors such as 25 calories per kilogram per day, and compared that with indirect calorimetry, plus or minus 10%. The overall accuracy was only 40%. Therefore, now folks have said, let's use indirect calorimetry. There is no doubt this is the only true means to obtain calorie requirements. It's considered the gold standard. And you can have a certain goal for nutrition therapy. The question is it practical and cost effective? Is it applicable globally? It is no doubt that use of indirect calorimetry will increase in future. But more important is the prior optimization of nutrition therapy, the entire gamut of pre-admission assessment, good nutrition practices, not waiting for too long post-operatively. When all that is done, indirect calorimetry may be useful. Now, in a survey of about 420 nutrition support teams in the USA, where indirect calorimetry is very rarely used, 40% did not use, and those that did used only less than 10 a month. Globally, the use of indirect calorimetry is only about 0.8%. In Europe, where it is very popular, it was found that it was indicated in 50% of ICU patients, but used only in 20 patients. Several publications can be quoted, but all these publications for several decades often end with when and where available. Further studies are needed. But why? Why is something that has been in the market and available for so many years not being used with greater frequency? There has to be a reason. And it is because it is not readily available. Trained respiratory therapists are generally needed. All patients are not suitable. There are limitations on oxygen requirement. FiO2 greater than 60, it won't be useful. Guidelines often recommend, but they're not very practical. Results may not be replicated even on the same day. But what is most important is interventions adjusting the calories do not generally affect outcomes if the protein intake is taken care of. And there are other references quoted here to show that routine use of indirect calorimetry must be avoided. What Dr. McClave has very clearly stated is achieving energy goals do not necessarily need to be reached. It is not needed. Benefits are seen even with 50 or 80% of goal. And therefore, this obviates the need for gold standards. Now, certainly, IC is useful to sensitize physicians to teach them that nutrition is also dose-related. If patients fail to improve major burns, large surgical wounds, sarcopenia, anasaka, extremes of weight, low BMI and high BMI, possibly in COVID. But it is not something that should be universally insisted upon. Now, a few words about protein, even though we generally use total calories and not actually the non-protein calories. The protein requirements in 2022, which actually tells the same as the earlier guidelines, say that 1.2 to 2 grams of protein per kilogram of actual body weight is needed. And there is absolutely no evidence it is associated with subsequent renal insufficiency, certain changes in obese patients. The Europeans say 1.5, the US guidelines say 2, so the truth must be somewhere in between. But what happens in practical cases is that in day 1 or 2, we usually give lower protein because that is all the patient can tolerate. And then gradually it is increased. And this coincides with a gradual increase in calories. This is a pragmatic and practical way in which we do this. McClave, again, in this lovely paper in the current opinions in clinical nutrition and metabolism, has clearly said that determining nutrition risk and documenting the percent of goal calories is more important. That is what we have to keep in mind. But in several cases in critical care, as in the management of sepsis, glucose control, and preserve for hypotension, the intervention is more important than whether you use a tool or a certain formula. So that is actually what's important. Whether you use indirect calorimetry or don't, if you are able to practice nutrition the right way, then you will achieve the same benefits of early feeding. So I go back to my original slide here. A rule of thumb of 12 to 25 kilocalories is fine for the first 7 to 10 days. Don't use parenteral nutrition to supplement enteral nutrition if you really don't need it. Don't use predictive formulas. Indirect calorimetry has limited use. When high protein levels are met, survival is similar whether you use hypocaloric or eucaloric feeding. Thank you very much.
Unmute, sir, please. Sir, unmute, please.
Hello. Yeah. Thank you, sir. It was a really very informative lecture about how much calorie is too much. And moving forward to the next session, we have Dr. Anushka with a consultant intensivist at Colombo North Teaching Hospital. And she will be telling us about the oxygen therapy and particularly how much oxygen is too much. So over to you, Dr. Anushka.
Good morning, everyone. And thank you very much for that kind introduction. And also, I would like to start up with thanking the Hyderabad Intensive Care Symposium on inviting me to talk on this forum. So without further ado, I will share my screen. Yes, and the topic for me today is how much oxygen is too much oxygen. So by the end of this talk, I would expect to have explained the main functions very briefly of oxygen in the human body, to describe the effects of hyperoxia in the body, and to explore the evidence for conservative versus conventional oxygen therapy. So oxygen is a main gas that is present in the atmosphere, 21%, and produced mainly by photosynthesis by plants. And most of the beings are living on Earth depend on oxygen for their ATP production and survival. So looking at a human being, this would be the oxygen cascade starting from the atmosphere where we breathe 21% oxygen at 760 millimeters mercury. The pressure of the partial pressure of the oxygen slowly comes down, initially because of humidification, and then because of carbon dioxide from the lungs, and then because of diffusion deficits, as well as PQ mismatch and the physiological shunt. The pulmonary arterial oxygen tension will drop to very low levels at the tissue level, and then it actually increases during the vein, so not all of the arterial oxygen is being consumed at the tissue level. If you talk about the oxygen flux very briefly, oxygen flux is the amount of oxygen that is carried by the blood. So it is equal to the cardiac output multiplied by the oxygen that is delivered by hemoglobin, which is associated with its saturation, plus the oxygen that is dissolved in that blood. So for a healthy man, 60 kilos in a resting state, the cardiac output would be roughly about 5 liters per minute. So according to this oxygen flux formula, he will be carrying about 1,000 milliliters per minute of oxygen in the arterial blood. In the resting state, the oxygen extraction from the tissues would be about 250 mils per minute. So 750 mils per minute of oxygen will return to the venous flow. So if we look at the cellular level, the partial pressure of oxygen at the arterial end would be about 95 millimeters mercury, and at the tissue level it will be 23. So there's continuous diffusion of oxygen. Whereas on the venous side, it is still higher than the tissue. So even from the venous side, in case there is a deficit of oxygen, oxygen can diffuse into the cells. So what happens to this oxygen at cellular level? It is through this electron transport chain that ATP is actually formed. ATP would be the energy store for all the processes that happens in the human body. So for this electrons capture, we need oxygen at the end of this cycle. So without oxygen, this whole process will come to an halt, and survival will not be possible thereafter. So we only need 21% oxygen at normal atmospheric pressure. So can we overload patients by giving more than 21%? So high concentrations of oxygen for a short duration, as well as lower concentrations of oxygen but for a longer duration, can be explained as overloading with oxygen. Patients who are at risk would be ones who are exposed to hyperbaric oxygen or exposed to prolonged high levels of oxygen, premature infants, and underwater divers. But here in this talk, we'll be mainly targeting on patients exposed to prolonged high levels of oxygen. So what happens when there's too much oxygen? Oxygen tends to bind with electrons, and it goes into this superoxide state where there is a free electron at the outer circle. So this is very reactive. It binds with nitric oxide, forming peroxynitride. And some of the superoxide is then broken down by superoxide dismutase to hydrogen peroxide. But then this hydrogen peroxide also binds with the hydroxyl groups, making this hydroxyl radical, which is again quite reactive. So all these active ions will go and cause oxidative damage to lipid proteins and nucleic acids, which is our cells. And when the cells are damaged, the organs damage, and when the organs damage, the patient will suffer from that and he'll become critically ill. So the symptoms of oxygen toxicity, so mainly it involves the pulmonary as well as the central nervous system. So it initially shows up like a tracheobronchitis going into pulmonary edema, and then later on, if not removed, death. CNS symptoms, again, they can lead to muscle twitching, tinnitus, nausea, and convulsions at the end. There can be also ocular as well as ear manifestations. So birth defect is when oxygen is exposed to the patient at higher atmospheric pressures at hyperbaric oxygen therapy, and this causes CNS effects. And the Smith effects is when oxygen is given at higher doses rather than higher pressures after prolonged exposure. So the treatment of oxygen toxicity, if symptomatic, is to induce antioxidant enzymes such as the superoxide dismutase, which breaks down the oxygen free radicals, or to give exogenous antioxidants such as vitamin E and C. The prognosis is usually good for both central nervous system and pulmonary toxicity in adults. Even in infants, they do get near normal lung function at some point. But seeing this is all what we have read about, its own literature and its biochemistry. So what does this really actually happen? So we have to go through the evidence to see this. So first I would like to talk about this HICS2 randomized control study, which was done in 2016 involving 420 patients, where they used high oxygen, that is an FiO2 of 100%, again against the conservative group, where they titrated the oxygen to maintain saturation between 92 to 96. And the outcome they looked at was mortality, which was actually increased in the liberal group. Also was the ICU related weaknesses, as well as atelectasis. And then there is this second study in 2016 that was published in JAMA called the Oxygen ICU randomized clinical control trial, Yeah, they used the conservative group used a PaO2 of 70 to 100, which is kind of a little bit high for a conservative group, against the liberal group where they used up to 150 millimeters mercury of oxygen. And they actually showed that the conservative oxygen therapy group had better survival compared to the conventional or higher oxygen group. And then in 2019, this study came up with liberal versus conservative oxygen therapy for acute respiratory distress syndrome. This was first time it was used in ARDS. And here they showed that in the first 28 days, conservative oxygen therapy did not reduce mortality, or the survival was same for both groups. And also they did a follow-up, and by 90 days, they showed actually that in the conservative group, the survival was less compared to liberal group, and this was associated mainly with mesenteric ischemia. So this study actually imposes the questions about the safety of using conservative oxygen. This is another pilot multicentric randomized study done by Panwar et al. On conservative versus liberal oxygen targets for mechanically ventilated patients. So this was done in patients who were ventilated. And they actually showed that in the conservative group compared to the conventional group, the oxygen targets they were targeting, the saturation in the blood gas as well as on the pulse oximeter, the PA, partial pressure of oxygen, as the FiO2 was statistically significantly lower in the conservative group compared to the conventional group. But the outcome, on the other hand, that is new organ dysfunction, the ICU and 90-day mortality, was same in both groups. So ultimately what they said was, it supports the feasibility of conservative oxygenation strategy in patients receiving mandatory ventilation. So it is actually, they said it is safe to use conservative oxygen therapy. This study, which was published in the New England Journal of Medicine in 2020, conservative oxygen therapy during mechanical ventilation in ICU, and to see what happens with mechanical ventilation free days, whether it is increased in the conservative group, but actually it didn't. The number of days on the ventilator was equal on the two groups. And when they looked into long-term survival, it was actually the same for both the oxygen therapies. And they also look at the secondary outcomes, employment status and cognitive function. They were similar in the two groups, but quality of living, the component mobility and personal care components, was actually better in the conservative group compared to the liberal group. Also, they did a subgroup analysis where they compared ischemic, hypoxic, and cephalotherapy patients. And they actually said that they found out that on the conservative group, their survival as well as their ventilator-free days, as well as their extended Glasgow coma outcome scores were better in the conservative group. So that's food for thought. So doing some subgroup analysis or looking into these populations where there is neurological effects, whether there is a place for conservative oxygen therapy, is a good place to investigate in the future. And in this study, which was published in 2021, low or high oxygen targets of acute hypoxic respiratory failure, they again showed that the mortality at 90 days was similar between the lower group and the higher oxygen group. And also they showed that the incidence of myocardial infarction, stroke, and mesenteric ischemia was similar, because there was this issue of increasing ischemic episodes during conservative oxygen therapy, but they showed it was similar. And finally, coming on to this meta-analysis that was published in 2021, here they have compared 7 randomized controlled trials. And the overall effect, as you can see, mortality is similar in conservative versus the conventional group. But when you take the patients who are hypoxemic, again, there is no effect. But if you compare the group where you have mild to moderate hypoxemia, the conservative group actually did better. So their conclusion was that conservative oxygen therapy did not improve prognosis of overall ICU patients, But in the subgroup of ICU patients who had mild to moderate hypoxemia, they had better prognosis in the conservative group. So in a nutshell, what they have done is, what I can tell you is that conservative is when you target a saturation of 88 to 92% and a PO2 of 50 to 70, whereas liberal would be using anything 90 to millimeters mercury of 90 to 100 or saturation of more than 96. And you can use conservative oxygen therapy without any mortality, increasing mortality. It has not reduced mortality, but it has not also increased mortality, so it can be used safely. And adverse effects such as ischemia are rare if you do proper monitoring of the patients. And so with that, I have actually come to the end of my talk. And in summary, I would like to say that oxygen is vital for the survival of life. And contrarily, it is harmful in excess, causing damage to intracellular, cellular, and organ integrity. At least theoretically, this is what we believe. The optimum oxygen balance between supply and demand in critically ill patients is still under exploration. Until such discovery is made, prescribing oxygen in a conservative approach is not unreasonable. So here are my references. And with that, I have come to the end of my presentation. Thank you very much.
Thank you, Dr. Anushka. It was an evidence-based informative talk about the oxygen therapy. And coming to the question answer session, so we have a question from the delegate for Dr. Shaila. So, madam, which takes the preference, like fluid responsiveness in a shock situation versus fluid tolerance?
Yeah. So, firstly, I have a little concern about this term fluid tolerance, right? So, and this is something that we are discussing globally, because when you say fluid tolerance, it could be misunderstood as, can the patient tolerate more fluid? Okay. So like I told you today, we're not interested in knowing whether I can, whether the patient can take in more preload, can increase the preload. What I'm interested in knowing is whether the patient is fluid responsive or not. That means by giving this preload, is the cardiac output going to increase? So when you say tolerance, it could be understood as, can this patient tolerate more fluid? But what the question that you're actually asking is the risk of fluid administration. So, we need to use a better term, tolerance. Some people do understand it, but it could be misunderstood. So I would say it's a balance. Like I said, patient first in acute circulatory failure. If the answer is yes, the next question is the patient fluid responsive? And if the patient is not fluid responsive, then of course you don't give fluid. If the patient is fluid responsive, then you need to ask yourself the third question, is there a risk of giving fluid? So using whatever objective criteria I described. So if your answer to all three is yes, then you give fluid. So describing all the tests for fluid responsiveness, that's only one part of the question. Just being fluid responsiveness doesn't mean that you give fluid to the patient. You need to ask whether see the risk and the benefit. So you need to see both if you want fluid tolerance, but I would use a better term than fluid tolerance. So essentially what you're assessing is the risk of fluid administration.
Okay.
So like if you have more risk, just to add on to that, if the risk is more than the benefit, even if the patient is fluid responsive, I would not give fluid. I would go up on the vasopressors.
Madam, if a hospital is not having a facility where they can do the flow track monitoring, what do you suggest? PPV versus SPV or PPV versus IBC disinfluent index? Like if pulse pressure variation should be considered as superior than IBC assessment?
So if you just forget the funding and the availability of the equipment, if you just look at the reliability of the test, the pulse pressure variation is more reliable than the IBC variability. If you look at the ease of performing it, it's much easier to do transthoracic echocardiography, look at the IBC, right? But having said that, if you have a patient in acute circulatory failure, you would at least have an arterial line in this patient, right? So if you can very easily, a lot of people don't know that you can measure PPV even without a cardiac output monitor. So all you need is an arterial line, which you would have in a patient with an acute circulatory failure, and you can get PPV. Now, PPV is not reliable in specific settings, so you can use simple tests like the tidal volume challenge, etc., to overcome these limitations. So this can be easily done, and these are reliable. Of course, you can use IVC variability, but you have to know that the area under the curve, recent studies have not demonstrated very good reliability of these tests. So even without continuous cardiac output monitoring, you could use these tests. If you use stroke volume variation, of course, you need a continuous cardiac output monitor. You can even use PLR, which is easy to perform. You can use this with the echocardiography if you have it, okay? So you can use the conjunction, this in conjunction. Or a recent study has demonstrated that changes in the pulse pressure variation, so the drop in pulse pressure variation with the PLR. So there are various tests, simple tests that you could use at the bedside. It's not necessary that you have to have continuous cardiac output monitoring. But the point I'm trying to make is static parameters like CVP should not be used to assess fluid responsiveness.
Okay, thank you. Sir, Dr. Sriram, we also have a question from delegate for you. As you know that the calorie requirements change on the daily basis in the ICU, particularly sometimes we end up into overfeeding or sometimes underfeeding. So does it matter if you overfeed for a couple of days and then underfeed to the other days? Is it the community calorie intake that matters, or on a day-to-day basis requirement matters?
Though you might find there is a theoretical reason to change the calorie intake from day to day, it is not practical at all, and it is not done. So folks who use indirect calorimetry will say, I would measure this. And some of you in the audience, in the participants, may also be strong believers in that. But the fact is, you cannot really know exactly how many calories you're going to give. It is like changing the dose of antibiotics from day to day. Likewise, you wouldn't be changing this on a day-to-day basis. Glucose control, fluid balance, everything will become chaotic if you keep changing it from day to day. So the general wisdom that I think folks like Dr. Martindale and McCabe and others have published periodically is that you stick to one plan. You start at a low calorie intake to the level of tolerance and then gradually keep increasing it. You can, I've had patients who have received too many calories within 1 or 2 days and have delivered hypophosphatemia and have actually needed to be intubated. Refeeding syndrome can occur within even a very short period of time. So the short answer to your question is that you shouldn't be changing it abruptly like that from day to day.
Okay. Question to Dr. Anushka. Madam, how do you assess oxygen toxicity in ICU on a ventilator patient?
Assessment, I would say it's not going to be easy to assess whether it's oxygen toxicity or it's the primary illness that is causing the pulmonary effects and the CNS effects. So I would rather say, rather than looking for the oxygen toxicity, you always aim at low oxygen levels, because it has been shown that it is not dangerous to use low oxygen. So target a low saturation, low end of the spectrum, that is your saturation. I would prefer to have it within the range of 90 to 92, and avoid giving too much oxygen and see, because the effects might take some time. You will not recognize it during the acute illness itself. So it's always better to have low threshold and go for low oxygen saturations and PaO2s instead of actually looking for the toxicity.
Okay. Right. Thank you, ma'am. So it was a wonderful session about the fluid, oxygen therapy, and calories. How much is too much? And thank you, Dr. Sheila. Thank you, Dr. Anushka. Thank you, Dr. Sriram, for your wonderful talk on this topic.
Thank you very much.
Thank you.
Thank you.
Thank you. Good night.
And I think we will have a short break, tea break. that available? Yeah. After a wonderful session about fluid, air, and oxygen, we'll move forward to our next session, and which is a very interesting topic. We all know that many of us might be very good at clinical skill, but we might not be good at handling the conflicts in ICU. And we have a very good speaker here, Dr. Pradeep Rangappa sir, who is a consultant intensivist at Manipal Hospital, and he will give us few tips how to resolve these conflicts in the ICU. Over to you, sir.
Hello, friends. So, at the outset, I wish to thank my good friend Dr. Samvedam in having me for this HICS meeting. So, at the outset, wish to say that I'm recording this talk from Indonesia. So as you see the backdrop, I'm sitting very close to Borobudur, which is one of the largest Buddhist temple in the world at this point of time. And as you see on the backdrop, there are 504 Buddha stupas. So I'm sitting very close to this monument in a very nice resort in Yogyakarta. So just few meters away, I have this beautiful monument, which is a marvel in its nature. So I'm recording this talk for my good friend. So the talk is very interesting. It's conflict management in ICU. So I wish to thank my another colleague, Dr. Pradeep, who is my team member who helped me develop this content. So on a holiday, I am delivering this talk, recording in this beautiful place. So the topics that I would be covering is a bit on the background, and we look into what is the origins of ICU conflict, and we look at what are the reasons for a conflict from family's perspective, and what are the different stages of conflict, and what do we understand by moral aporia and moral positions whenever there is a conflict. And the topic for today is what are the 10 steps that we need to keep in mind to resolve conflict in ICU, and the take-home message. So when you look at most of the listeners here, intensivists would know, in an ICU, it's a very high intensity sort of environment, and people are in some sort of a duress at any point of time. And there is tremendous amount of stress in an ICU environment as a general rule. And amidst this high intensity, stressful sort of an atmosphere, we are expected to make rapid decisions. So that also adds on additional stress during this whole course of ICU. And to tag along with all this, we need to factor in the patient's preferences when we are making rapid decisions for the patient. And at the same time, there are various different opinions that come from within the ICU team members and the intra-ICU opinions. And most importantly, another important sort of an interfering factor is the perspectives of all the different specialists that may be involved in the care of the patient. So this is the typical sort of a milieu in which we work. So this high intensity, stressful environment where rapid decisions are to be made, keeping the preferences of the family and the ICU team and the interdisciplinary teams. All this leads to a proper sort of a recipe which can lead to the conflict. I think this is the typical sort of a recipe that we have, or a very right pitch that we have in ICU for a conflict to arise. And when we talk about conflict, the conflict can be between various individuals within the ICU. It may be between the patient and the family members. Most importantly, between the family members and the ICU team. So when I say ICU team, for all the listeners, it is not only the doctors, it can be the nurses, it can be the paramedical staff, it can be physios, it can be dietitians, it can be nurses, so on and so forth. And the conflicts can be between the different teams that are involved in the care of the patients, as I said. So it is a very complex sort of a milieu in which we work, where conflict can arise from any of these sort of dimensions that are involved in the care. So what are the origins of ICU conflict? So we need to bear in mind, so for any ICU patient, there are three important aspects which we need to emphasize. One is the compassionate care that we give to the patient, and the trust that the patients have in us whilst we're treating, and the hope that we are creating for the patients. I think these three form an important tenets or pillars whenever we're caring for the patient in ICU. So why does conflict arise? Conflict arises when there is sort of a divergence between what the clinical situation is and what the clinical situation should have been. So when there is a divergence or dichotomy in this understanding of what the situation is and what it was meant to be, and there is failure of consensus that is drawn in narrowing this wedge within 48 hours is what is found to lead to conflict, which means if there is no proper communication that has happened to make family understand what the situation is, and there is no sort of a divergence in their expectation, I think that is one important aspect how we can minimize the conflict. So this is a very important aspect to improve this understanding of the patients and to improve or to narrow down this divergence that exists between what is and what should be. There has to be three important components. So at the end of my talk, if you remember these three components, I think that would be the recipe for avoiding conflict, which is good quality, timely communication that needs to be happening with a shared decision making. So this is very important. So good quality communication with shared decision making, where whatever decision is being made has to be in concurrence and in consensus with the patient, with the family, and with all the team members that are involved in the care of the patients, keeping the values of the patient, preferences of the patients, and the goals that we have set for the patients. So this is, although there are a lot of things that I'm telling, but if you just remember these three pillars, it's a very important recipe or important way how we can minimize the conflict, and obviously specific care for the clinical conditions in a committed, compassionate, empathetic way are the key aspects which can minimize the conflict. So good quality communication, shared decision making, keeping the values, preferences, and goals, and compassionate, empathetic care, addressing the specific clinical needs is what can minimize the conflicts. So what are the reasons from the family perspective that conflict arises? From the family perspective, when family sees there is an unanticipated sort of change in the clinical condition or unanticipated event that has happened in the course of the illness, that can lead to origins of the conflict, or the prognosis that is being explained to the family is misunderstood or misread by the family, or this is the most important aspect I'm sure most of the listeners would allude to, there is a discordance between the intensive care team and the other teams that are involved in the care and the family members, where there are different views or opinions given by the caregivers, is what is an important aspect we see day to day with regards to origins of the conflict. And as I mentioned, this is a very important aspect where there is lack of shared decision making, keeping the values, preferences, and goals. And this is something which possibly we do not have solutions, where family have unrealistic expectations in this day and age, because there is so much of amount that patients incur during the care of the patients. So there is element of unrealistic sort of an expectations, which is something which is difficult for us to address. And the last and important, but not the least, is the ineffective communication that happens through the care of the patient. So these are some of the elements, which are the salient elements as to the reasons why there is conflict from the family's perspective. Then there's something called decision paralysis. So the decision paralysis happens when the clinical uncertainty is looming around the family members. So when family is not clear as to what is the clinical course that their dear ones would be undergoing, or when the outcome prognosis is not established, or this again will be repetitive, that this is a very important sort of a illustration that you need to keep in mind, that any disagreement that happens between the family member, the treating team, and all the other specialist doctors who are involved in the care is an important recipe for any conflict that arises. Or the information given to the family is many a times can be confusing, because like we have an ICU team of 13 people, 13 doctors, and within our ICU team, many a times we would see on almost a daily basis that patient has misinterpreted the way things have been communicated by different team members. So they can get confused and it could be conflicting. I'm sure every listener here would allude to this, that within the ICU, the way it is communicated by the senior most consultant and by any of the team members will be hugely variable, and it will be perceived as very different and confusing by the family. So there are certain key aspects when we are communicating, how we minimize the sort of a recipe or the pitch for the conflict is having some of these body language. So sitting at the level of the patient whilst communicating and being open and not folding the hands and looking tense. and leaning towards the patients while you're communicating, making a good eye contact with the family, and having a relaxed posture. All this you can remember by the acronym SOLAR. So these are some of the body languages or etiquette that one needs to have in mind when we're communicating. And these are all simple sort of a life skills that one can utilize to minimize the conflict. Then there is a spike approach where you make the patient sit whilst you're communicating in a comfortable position without a barrier or without any sort of a barrier between whom you're communicating to, and trying to understand the perceptions from the patient's perspective, and inviting them or to discuss and collaborate with regards to the diagnosis that one is working on and the type of prognosis that one is looking into, and whether the person whom you are communicating to has a good awareness and knowledge of illness and prognosis, and providing emotional support at the same point of time, and what is the strategy and the future course of plan that one has in mind. So this is Pike's approach. I'm sure many of the listeners would have understood this. So these are some of the behavioral etiquette and intensities should bear in mind to minimize the conflicts. So spikes and solar is something you can remember, easy to recall as to how we need to be communicating. So there are different stages of conflict. One is latent, where when you talk to the family, you know there is something cooking in their mind and something is not right. So that is the situation one should anticipate. There may be a possible situation where conflict is arise. Then there would be manifestation of this where there is an emergence phase, and then it escalates when it is not addressed in the latent phase or emergence phase. Then it gets escalated. Then you have a stalemate where there is a loss, there is a great dissonance of the trust between the treating teams and the patient, which is not a good thing to have. And after that, there has to be de-escalation, and then there is a dispute settlement, and then there is a post-conflict peace-building process that tends to happen. So these are the typical stages of conflict that has been described by various pundits. And there are interprofessional conflicts. This is very important, and it is shown that the interprofessional conflicts seem to arise and seems to prevail and is highest in certain life-sustaining therapy or end-of-life sort of a situation, which I'm sure we all agree, because there may be a discordance or divergence in the views of the intensivists and the other treating teams with regards to end-of-life or life-sustaining therapies. And it is shown that and in a situation where you're dealing with end-of-life or life-sustaining, the clinical condition also becomes very dynamic, and there is degradation of the decision-making process that tends to happen in this sort of a situation. And there can be distortion of the shared decision. So there is no shared decision-making because there is a dichotomy or divergence or non-concurrence between the treating teams with regards to life-sustaining therapy, where the goals are differential and it is not set, and there are discordant views within the family members, and there are disagreement within the family members or between the treating teams. All this leads to the conflicts. And as it is mentioned and referenced in the literature, the approach to end of life is complex and it is very highly variable. So there is something called Thomas Hillman model for conflict management. So where there are 5 sort of a dimensions in conflict management. One is competing, which is not the right way to end the conflict. Then there is avoidance. Avoidance is very bad in ICU to end the conflict. Then there is accommodating, also is considered very bad, because accommodating is losing out to the other person who is engaged in conflict and losing out yourself or surrendering, which is also, or sublimation or supplication, so which is also bad. So the best sort of a recipe for addressing the conflict or having solution for the conflict is compromising or collaborating. So please remember, this is a very important cartoon. You can keep it in mind. 2 C's are what is important. Collaborating. Collaborating is the best, where there is some sort of a dialogue that happens and come out with a win-win situation. And before collaboration, it has to be some sort of a compromise where you let the ground down a little bit and then reach out and try to see for a workable solution. So compromising plus collaborating is the best way as to how we can resolve the conflict. So this is a very important sort of an aspect which I'll try to simplify. What is moral aporia? Moral aporia is where when there is a conflict, you have to let the ground down and get empathetic to the person with whom you are engaged in conflict, So, but there may be this moral sense of feeling that you are losing out. So that is moral, where there is a dichotomy, whether you are losing out on ethics in losing out and conceding to the conflict. So in the moral positions, the harm that can happen is there can be physical, psychological, which is easy, but there is a perceived harm where by losing out or where by reaching out to a compromise or collaborating, so one has a sense of feeling there is a violation of ethics or belief system that one is one is bound with, or the value system one is bound with. So that is moral aporia, where you are doing something, but it is against your principles or against the beliefs and values that you hold close to your heart. So there is a sense of perplexity where one questions oneself about whether one is compromising on the ethical principles that he is guided by, and there is a situation of ambiguity or ambivalent. Ambivalent is where you are acting contrary to the beliefs and values that you that you own or that you embrace or that you value. So that is moral aporia. So where you are doing something which is against your ethics just to resolve the conflict or end the conflict, you are letting your moral ground down and compromising on certain ethical framework that you are bound by is called moral aporia. This is something which tends to happen in conflict resolution, where right is not always equal to right and wrong is not always equal to wrong, is what you may have to reconcile to in moral aporia. What are the causes of conflict? So causes, there are three causes. There is substantiative causes where unexpected or undesired outcome has happened. And there is process problem where there is a differential policy, where there is discordant care given to individuals, which leads to conflict, or there is decision-making error. So when I say differential policy or a discordant care, this can happen within the team and between the team and the family. And there is relational, where there is opposing value-based judgments that are happening, and there is communication failure. So these are some of the three broad causes. So the first one is easy: unexpected or undesired outcome leads to a conflict. So the differential policy with regards to be it the type of care that is given to one group of patients vis-a-vis another group, which is evident as a discordant care, can lead to conflict, or whether there is a gross error in the decision making, which is quite intuitive that why conflict arises. And relational is where there is value-based judgment with regard to certain decisions, and communication failure. So these are some of the key causes of conflict that has been referenced and identified. So there is something called optimism bias, where the expectation is somewhere here, but the reality, as you see, is something entirely different. And which I mentioned, one of the important causes is unrealistic expectations. And this is something very hard when some of the families initially have unrealistic expectation. To circumvent and counter that in resolving the conflict can always be challenging. That is something one needs to bear in mind. So there is some sort of a matrix and or the dimensions or domains which are the usual causes of conflict always falls in one of these dimensions or domains, which is called conflict trigger matrix. So any conflict that arises within ICU will fall in one of these domains or dimensions. So I'll show you different dimensions. One is communications, the type of information given to the patient's emotion and empathy, family dynamics, the biases, which I said optimism bias, which I showed in a cartoon, health disparities, which is very much prevailing in a country like India, cultural differences, end-of-life disputes, goals, which we discussed, medical system distrust. So this is something where there has to be an institutional sort of a gear up to try to attain trust with the family members, and chronic illnesses where there is no reconciliation to caregiver disagreements and questionable policies. So this is sort of multiple sort of a basket from which there can be a stemming up of these conflicts, and most of the conflicts or all the conflicts fall in one of these baskets or dimensions or domains. So this is called trigger matrix. So then there is something called cycle of conflict, where when there is a miscommunication, the miscommunication can be multi-layered, and when miscommunication is percolating through all these layers, then there is whatever distrust that has developed becomes deeply entrenched. And the belief system that has been entrenched, which becomes very difficult and which leads to intractable sort of a conflict. There is a strong notion that whatever is belief is with regards to conflict is considered as right, and he considers the other party, he or she considers the other party as being erroneous, and this becomes very difficult. So this becomes a vicious cycle, which is something which gets challenging to break it and try to attain solution when the miscommunication is happening at multiple levels or multiple layers. Then there is a deep entrenchment of this distrust, which becomes very hard to break it. So unresolved conflict. So this leads to a vicious conundrum of unresolved conflict, and this can lead to other ramifications like post-traumatic stress disorder, depression, or anxiety. So these are some of these deleterious effects of this vicious conundrum or cycle of conflict that tends to happen. So this is something one needs to recognize and bear in mind, that you want to eliminate or mitigate the conflict at an early stage and not allow it to percolate into multiple layers and allow it to get deeply entrenched. Then it becomes very difficult and it can start affecting the personnel who are dealing with. Then there's something called compassion fatigue. So this compassion fatigue is something very typical in ICU setting, where because it's a high intensity, highly stressful, where rapid decisions, so very often the doctors or the caregivers lose out on giving empathy to the patients and to the families. And this typically happens in very high volume ICU, where there is rapid turnover and you're dealing with multiple deaths at one point of time. You really sort of get into this apathetic feeling where you no longer feel that you need to be bothered about it, and you stop giving care with good compassion and putting yourself in that position of a patient. So we lose empathy. So this is a very dangerous situation to be in, and this needs to be recognized. And the triggers for this can be internal and external, and even this compassion fatigue can lead to intractable conflict, which leads to undesirable outcomes. So this is something one needs to always introspect and internalize and see whether someone is going into compassion fatigue. And this very much happens, even it happens to me sometimes when we have a very busy ICU with 3 deaths or 4 deaths happening. I think it's good that you get out of the system, because otherwise you're getting into that vicious cycle where you get irritable, and that can lead to cascading of the conflict. So this is something one needs to recognize oneself, whether you are dealing. So we'll come to, so the first 20 minutes is all about the types of conflict, why the conflict arises, and what are the different sort of components or dimensions of conflict from the patient's perspective, from the family perspective, or from the doctor's perspective. Now we look into what are the techniques for ICU team members, which is the topic in next 10 minutes. Why do we need this? We need this to address the disruptive behavior or workplace violence. The first step, I'll go with 10 steps that is recognized and that is objectively sort of referenced, is try to recognize and prevent the emotions that are stemming up during the conflict. And these emotions can be someone being very angry, someone who is very frustrated, or someone who is very indignant. And all this leads to conflict, and this can lead to the harm to the individuals involved in the conflict, which can be real harm or which can be a perceived harm. Perceived harm also leads to conflict. And the early recognition of these moral emotions by the doctor helps in preventing the perpetuation or cascading of this violence. And it is important to identify the source of this moral injury. And this moral injury can be internal or external moral. So early recognition of the emotions that may be stemming up, which leads to conflict, is very important as a first step. So first step is recognition of the emotional aspects which can potentially lead to conflict becomes very important. So what is the second step? Second step is prevention and de-escalation. So this is a very important slide. So this every day in ICU we deal with this second step, which is trying to delineate positions and interests. This is very, very important, which I deal with in my ICU every day. So delineating positions and interests. What is position? Position is externally articulated preferences. So I'll give you an example where someone is deteriorating and then there is a huge furor in the family that you are not treating the patient, nothing is communicated. This I'm sure every listener will allude to me, that they'll say, nothing is explained to me. Now you are telling me that patient is deteriorating, dying, and he needs dialysis, and we are very unhappy. So these are externally articulated preferences, and family members may be making these statements, which is binary. Binary means it is in opposition. So they are basically making certain statements which are not true. But the interest, very often when you dwell into the interest, the stated statements not necessarily true, because you may be explaining every day about the progress, but they're telling this. But the interests are internally held values of it. Maybe, so what the example is, the interest may be financial. Many a times, because they're not able, suddenly they get a bill of some amount and they're unable to bear this financial burden, and they are masking this with the externally articulated preference, because the interest is finance, but the positions they're taking is blaming on the system. So this is called, this is trying to delineate position and interest, because the internally held values or concerns is underlying the statements that they're making as to why I want it. So they are making a claim, but the main reason may be something else. So that is delineating positions and interests. And trying to find out interest is very important, because when they are making certain positions or claims which is untrue, you are unable to mitigate this. But once you know the interest, which may be financial in the example I gave, then it becomes easier for you to break the conflict and try to get them on a common ground where you can have a compromise. So this is when the interest is known, then it becomes some sort of a shared responsibility to mitigate the conflict, where you can get into a common ground to attain this compromise. So this is a very important slide. Please remember this, that any conflict that arises, the statement being made is an outward thing, but underlying thing or the undercurrent, there may be an internally held other concern which needs to be explored, and solutions can be gained by understanding what is that interest with which they are behaving that way. So the analogy, the typical analogy which simplifies your understanding, is a tree. So the position is the tree, the leaves and all the other things, but the interests are the roots. So digging into the roots you will be able to know what is the exact reason why the person is behaving that way, into creating a conflict. But digging into this to have a win-win situation, one needs a lot of patience and time and commitment from the clinicians, and should be able to understand the current and pre-existing events and influences to get into the interest. Otherwise, many times it may not be very easy. So that is the second step, trying to delineate between the positions and interests. The third step is very active listening. So this is a very important aspect. Many of you would have heard from many pundits. Rather than speaking during conflict time, it is very important just listen out to someone who is engaged in the conflict as to what they're saying. And it's important to repeat the words like it sounds like from what I understand. So after he says, after he or she who is engaged in conflict says something, it is good that you re-emphasize saying, from what I understand, this is what you're trying to say, rather than trying to counter what they are saying. The fourth step is very important, to express your inquisitiveness, to express your desire to know more about what the reason is that they're behaving that way, to probe individual concerns. And again, in the fourth step, try to understand what their true interests are as to why they're behaving that way. So very often this, I use it. And when you say, when you try to dig in a little more, you will get to know as to what is the exact reason why they're behaving that way. So by using the words, tell me more about, and what are you hopeful for? What are you looking at for the solution with regards to this particular situation? So something like that I ask. So what do you think we should be doing to help you out? So these are the statements that I make, which is important to understand. Then they will say, so my problem is I'm not able to bear this expenses, or my problem is I have problem with this doctor, the way it is coming. So at least you know what the solution is. So the fifth step is empathy, which is very important, putting yourself in their position and acknowledging their position, validating their position, and respecting their position is called empathy. Is all about putting yourself in the patient's shoes or the family member who is involved in the conflict, putting yourself in their shoes and trying to think from their perspective. So, and using the words, I can imagine, so this has been difficult for you, and I'm so sorry, things have been so challenging. So why you are saying this is putting yourself in their position and trying to imagine how one would be feeling is all empathy about. The sixth step is trying to acknowledge different perspectives as to from the thought process, so which is plurality of moral emotions, which helps you in trying to get into a decision to resolve the conflict. So acknowledging different perspectives of a different family members who are involved in the conflict helps you to come with a solution. So like asking questions as you've seen it, I imagine from your point of view, because if there are 3-4 people engaged in conflict, so you can delineate and try to say that as I see from this person's point of view, this is what I get to gather. Something like that is very important. And it's important to say it's okay for us to disagree about the best option for you or your loved one. So it is basically acknowledging different perspectives that may be stemming up when you are engaged in the conversation in the conflict. The seventh step, which is very important, which I use it very often, is identifying the emotions. I always tell, I want to know what is running in your mind as I see you. You are the situation you are in. I find you are very sad, or I find you are in a very devastated position. So it is important to name that emotion. So identifying, naming, and respecting that emotion. So he may be feeling angry, he may be feeling frustrated, he may be feeling indignant, he may be feeling devastated, terrible. So I use the words, I see that you are feeling terrible and I empathize with you, something of that order. So I sense you are terrible. Is that correct? Many people in your situation would feel terrible. Is that how you feel? I imagine if I were you in your situation, I would feel terrible as well. Are you feeling that way? So putting yourself, using that word, so using the word for that emotion that you are feeling very sad, or you are feeling devastated, you are feeling terrible, you are feeling very angry, you are feeling frustrated, you are feeling apprehensive. Use some word for the emotions and tell, I would also feel the same feeling. It's the seventh step, using that own emotion. So eighth step is so abandoning the moral high ground. So when you are engaged in resolving the conflict, we cannot stick to our high moral ground. So we have to come down the moral high ground and don't stick to your point of view, which may be correct. So never keep repeating that what you did was the right thing. And this is a very difficult thing. It is very difficult for all of us here, including me, letting go of our ego. I think we need to be spiritually exalted to let go of our ego. And so I think this becomes very difficult, but somewhere we have to reaffirm to ourselves that we have to let go of our ego, especially when we're dealing with a conflict situation. So ninth step is righting the wrong, maybe perceived or real. So basically expressing regret. So here you take one step backwards and put yourself in a regretful position. This is also a very difficult. So this comes one step after ego. Ego is where you just don't stick to your point of view, saying that what you did was right. So that is the eighth step. But the ninth step is going one step backwards and saying, I'm sorry. So I think this is also very difficult. I'm sorry that such a thing has happened. I wish things were different. So the eighth and ninth steps are very difficult. Letting go of your ego, letting go of our moral high ground. And ninth step is taking one step backwards and expressing the regret that this should not have happened, or this situation should not have risen where we are engaged in conflict. I think that also becomes very difficult. The 10th step is very easy, where you get into the mediation process, where you have a person who is mediating between the two teams, where there is some sort of a good dialogue that is so that is sort of engaged in to get them to truce, and having some elements of education to get the moral sort of a aphoria inculcated into each parties to resolve the conflict, and finding an amicable solution. So the 10th step is the result of a successful 8th and 9th step. So 8th and 9th step, I believe, are very important. Letting down your moral high ground and retracting a bit and righting the wrong where you express your regret. So which is sort of a compromise that you get into. And then after compromise, the 10th step would be collaborating. So where you are trying to educate and transform and be transformative in your approach. So the whole thing is all about mediation. You need a lot of training. So the key aspect is recognizing, preventing, and de-escalation. So the take-home message, just taken 1 minute more. So the conflict within ICU between the patient, family, ICU team, and the other teams is a multifactorial process, and it is multidimensional. So this statement which I'm making is extremely important. So the important recipe for the conflict is good quality communication, shared decision making, keeping the patients and families' values in mind, preferences in mind, and goals in mind is very, very important. And compassionate, empathetic, committed care, clinical care, addressing the specific clinical needs. These three form an important pillar as to how we can avoid the conflict. And the best solution for conflict is a combination of a compromise and collaboration with the person you are engaged in conflict is the best solution. And remember and reaffirm the 10 steps that I mentioned. 8th and 9th are important, followed by the 10th, which is collaboration and compromising, and mediation and regular training on conflict resolution. Recognizing becomes an important step. Once you recognize, trying to take preventative steps very early on and de-escalation are the important tools for conflict resolution. So thank you one and all. I end with this beautiful quote: you can't change what's going on around you until you start changing what's going on within you. And this applies very much to conflict resolution. So thank you one and all, and goodbye from Borobudur, Indonesia. So it's a great place. So any of you have an opportunity, visit this place, because many come to Indonesia and only go to Bali. But there are great sites like Borobudur, and tomorrow I'm going to Prambanan, which is the largest Hindu temple after Angkor Wat in the Southeast Asia. So thank you. Bye from Indonesia. Thank you, Barando.
Thank you, sir. It was a really good informative session about how to deal the conflicts in the ICU. Moving forward, we have a hematology session, and we'll start with our next session with Dr. Bharat Jagyasi, who is the Director of Critical Care Department at Kokilaben Hospital in Navi Mumbai. And we'll have a session on role of ROTEM in ICU. Over to you, sir.
Hello, friends. So we all work in ICU, and we many of the time come across cases bleeding massively. It could be the post-op cases or post-trauma, or maybe a liver failure patient or a GI bleed patient. So invariably what we all do is we end up giving lots of blood products and without realizing what actually is required. So to understand all this, what is required, and how to study it, and how to find out what is required, and so that we should be giving the specific treatment, is the role of ROTEM comes in ICU. I am Dr. Bharat Jagyasi, Director of Critical Care Department, Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. And we are going to talk today about the role of ROTEM in ICU. So if you look into this, bleeding and coagulopathy in critical care environments can be a source of significant morbidity and mortality. And it's a quite complex thing, and exposure to giving allogenic blood products carry important associated morbidity. So we obviously need to avoid this. And if we look into it, there has been chronic disease, and especially if involved with the hemostasis involved organs like the liver, kidney, or maybe the bone marrow. So invariably, the patient comes either with the bleeding coagulopathy disorders, or maybe the bleeding heavily. And these are the patients where we really need to find out what exactly is deficient and how we should be correcting it. Or we might come across in acute settings in patient of trauma, blood loss, or some heparin has been given, or maybe the patient was on warfarin and now bleeding massively. So these are the situations we need to find out and intervene in those situations and correct it appropriately, rather than just blindly giving the product. So this is what we are looking to: targeted treatment of bleeding events. So during acute bleeding, a multitude of different therapeutic options are at disposition of the physicians. And what we all end up doing is just giving any of the medications, because it's very difficult to choose the right medication at the right time. The reason being is it's difficult to evaluate what is actually required and what should be the exact therapeutic option. And only right therapy will stop the bleeding. Supposedly, if you look into this, in liver failure patient, INR is always high. So INR was high, maybe was at somewhere around 3, and the patient ends up in ICU. Invariably, will try to correct that INR. But INR was actually invented to look into the therapeutic requirement of warfarin treatment. It was not at all invented to look into the bleeding risk of the patient, and it has is not the only indicator which look into the bleeding risk of the patient. So just by giving FFP, and when especially the patient required a platelets, will not correct our problem. And this is why we need to find out what exactly is required for the patient, especially in conditions like liver failure, sepsis, trauma, or the transfusion themselves. And we need to evaluate, find out the strategies and evaluate to correct coagulopathy as are evolving. And one such strategy has been the increasing use of TEG and ROTEM in ICU. So these are collectively called as viscoelastic assays. So viscoelastic assays include rotational thromboelastography and thromboelastography, and have become increasingly available at larger centers. While two assays differ slightly in the execution, the overall therapy is about the same. So they were first used in OR during the transplant and cardiac bypass, and viscoelastic assays are also used at the point of care to help guide blood product administration. And more recently, they're also being used when large amount of blood products are required for resuscitation and also optimization of extracorporeal life support circuits. So this is what it actually does. Blood sits in a conical valve and is exposed to an activator, at which point of tension or rotation element, which could be an either pin or a wire, estimates the clot strength as the time passes. Both assays plot a graph of clot strength, that is amplitude versus time. And this is what tells about the ROTEM. So when the ROTEM graph comes to us, it looks like an ECG. So as by looking at the ECG, we can actually make out what is wrong with the patient, which side of the or which artery is involved. So by looking at the ROTEM, if we do it very often, just by looking at the picture, you can make out what exactly is wrong with the patient. So ROTEM principle is simple. A sample is placed in cuvette and a cylindrical pin is immersed. Between the pin and cuvette, there is a gap of around 1 millimeter, which is bridged by blood or blood clot. Pin is rotated by spring alternating to the right and left. Now the blood is in liquid form, movement is unrestricted. As soon as the blood starts clotting, there's a restriction to the rotation of the pin, increasing with the rising of clot formness. And this is why rotation of pin is inversely proportional to the clot formness. And if you look at this, there's a light source. The rotation of the pin is detected optically and is integrated to the computer, which calculates the ROTEM curve as well as the numerical parameters. So this is what the ROTEM assays look like. So these are the various type of assays. Actually, there are 5 assays. So these are created when by adding different reagent to a sample. So XTEM is when we are looking into the extrinsic pathway. INTEM is when we are looking into the intrinsic pathway. HICS2023 is when we are looking into the role of or involvement of the fibrinogen in the clot formation. HEPTEM is when there is an heparinized sample and we need to reverse the action of heparin and we want to study the sample without heparin section. What is missing over is EPTEM, which also looks into the fibrinolysis. So there are 5 assays in all what we look into, and these assays are created by adding different reagents to the blood sample. So eventually, what we look into is this graph. So if we understand the concept of ROTEM, what we are looking into is how fast the clot is being formed, how strong the clot is being formed, and how long does it last. So fast, strong, and last. So looking into the formation of clot, what we look into is the CT, that is clotting time. So this is line in green is what looks into the clotting time. So in XTEM, clotting time is less than 100 seconds, and in INTEM, clotting time is less than 250 seconds. So supposedly clotting time is more than 100 seconds in XTEM and more than 250 seconds in INTEM. It tells us that there is a deficient either in the patient either needs the FFP or the prothrombin complex concentrate. Now this was about how fast the clot is being formed. Now what we have to look into how strong the clot is. So we look into the amplitude at 10 minutes after the clot formation, that is A10. So A10 in both the INTEM and XTEM is less than 40. If it is more than 40, it tells us clot is not formed that strong. So either, if you all remember, formation of the clot, the strength of the clot is by the platelets along with the fibrinogen. So either the fibrinogen is missing or the platelets are missing. And if we run that sample in the FIBTEM, and if the A10 is also more than 14 FIBTEM as well, or less than 14 FIBTEM as well, that means fibrinogen is missing, and that patient needs a cryoprecipitate or the fibrinogen concentrate. Now, ML is about the maximum lysis. So there's something called as maximum clot formness and the maximum lysis. So we look into the relation of it. That is the maximum lysis in relation with the maximum clot formness. So if it's more than 15%, that means there's a hyperfibrinolysis, and those are the set of the patient that will require the tranexamic acid. So these are the various parameters what we look into most commonly: clotting time, clot formation time, maximum clot firmness, and maximum lysis. So this was about how fast, how strong, and how long. If you can understand all this, I'm going to repeat it once again. The overall concept of the ROTEM and TAG becomes quite clear. So again, this is about how fast we discuss about. So it is about the green line over here. So that is called as clotting time. So this time it takes a new clot to begin forming, indicates the cumulative function of the higher clotting factors within the coagulation cascade, leading to conversion of prothrombin to thrombin. The movement start clot starts forming, that means there's a conversion of prothrombin to thrombin. So prolonged clotting time can be treated with a FFP or the prothrombin complex concentrate. That means there's either a definition of these factors. So when we look into this, as I told you, in the XTEM, value should be less than 100 second, and in the INTEM, value should be less than 250 second. If it's more than 100 in XTEM and more than 250 in INTEM, that means there is a missing FFP or the prothrombin complex concentrate, and which should be given. Now we come to the next parameter, how strong. Again, we discuss this. Clot is composed of platelet plug along with the fibrins. So either the fibrin is missing or the clot is missing. So or the platelets are missing. So what we exactly do is we run A10 in a patient, and suppose the A10 is less than 40. That means clot strength is not there. So either the platelets are missing or the fibrinogen is missing. We run the same sample in FIB10 and we read the A10 in FIB10. If the A10 in FIB10 is weak, then we end up giving fibrinogen concentrate or the cryoprecipitate. If the A10 in FIB10 is normal, that means this patient lacks platelets and these patients require platelets. So in those cases, platelets can be given in those patients. But there are certain cases where both the fibrin and platelets may be deficient. In order to detect those combinations, there is the interference test which is being used. So suppose I've used an INTEM and A10 is less, I give fibrinogen first. Again, I run the sample. And again, if the A10 is less, then I end up giving platelets in those certain cases of patient. What we in the end look into is whether the clot which is being formed is durable as it should be, and it should not be breaking down sooner than it should be. So this is a question of fibrinolysis, and it has been indicated by the maximum lysis. So this process occurs normally in healthy patients. For overactive plasmin causes hyperfibrinolysis, which is treatable form of coagulopathy. And to detect hyperfibrinolysis, you may examine lysis index at 30 minutes or the ratio of maximum lysis to the maximum clot formation. And your patients' clots are being lysed too early, and this is where you may treat them with a tranexamic acid. So this is very different in relation to the CRASH-2 trial, because CRASH-2 trial advises us to use tranexamic acid within 3 hours of the trauma. So this is not related to death. So this is not related to death. This is a different terminology altogether. This is we are actually studying in a patient. These are the hyperfibrinolytic patients where it can be used beyond the 3 hours as well. So again, for ROTEM, initially we see how fast, that is CT prolonged, indicating delayed clot formation. Yes, then you give FFP or PCC. If it is normal, then you look into the MCF. If that is too weak or low, indicating a weak clot, then check for the FIB10 MCF or ROTEM platelet if available. If FIB10 MCF is low, there's a deficiency of fibrinogen, give cryoprecipitate. If FIB10 MCF is normal, then platelet is low, please give platelets in certain patients. Suppose if these two indicators are normal, even CT was normal and the MCF was normal too, so we have to look into the clot lysis. So the clot lysis is there, if lysis index at 30 minutes is too high, indicating too much of lysis, then please give tranexamic acid to those patients, because those are the cases of hyperfibrinolysis. So when to reach for the ROTEM, we have studied this. Patients who require a massive transfusion, operating room, unclear bleeding causes in ICU, patients of GI bleed, or preoperative optimization of liver patient. Also, if we need to optimize extracorporeal life support circuits. But ROTEM has its own limitation. Clinical judgment should always be based on in combination with the ROTEM. ROTEM has never been shown to improve mortality. So mortality benefit is not there in all of the studies. ROTEM doesn't have ability to detect anemia and to tell us about the need of PRPC transfusion. Low hemoglobin level can falsely increase ROTEM amplitudes. Data for ROTEM used with direct oral anticoagulants remains lacking. Data is limited to thrombophilia factor 5 lead and antithrombin 3 deficiency and detection of protein C and protein S deficiency. So again, I revise that. ROTEM will not tell you about the platelet function disorders such as von Willebrand disease or Bernard-Solier syndrome. Factor deficiencies, it might tell you deficiency in the intrinsic and extrinsic pathway, but for example, it might not tell you to differentiate between deficiency in factor 8 and a deficiency in factor 9. Fibrinolysis can provide some information on the fibrinolysis or the breakdown of the clot, but it may not be able to detect abnormality in the process. So about the guidelines, these are the various societies, like European Society of Anesthesiology and European Society of Intensive Care Medicine in 2019 came up with a joint guidelines about the use of ROTEM in perioperative and critical care settings. And this is where they suggest that ROTEM should be used to guide transfusion therapy, and healthcare workers should receive proper training and education in the use of ROTEM. International Society of Thrombosis and Hemostasis in 2018 also suggested the same thing in the critically ill patient. The same was also suggested by the American Society of Anesthesiologists in 2010, that ROTEM should be used especially in the bleeding patient, and transfusion therapy should be guided by the ROTEM, and we should also train our healthcare workers in the ROTEM therapy. So these are the simple examples I have given, again on the same concept, that is how fast, how strong, and how long. So this was a 56-year-old male which presented to ICU with severe sepsis and disseminated DIC. ROTEM was performed and released. It's not CF, it's a prolonged CT, that is prolonged clotting time, and decreased alpha angle, which is also seen in the TEG. It was suggestive of coagulopathy. So obviously the clotting time was prolonged. We end up giving fresh frozen plasma and cryoprecipitate to this patient, and patient improved over 24 hours. Then again, one more example, in a liver transplant patient which experienced severe bleeding post-operatively, we did a ROTEM, and really it revealed high lysis 30, that is high lysis index at 30 minutes and low clot strength. So obviously this patient has a hyperfibrinolysis and was given tranexamic acid and apratonin, and ROTEM values improve over the next 24 hours. One more example of atrial fibrillation anticoagulation therapy patient was on, present to the ED, and CT revealed a subdural hematoma. After evacuation, patient was bleeding. So ROTEM was performed prior to surgery and revealed prolonged R time and decreased MA suggestive of anticoagulation defect. That means this patient was given heparin. So the protamine sulfate was given to reverse the anticoagulation, and this ROTEM values improves post-operatively. So ROTEM is a viscoelastic assay which can be used in various situations like large-scale blood transfusion, unexplained bleeding episodes, pre, peri, and post-op courses of liver and cardiothoracic surgery, but may not screen for an illness. Use with caution when trying to manage or diagnose conditions like hemophilia or anticoagulation because of the DOACs. ROTEM only helps you to strategify and to help you get through waveforms and parameters. Hematological experts may not be able to help you here. For nitty and gritty breakdown and some help with strategy. So it's very important to understand the ROTEM. It's not easy, but once you understand the concept, it will definitely help you in guiding the therapy. Thank you very much.
Thank you, sir. It was a nice insight into ROTEM use in ICU. Moving to the next talk, we will have Dr. Jacob Varghese, who works as intensivist in Rajagiri Hospital, and the topic is HLS. Over to you, sir.
Hello, my dear friends. Thank you, HICS team, Dr. Srinivas, Dr. Ghanshyam, for this opportunity. Today's topic of discussion is something which is important to intensivists in the recent years. That means HLH, hemophagocytic lymphohistiocytosis. This nomenclature has been used for many years. 1939, the first nomenclature called as the histiocytic medullary reticulocytosis. Then becomes familial hemophagocytic reticulosis, and then hemophagocytic syndrome, and then the current term which is called as the hemophagocytic lymphohistiocytosis. The first described condition is by two pediatricians, Ronald Scott and Rob Smith, in a child. They termed it an atypical lymphoma. Subsequently, the Histiocytic Society proposed the current name, which is called as the hemophagocytic lymphohistiocytosis, and they set up the first guidelines in 1991-92. In 2016, Histiocytic Society classified HLH into three subtypes: the primary or the familial HLH, Mendelian conditions; the secondary HLH, which is non-Mendelian; and HLH of unknown or uncertain origin. The primary one is predominantly familial. It is basically due to the defects in the genes controlling natural killer cells and cytotoxic T cells. Autosomal recessive one, very less common, 1.8 in 1 lakh live births, most of them present in the first year of life. And the types comes from 1 to 5. HLH in a nutshell is a life-threatening hyperinflammatory condition which causes severe cytokine storm. You have the primary, which I mentioned, due to genetic mutations, 5 subtypes are there. Secondary one is predominantly of interest to intensivists, which include the viral trigger and all the viruses mentioned there, Epstein-Barr virus is a common, and the novel coronavirus, which has been currently having a lot of inflammatory syndromes. In malignancies, leukemia and lymphoma are the commonest one, which triggers secondary HLH. Again, the autoimmune or autoinflammatory condition causing HLH also mentioned as the macrophage activation syndrome. Your juvenile idiopathic arthritis, your adult onset skin disease, SLE, systemic sclerosis from the most common inflammatory conditions. Other rare conditions include TB, malaria, enteric fever, and leishmaniasis. Secondary HLH is something which is commonly seen mainly in adults of our concern mainly. It is predominantly due to an immune activation by systemic infection, immunodeficiency, or underlying malignancy. In a study of 775 reported cases, the male to female ratio is found to be 1:7, and the mean age is diagnosed around 50 years. 41.1% of adult HLH or secondary HLH are triggered by infections, followed by 38% by malignancies. And HLH induced by autoimmune disease is termed as the term what we commonly use macrophage activation syndrome. Associated HLH, also called as MAS HLH, and it commonly follows secondary to SLE or a skin disease, followed by rheumatoid arthritis or systemic vasculitis. And if you look at the pathophysiology, in patients with viral infections and rheumatological disorders, there will be a reversible dysfunction of NK cells and cytotoxic T cells. Whereas in chemotherapy and sepsis, there will be NK cell deficiency. It can also occur after transplantation, vaccination, surgery, burns, and certain drugs. This is the pathophysiological picture representing what happens in HLH. You have the deficiency or dysfunction of NK cells or cytotoxic T cells, and this dysfunction results in a persistent antigen presentation of tumor or infected cells. And this persistent antigen presentation results in severe histiocytic proliferation or macrophage proliferation, which engulfs the cell lines, what is called as hemophagocytosis, triggers a cytokine storm, end up in hyperinflammation. This ends up in severe organ dysfunction, unstable hemodynamics, and organ failure and high mortality. This is a pathophysiological picture which deficit what is being seen in a HLH. This one being the bone marrow aspirate, this is a bone marrow biopsy, where the arrow one showed a macrophage engulfing the cell lines, which includes RBCs and platelets. And here a bone marrow picture where the macrophage engulfing again the erythrocytes and a neutrophil, resulting in hemophagocytosis. When it comes to clinical syndromes, fever is the most common symptom. Is overproduction of interleukin-1 is the reason for this. Sensitive marker, but not very specific. Organomegaly. Splenomegaly is predominantly caused by infiltration of lymphocytes and macrophages. Cytopenias again is a hallmark. Thrombocytopenia is the most common, which comes in 78%, followed by anemia and neutropenia. Hemophagocytosis, the pathophysiological hallmark, results in macrophage engulfing the cell lines, especially seen in bone marrow, spleen, liver, and lymph node, which is present in 25 to 100% of the cases. But it's not required to diagnose HLH. It can be absent in early stages. The ferritin values, again, the one marker which we all stand right now, suspecting an hyperinflammation. If it is more than 10,000, it is specific, 96% specific, and 90% sensitive. Remember, ferritin can be elevated in other multiple conditions also. This particular marker called as a soluble CD25 or interleukin-2 receptor. A cutoff value of 2,400 units is a criteria of diagnosing HLH. Other findings which are associated with HLH, which includes high triglyceride values, low fibrinogen, lymphadenopathy, and CNS dysfunction. Now, how do you diagnose HLH? Two scoring system has been well accepted. First one is the revised HLH 2004-1, which has been derived from the previous HLH 94 criteria. It's the most commonly used. And we have a probability score, which is called as the H score. This is the HLH 2004 criteria. The first one is the primary one. Primary HLH, we have a molecular diagnosis. It's predominantly familial. Genetic mutations can become possible for that. In adult or a secondary HLH, we have this other criteria, which is called as the HLH 2004. We have the 5 out of the 8 if it is positive to diagnose an HLH. Where you have fever, splenomegaly, you have your cytopenias, which includes all three, at least 2 of 3 is important. High triglyceride value more than 265, low fibrinogen less than 150. You have the hemophagocytosis, you do a bone marrow, you get hemophagocytosis. You have ferritin values more than 500. The other two values not commonly used. If you have an NK vessel, is low or absent, or a CD25, if it is more than 2,400, it suggests a diagnosis of an HLH. And this is the X score, which is available online. You have the parameters there and the scoring in the right side, and you score it depending upon the values. The cutoff value of more than 168 is considered a diagnosis of HLH. When it comes to the difference between pediatric and adult HLH, fever is common in both. Organomegaly is common in pediatrics, but in adults also. Neurological manifestation is also present, more higher in children compared to adults. In miscellaneous one, lung involvement is common in adults than children, and we just got a very bad prognosis. So what about this macrophage activation syndrome HLH or secondary HLH in ICU? This is something we intensively are interested about because 1.5% of high ferritin patients reportedly had HLH. And once HLH is there, the mortality in adult cases is around 70%. And HLH diagnoses are not established before ICU admissions. Probably intensives are the first one to trigger the diagnosis because of severe modes. The diagnosis remains challenging because of the fact that one, it is rare, second, it has got severe overlap with other inflammatory conditions. These are the populations which is at high risk. What viral triggers, inflammatory conditions I mentioned earlier. Influenza 1, influenza H1N1 and dengue infections, which has been common nowadays, is another important population which is high risk for getting into HLH. Others being your lymphomas and your miscellaneous one, which includes your immunosuppressed group of patients. When compared to HLH and sepsis, the significant overlap is there. Hyperinflammation is there in both the conditions. It's very imperative to differentiate between these two conditions because HLH will target immunosuppression, to target suppress the immune response, where there can be detrimental in sepsis. And both can coexist. One can trigger, HLH can be triggered by sepsis. And please consider the possibility of a HLH in septic patients who is not responding to conventional therapies. And the presence of very high ferritin, organomegaly, cytopenias, low fibrinogen, thrombocytopenia in the absence of a DIC or a low C-reactive protein, which with increased triglyceride levels in adults are uncommon in cases of sepsis and usually trigger the diagnostic criteria to look for HLH is there. When it comes to the consensus treatment guidelines and diagnosis, this is something that is published in CCM 2022 May, and the consensus statement reads like this. If an unexplained inflammatory condition is there in the ICU, suspect HLH. Any patient who is rapidly evolving into modes with not responding to your empiric antibiotic therapy or any supportive care, suspect HLH as a possible. And if you are suspecting HLH, then investigations, which includes a ferritin, which you all can, interleukin 2 receptor if it is present, and do the other investigations as mentioned in the diagnostic criteria. And these investigations, which I already mentioned, you do all the lab values, which includes a fibrinogen, triglycerides, your imaging, bone marrow, and additional values, which includes your liver function test, everything. In primary HLH, genetic confirmation is important. 5 out of 8 diagnose that. In case of secondary HLH phenomenon, you don't need to go the criteria completely. Probably you could combine this clinical and lab criteria, which makes things easier. It's available in the net. You can always download and use it. And a simple tool is that you do a ferritin value. If your ferritin values is more than 10,000, your macrophage activation syndrome or secondary HLH is probable, and confirm the consistency by sending other investigations. If it is between 500 and 10,000, you need to consider the possibility and check serial values so that you don't miss it when it is active. Now, a thorough investigation is important to find out the triggering factors in ICU. Most commonly viral trigger or autoimmune trigger. An elderly age group always find the trigger, which could be an underlying malignancy, and that can be missed. And when it comes to CNS disease, something which has got a CNS and pulmonary features are most common features in the adult group of patients. And patients admitted with ICU with the hyperinflammation state, which is not able to differentiate between CNS manifestations, should promptly initiate diagnostic evaluation. Lung involvement, prognostication is very, very bad. And you start the treatment immediately by normally what you do, your organ support, antibiotics, and all other supporting cases. And HLH is not a contraindication to start ECLS because most of the times your organ dysfunction is such huge that even instability is such huge that normal vascular may not be enough. So ECLS support therapy is important to be considered at that stage. And more important is that you should continue with your and your treatment modality to specific HLH therapies and the underlying trigger needs to be addressed for making sure the good patient out. When it comes to the treatment recommendations, it's important that you need to identify the underlying etiology and what has triggered the secondary HLH. In patients with treatment naive, and if if the HLH is not persistent, relapsing, or severe, consider giving IV steroids or IV immunoglobulin. In patients who is having a primary HLH, you need to consider giving etoposide treatment along with other modalities. If the patient is not responding, interleukin-1 inhibition is something which needs to be considered. And for severity assessment, you divide into 3 groups: mild, moderate, and severe, depending upon your SOFA scoring. The SOFA scoring is more than 2, it is moderate. If it is more than 3, it is severe assessment. And in mild cases, you need to consider giving steroid therapy. In moderate cases, again, steroid is indicated. What recommendation is that dexamethasone you give 10 mg per meter square in divided doses, or you give methylprednisolone. Whereas if it is not responding, consider giving interleukin-1 inhibitors. In severe or refractory or progressive HLH, you need to consider giving etoposide along with steroid therapies. Similarly, if you're dealing with a macrophage activation syndrome HLH, which a trigger factor is there, identify the trigger, and in mild cases, you need to consider giving hydrosteroids because most of them will be secondary to underlying autoimmune diseases. So methylpred 1 gram per day is indicated for 3 to 5 days without giving IVIG. If it is moderate, you need to consider going up in therapy with interleukin-1 inhibitors, cyclosporine, and then if it is severe, probably consider giving tocilizumab, which you are doing it in our current COVID pandemic. If it is severe, progressive, and refractory, you need to step up again to give chemotherapy, which includes etoposide and cyclophosphamide. In malignancy-associated therapy, you have 2-step approach. One is treat HLH by using etoposide, steroids, IVIG, and always important that once it's stabilized, do the cancer-directive therapy. Agility therapies includes your IVIG, plasma exchange, and cytokine absorption, which is for only supportive care. Agility therapy is not proven. And again, your monoclonal antibodies, including tocilizumab, is also can be considered as a salvage therapies in severe persistent HLH patients. And how do you assess the response to treatment? Improvement in ferritin, clinical values, clinical stabilization, response, continue the treatment, especially for the trigger factors and main therapy. Non-responding patients, you need to consider that because the ferritin values are not improving, not clinical improvement, you need to consider additional HLH dietary therapies. Where a disease is progressing, if it is more than 48 hours, no clinical response, evaluate and see any trigger factor is there, and consider your stepping above therapy to more specific HLH dietary therapy. So, my dear friends, to conclude, HLH is a multifunction disorder of immune dysregulation, typically in the setting of an immunological challenge that results in severe mortality and morbidity. The clinical syndromes are variable, and it is not easy to identify or diagnose because overlap happens in a lot of clinical conditions. And it is important to diagnose early and treat for better patient outcome. So always you should have an open eye, suspect HLH if patient is not responding to the normal treatment, and appropriate adequate response is not being maintained, and any CNS manifestation happens, and have a multidisciplinary approach for a good patient outcome. Thank you.
Thank you, Dr. Varghese. This was a very good insight about HLH incidence in ICU and how to diagnose it. It's one of the difficult entity to diagnose. Moving forward, we have a next topic on various transformation triggers in ICU beyond RBCs. And we have Dr. Pankaj Anand from Fortis Hospital, Jaipur. Over to you, sir.
Hello and a very warm welcome. Let me first thank Dr. Samvedam, Dr. Ghanshyam, and the entire team of Hyderabad Intensive Care Symposium. And let me congratulate them for this great work that they have been doing for so many days, for so many years. I think the topics that are included in HICS are, I think, one of the best anywhere in the world. Now, friends, over the next 10-15 minutes, I am supposed to be talking on the transfusion targets beyond RBC. Now, when we talk about or when we think about transfusion, most of us, the first thing that comes in our minds is the red blood cells, anemia, hemoglobin. That is not what I'm going to talk about. I'm going to talk about transfusions that we make in our day-to-day clinical practice beyond the packed cells, Now, the blood components are obviously the products derived from whole blood, either by a process of differential centrifugation or a process of apheresis, and they might include the plasma, the red blood cells, the platelets, the granulocytes, and others. Now, whole blood contains the cells and the platelet-rich plasma. Your red blood cells could be filtered red blood cells, your frozen red blood cells, washed red blood cells, and the platelet-rich plasma obviously can contain the platelet concentrates, besides the plasma being either as a frozen plasma or a fresh frozen plasma. There is a process of fractionation which yields plasma protein fractions, albumin, gamma globulin, IVIG, special gamma globulins, and lyophilized substances. Fresh frozen plasma also includes a cryoprecipitate, which has the factor 8. Now, besides the RBC, the most talked about, the most used blood product in our day-to-day clinical practice is obviously the platelets, thanks especially to diseases, tropical diseases like dengue. So now I'm not just going to talk about the targets of platelets, I'm also going to briefly touch upon the various salient features of platelet transfusion. We all know that platelets might be collected in two ways, by either isolation from a unit of donated blood, what are termed as the random donor platelets, or by a process of apheresis from a single donor, which is termed as the single donor platelets. So when you talk about pooled platelets, a single unit of platelets can be isolated from every unit of donated blood by a process of centrifugation within the closed collection system to separate the platelets from the red blood cells. Now, since the number of platelets per unit varies according to platelet count of the donor, usually yields around 7 to 10 raised to power 10 platelets is typical. I'm talking about the RDPs, and 4 to 6 units of these RDPs allow a transfusion of around 4 raised to 10, 4 into 10 raised to power 11 platelets per transfusion. Now, the major advantage of RDPs are, firstly, they are lower in cost and it is easy to collect and process the RDPs. But the major problem is that when you are giving RDPs, you are exposing the patient to multiple donors, thereby exposing them to either infections or immune reactions. Talking about the apheresis platelets or the single donor platelets, they are collected from a single volunteer, obviously, in a 1 to 2 hour apheresis procedure. The platelets and some white cells are removed while the RBCs and plasma are returned back to the donor. Usually, a typical apheresis platelet provides around 6 to or more units of equivalent of RDPs. Obviously, the major advantage of an SDP is that it limits the exposure to a single donor. But the disadvantage is that RSDPs are definitely costlier and the process of separation is more cumbersome. So coming to the targets or indications of platelet transfusion, there are various guidelines, but the broad consensus is that if somebody has a platelet of less than 5,000 or 10,000, then there is a role of giving prophylactic platelets, mainly to prevent bleeding. If the platelet count is, if the patient is at a risk for bleeding due to infection or chemotherapy or coagulopathy, then the threshold needs to be higher. Usually, platelets should be transfused if they are less than 20,000 in such patients. However, if you are planning an invasive procedure or the patient is bleeding actively, please give platelets once they fall below 50,000. There are certain situations where you might give platelets even if they are below 1 lakh, the most important of which is if you're considering a patient to be on ECMO or to be going on a neurosurgery, in certain cases of eye surgery and airway surgery, etc. Now, where you should not be giving platelets, even if they are low, are these various autoimmune processes like your TTPs, your hemolytic uremic syndrome, HIT, immune thrombocytopenic purpura or ITP, or your alloimmune thrombocytopenia. Just going into slight details, if your patient is actively bleeding, the consensus is clear, platelets have to be kept above 50,000. If you're planning ECMO or the patient is in DIC or there is a CNS bleeding, try to keep your platelets above 1 lakh. Preparing for an invasive procedure, 20,000 or at least 50,000 is the usual threshold. However, there is no need of transfusing platelets if your patient is otherwise healthy, unless and until they go below a level of around 10,000. Higher thresholds might be considered if your patient has high-grade fever or sepsis. Now, I'll just introduce you to two terms that we commonly hear about when we talk about platelets. One is leukoreduction and the other is irradiation. Now, leukoreduction removes most of the contaminating white blood cells from the platelets. It is basically indicated where you are suspecting an immune reaction, like you want to reduce an HLA alloimmunization, or you want to prevent a CMV transmission, or you want to reduce a transfusion associated immunomodulation. However, irradiation is basically just irradiating the platelets mainly to prevent a graft versus host disease. This is not a substitute for leukoreduction. It is capable of eliciting an anti-HLA antibody response from the host, and usually irradiation is indicated for immunosuppression or imminent immunosuppression from hemopoietic cell transplant, solid organ transplant, and where you are giving cytotoxic chemotherapy in cases of congenital immunodeficiencies, Hodgkin's lymphoma, etc. Now, ideally, while transfusing platelets, ABO and HLA compatible platelets are preferable because they cause a greater platelet count increment in the recipient. Usually, the infusion rate for an average size adult is 6 units of RDP or 1 SDP is to be transfused over approximately 20 to 30 minutes. And ideally, your platelet count should rise with a peak at 10 minutes to 1 hour with a gradual decline over 72 hours. 6 units of RDP or 1 unit of SDP should ideally increase the platelet count by at least 30,000 in the patient. However, if they are not increasing, then there are chances that almost 2/3 of refractory episodes are due to non-immune causes. 20% occur because of a combination of immune reaction and non-immune causes, and the remaining happen because there is an immune platelet-specific antibody formation. Now, the other important transfusion that we do are the plasmas. And there are various forms of plasma that might be transfused, most common of which is the fresh frozen plasma. You could have plasma frozen within 24 hours after phlebotomy, thawed plasma, liquid plasma, a plasma which has been treated with a solvent or a detergent, and there could be a plasma which is cryoprecipitate reduced. Talking first of fresh frozen plasma, it is a plasma that is frozen to -18 to -30 degrees Celsius within 8 hours of collection. The standard FFP units derived from a single unit of whole blood have a volume of around 250 ml, and it contains almost all the coagulation factors and other proteins present in the original unit of blood, slightly diluted by the citrate-containing anticoagulants. This is important. FFP has an INR of 1.6, so there is no use of transfusing FFPs if your INR is below 1.7. Ideally, FFP must be ABO compatible. 10 to 20 CE per kilogram will increase the factors by 20%. RH factor need not be considered, and since it does not contain any leukocytes, so plasma does not carry a risk of either a CMV transfusion or a graft versus host disease. Indications, obviously we use it for documented coagulation factor deficiencies and active bleeding, or who are about to undergo an invasive procedure. Deficiencies might be congenital or acquired, secondary to liver disease, and also in warfarin anticoagulation overdose or in DICs. Recombinant or factor 8 concentrations should be used to replace factor 8. Reversal of warfarin anticoagulation with plasma is indicated only if there is a major risk of bleeding. Another form of plasma that is used is the plasma frozen within 24 hours after phlebotomy. It contains all the clotting factors at the same level as FFP except the factor 8, which is in the range of 65 to 80% of the normal plasma. Thawed plasma is basically a slow heating of FFP for refrigeration at 1 to 6 degrees Celsius. reduces the expiration time to 5 days. So it is the main advantage is that it is available for immediate use. A substantial reduction in the wastage of FFP occurs. The problem with thought is it should not be used as a predominant source of factor 5 or factor 8, and it is not yet proven to be safe or efficacious in neonates. A word about the so-called solvent detergent treated plasma, largely useful in treatment of pooled plasma prior to freezing with a solvent and a non-anionic detergent, especially if you want to remove the lipid enveloped viruses, and that is the HIVs, the hepatitis B virus and hepatitis C virus. No use for non-lipid enveloped viruses like hepatitis A or parvovirus B19. A word about plasma cryoprecipitate reduced. What it means is a plasma from which the cryoprecipitate has been removed. In other words, the cryo-poor plasma, largely used as plasma replacement in some patients with TTP. It can be used for vitamin K deficiency or correction of major bleeding in the setting of warfarin anticoagulation. So when I talk about indications or targets for plasma, mainly there is congenital factor deficiency. If you're planning an invasive procedure or a major trauma, especially with factor 11 deficiency, an emergent warfarin reversal after vitamin K antagonist, macrovascular bleeding with elevated PT-PTT, and in settings of massive transfusion. Plasma products should not be used as a source of protein or nutrients or as volume expanders. We all know that. Now, what is a cryoprecipitate? If a unit of FFP is allowed to be thawed for 24 hours at 4 degrees Celsius, a milky flocculum consisting of several cold insoluble globulins can be separated from the liquid plasma. This is the cryoprecipitate, has a volume of around 10 to 15 ml, and a residual cryoprecipitate frozen plasma I have already talked about. The cryoprecipitate contains the fibrinogen, von Willebrand factor, factor 8, factor 13, fibrinonectin. The concentration of fibrinogen is almost 10 times that of FFP, so it has use in DIC along with FFP in isolated hypofibrinogenemia and platelet dysfunction that is not responding to dialysis. Cryoprecipitate is useful for the replacement of fibrinogen and the treatment of uremic bleeding in appropriate circumstances. A word about factor 7, or which is commercially available as Nova 7. It is a recombinant protein which, in combination with tissue factor and platelets, leads to platelet aggregation, reducing platelet fibrin matrix and ultimately causing hemostasis. It is useful in massive transfusion scenarios to attempt to control intractable hemorrhage, but we have to remember that it is quite an expensive drug and should ideally be used judiciously. It should be used always in combination with platelet transfusion. Where is the evidence? It was initially developed for hemophilia. There are encouraging case reports for use in trauma. It might avoid problems with ongoing transfusion disease transmission, acute lung injury, TRALI, etc. Massive transfusion and trauma are of license use. This was an interesting paper published in New England Journal of Medicine, where they actually did an RCT trial on the use of recombinant activated factor 7 for acute intracerebral hemorrhage. It was a multi-center RCT with almost 400 patients with acute intracerebral hemorrhage. Single IV injection of factor 7 was given as against a placebo. There was a significant reduction in volume of hematoma, significant reduction in 30-day mortality, and there was no statistically significant increase in the thromboembolic phenomenon. Coming to granulocyte transfusion, it is still largely under study, but the minimal criteria include an absolute neutrophil count less than 500 with evidence of bacterial or fungal infection which is not responding to antimicrobial or antifungal treatment. It is used in profound and prolonged neutropenia secondary to marrow suppression. Its efficacy might be doubted. Antithrombin concentrates are used in antithrombin deficiency thrombophilia, gamma globulins in hypogamma globinemias. and specific immunoglobulins we use in tetanus, zoster, etc. Coming back to granulocyte transfusion, the most common indication includes neutropenia from chemotherapy or transplantation, but it is still controversial. We don't have sufficient evidence. Aplastic anemia, especially when you are awaiting bone marrow transplant, where there is an evidence of bacterial or fungal infection, which is not responding to maximal antibiotic, it can be considered. Chronic granulomatous disease, again, it is pretty controversial. Neonatal sepsis may be benefited but with GTX, but we still are awaiting credible evidence. Prophylactic is definitely controversial. So to conclude my talk, friends, when we talk about transfusion, it is not just about RBCs or correcting hemoglobin. Several other blood products are routinely transfused. Different guidelines suggest slight variation in transfusion targets. Platelets ideally should be given prophylactically only when the counts go below 5,000. If you're planning a surgery, it should be done only when the platelets are more than 50,000. FFP is of no use if your INR is less than 1.7. Factor VIII has been found to be effective, but is costly, and granulocytes, etc., are still yet to be proven. Thank you once again, HICS, and I hope my talk was useful.
Thank you, Pankaj sir. It was a really informative session regarding all the blood product triggers we use in the ICU. If we have any particular questions, we'll take the questions at the end of this next session. And the next talk is approach to non-traumatic coagulopathy. And the speaker is Dr. Sharmili Sinha. She is a consultant intensivist from Apollo Hospital, Bhubaneswar. Over to you, madam.
Hello, my dear friends and colleagues. I'm Dr. Sharmili Sinha and currently working as a senior consultant in critical care in Apollo Hospitals, Bhubaneswar. And today we'll be discussing about nutrition in patients who are on extracorporeal therapies, including ECMO and CRRT. I'm thankful to Team ICCM for giving me this opportunity to discuss about such an important aspect of patients who are critically ill. So I'll share my screen. So the learning objective of today's session will be to understand the concept of nutrition in general in critically ill patients. What are the specific issues who are in concern to these patients who are on extracorporeal therapy, the literature, what are the current recommendations, and what are the future perspectives. So when you look at a patient who is in ICU, moved on to multiple organ supports, say like for example, this patient who is on ventilator, on CRRT, on ECMO, etc. Usually the major attention goes diverted to this hemodynamics, the organ injuries, the perspectives, antimicrobials, infections, etc. Hence, nutrition in general gets set back, and it is usually often gets neglected. Though some form or other nutrition we do consider starting, but it usually does not get the kind of attention that it should be receiving overall. Hence, in that context, it becomes very important to think about it for the at the onset, because all the parameters of outcome that you can think of for a patient who is in ICU are indirectly related to their nutritional status as well. And we must admit that it is also related to the intrinsic immunity of a patient who especially is critically ill and especially hooked on to multiple organ support. If we look at the pathophysiology, there are a surge of catabolic hormones for a patient who is critically ill, and all these, lead to a destruction of the proteins and compromises the immunity, be it the pro-inflammatory mediators or the anti-inflammatory mediators. All of these actually are responsible for leading to the high grade of catabolism in these patients and ultimately result in malnutrition if a patient ends up staying in ICU for more than 3 to 5 days. So all the parameters, as I said, that increases the length of stay in the hospital, ICU stay, increases incidences of nosocomial infections, mortality, and overall the healthcare cost increases enormously in these patients. So if you look at, remember or recapitulate the basic ICU care mnemonic, that is FASTag BITS, G for gut or nutrition, we usually call it, and it is essential for all those patients who are in ICU, and especially when they are on multi-organ failure or multi-organ support. Who are the patients who are at risk of malnutrition? The list is really long. And if you see those who are grossly underweight to start with or grossly overweight, they have been longer fasting, they have malabsorption syndromes or problems with the GI tract per se, they have multi-organ issues, especially for patients who are in sepsis or septic shock patients. And that is the commonest population that we see in our ICUs. They suffer from malnutrition to a larger extent. Now, if you talk about the nutrition score, if you look at literature, there are more than around 10 to 15 nutrition scores have been discussed in the last 2 decades. But the most validated and accepted one and easier to probably understand and practice is the Nutrix score, where these are the variables like age, Apache 2 score, SOFA score, number of comorbidities, days from hospital to ICU admissions, and IL-6 levels. If you have a provision to measure this particular variable, that also it can be utilized to calculate the Nutrix score. Now, especially in the context of these patients who are on extracorporeal therapy, usually they are on multiple vasopressors. And in that context, a vasopressor inotrope score is also being talked about in these patients, either depending on if the patient is on dopamine, dobutamine, or either epinephrine, levosimendan, or norepinephrine. This can be calculated. So these are the scores that we talked about, like not many scores, but the best one and which were easy to follow and validated is the Nutrix score. This is for the postgraduate trainees. If you want to note down about this nutrition assessment scores, these are the various ones. And there's a beautiful article in IJCCM, that is Indian Journal of Critical Care Medicine, which has a review article on this nutrition in critical ill patients in general. Now, what are the issues in patients who are on extracorporeal therapy? Now, these patients have a very high grade of inflammation. Given the severity of the illness, they are in a high catabolic state thereby. And usually there is an extent of hemodynamic instability in these patients, which requires administration of high dose of vasopressors. And also, along with low blood pressure, they also face a lot of myocardial depression and or dysfunction. And there is cardiac arrhythmias also. When a patient is on high dose vasopressors, something called still phenomenon happens. Thereby, blood is diverted from the mesenteric circulation of the GI tract into the peripheral circulations, and because the body tends to perfuse the end organs or the more important organs like the brain and the kidneys more. And this is essentially the reason which is responsible for causing bowel ischemia or mesenteric necrosis. But in these patients, if you start feeding them early or start enteral nutritions, the first and foremost important benefit is about that it ensures the integrity of the GI tract, prevents disintegrity of the intestinal mucosa, and thus prevents or minimizes the risk of gut-derived sepsis. It stimulates structural and functional changes in the gut through release of intestinal hormones in the gut. And such patients, usually the enteral nutrition is well tolerated and safe. And patients who are on extracorporeal therapy, either in CRRT or ECMO, either VECMO or VV-ECMO, due to the high continuous blood flow through the extracorporeal circuit, there is a lot of loss of proteins in these circuits. And in these patients, in addition to their normal requirement, body requirement of protein, they also need to be given extra protein to compensate for these losses. So now, what are the exact nutrition components? These figures are important to remember. For carbohydrate, it is usually 25 to 30 kilocalories per kg per day. For proteins, it is around 1.5 to 2 grams per kg per day. And of these, 50 to 60% of these calories should actually come from carbohydrates. Now, I must remind that protein should not be calculated towards the total calorie of a patient. And 30 to 40% of the total calorie requirement should come from the fats or lipids. To recapitulate the basic concepts, that 1 gram of carbohydrate and 1 gram of protein usually provide 4 kilocalories, and 1 gram of fat actually provides 9 kilocalories. So proteins should not be counted towards the requirement of total calories in a patient. And having said this, the requirement of proteins in a patient, in a general patient, for patients who are on extracorporeal therapy, if the nutrition is not improving after repeated assessments, the protein requirement can also be increased up to around 2.5 gram per kg per day. So one thing I would emphasize that these are the, just rough numbers of the guides to your daily calculation or dietary plan. But if a patient, the condition changes, especially if a patient is developing diarrhea, etc., then the protein content and the total calorie needs to be revised and has to be adjusted accordingly till the diarrhea settles. Now, how much protein needs to be given for patients on acute kidney injury who is on CRRT? Now, there is a common concept or thought among many clinicians that for a patient who has got an acute kidney injury, usually and especially if the patient is on dialysis, the total protein intake should be low. But this is a myth which has been busted now, and it is commonly there's a consensus that there occurs loss of proteins during CRRT. So protein up to around 2 grams per kg per day can be considered for a patient who is on CRRT or for the other form of RRT. And if a patient is not on CRRT, then also normal allowance of protein like 1 to 1.5 grams per day can be given for these patients. When to start nutrition? It is, as we have been discussing since beginning, it is as early as possible, and early enteral nutrition within 24 to 48 hours of admission is the best way to go about it to ensure gut integrity and motility. And it does, because the integrity is maintained, it prevents translocation of gut bacteria and prevents incidences of gut-derived sepsis in these patients. So overall, it reduces the risk of infections, mortality, and morbidity. Then when not to start enteral nutrition for a patient who is on CRRT? For any patient who has been on extreme high doses of vasopressors, acidosis or the metabolic parameters are not correcting, that is extreme degree of hemodynamic instability in forms of not only hypertension, but also kind of arrhythmias or episodes of cardiac arrest, etc., or your blood gases are showing high or increasing levels of lactate, these are the patients who clearly give an indication that they are not ready for enteral nutrition, and you have to wait for these patients before you consider the enteral route for nutrition, because essentially the gut is not moving, there is significant mesenteric ischemia or bowel necrosis, hence your feed is being rejected, so you have to just wait and assess these conditions. Routes of feeding, the common ones, the enteral, which always the preferred one, and parenteral one, which can be either through the peripheral line or the central line. Now, among the enteral one, oral, if a patient is conscious, nasogastric or nasoenteric. For patients who has usually got a pre-existing PEG, it can be also utilized. PEG is usually not performed on acutely ill patients in ICU. And for post-op patients, if they have a jejunostomy tube in place, that can be utilized as well. Now, what are the different formulas? Normal feed are isocaloric feed. It means 1 ml contains 1 calories. Diabetic formula, of course, low sugar, and usually they are isocalories and fiber rich because it reduces sugar consumptions and also increases the gut motility. Hepatic feed are also usually calorie dense with low sodium and rich in branch chain amino acids. Now, renal feed are usually calorie dense formulas with 1 ml and 2 kilocalories because they usually are on a prescription of fluid restrictions with low electrolytes, mainly the potassium ones, and low protein is usually there in the feed, but as per the prescription of the clinician, the total protein intake can be increased, especially if they are on the RRTs. Peptide-based formulas are become very popular in the last decade, I must say. And for patients who are on high-dose vasopressors, if they have hemodynamic instability or cardiac arrhythmias, etc., or in general, if they have a tendency to reject feed, if these peptide-based formulas, which are essentially semi-digested or partially digested peptides, they have been observed to be absorbed better. So they can be utilized in a patient who is otherwise not so bad and maybe probably on a moderate dose of vasopressors, and probably there have been few episodes of feed rejections. You can start these patients on peptide-based formulas, and gradually when there is establishment of good enteric absorptions, they can be switched on to normal formulas. Kitchen blend are still, formulas are still in practice in some places, and they're usually made isocaloric around 1 ml equal to 1 calories. Now, what about parenteral nutrition? As we saw, it can be given through the peripheral routes or the central routes. For central routes, usually the subclavian route is the best preferred one. Also, it can be given through the IJV, that is internal jugular central line. But femoral routes are usually not preferred for parenteral nutrition because the chances of infections are high. Now, if you are giving it to the peripheral line, there are certain limitations that they cannot tolerate an osmolarity of more than around 750 milliosmol per liter. And the fluid volume also needs to be limited. And this is mainly used for supplementation or short-term feeding because these are of less osmolarity, and the full dose of calculated proteins and calories are difficult to be administered through the peripheral TPN. However, they can be used as a partial parenteral nutrition along with the enteral route and usually given for shorter term. What are the solutions now which are given through the parenteral nutrition? It is usually dextrose, there is protein, and also there is a lipid segment of it. This dextrose is usually concentrated around 25 to 50% of the concentration is there, and that's why it is best to be infused through the larger central veins to avoid phlebitis and chances of infections. They're usually, amino acids are usually mixed with the dextrose solutions, and they usually contain approximately 50% of essential amino acid and 50% of non-essential and semi-essential amino acids. As we have discussed earlier, that proteins or amino acids are not meant for calorie supply. They are mainly meant for the purpose of anabolism or building up the muscle mass. Now, IV lipid emulsions also consist of submicron droplets of very small size. The triglycerides which are used nowadays in this formulas, in the total parenteral nutrition formulas, are derived from different kind of oils, and they're available in different strains like 10% or 20%. And in a patients who have got total parenteral nutrition, usually these days this 3-chamber bags are available, as we saw in this previous picture, and they are usually mixed with each other just before administrations. And as a result, the benefit is both the sugar, carbohydrate, like that is the dextrose, proteins, and lipids are administered to the patient at one go, rather than giving separate injections of dextrose, amino acids, and lipid formula separately. And thus the chances of infections and the accuracy of administration performance is better in this triple chamber bags. What are the additives in these bags which are added? It could be electrolytes, vitamins, and trace elements. Now, electrolytes are usually adjusted according to the blood daily lab values. So potassium, etc., can be usually added in these bags, but as a practice, I would recommend to give those additional electrolytes separately through infusion pumps in separate lines. Now, vitamins, among the vitamins, usually vitamin K and folic acid, etc., if they are necessary, they can be administered. Trace elements are also, as a practice, few clinicians prefer to give it while the patient is on parenteral nutrition. Complications of total parenteral nutrition are mainly related to the lines. There could be also hyperglycemia, episodes of sepsis, liver dysfunctions, and the less common ones like acalculous cholecystitis, metabolic bone diseases. And always there is a chance of sepsis in these patients, either related to the line or due to the high osmolar solutions passing through the lines. And if there is any new onset of sepsis in these patients, it is preferably the TPN should be stopped, it should be reviewed, and the line be changed as necessary. What about role of immunonutrition? There is no proven benefit of this immunonutrition which in these patients, and the formulas which usually advocate this glutamine, arginine, etc. Several trials have been done in the last 2 to 3 decades, like Signet trials, Ring, Redox trial, etc. None has shown any proven benefit in these cases. However, these are being used in clinical practice, variable by different clinicians according to their beliefs. Now, there are a few literature I would like to share with you here, which has looked at the adequacy of nutrition support during extracorporeal membrane oxygenations. And this is an interesting paper which has looked at 203 patients. If you see, their median duration of ICU stay was around 21 days, and VV ECMO was used for around 10 days. Now, if you look at this median energy delivery adequacy, it was around close to 90%, and adequacy of protein delivery was close to around 85%. However, they did found also underfeeding of either energy or protein occurred in almost 1/3 of these patients during their stay in ICU or when they were on VV ECMO in these patients. So underfeeding was also quite prevalent. Up to 1/3 of these patients had underfeeding during their ICU stay, especially when they were on this extracorporeal therapy or support. And they also found that a higher admission severity illness score was associated with inadequacy of protein delivery in these patients. And those patients who had got severe organ dysfunction or more severe organ dysfunctions on the first day of ECMO received inadequate energy. Common reasons for interrupted feeding are medical procedures usually and poor gastric motility. Poor gastric motility is easily explained by for patients who are on high vasopressors, if there is mode of cardiogenic arrhythmias and episodes of low hypotension for prolonged hypotension due to mesenteric ischemia, variable degree of bowel necrosis, etc. They tend to reject feed and it comes out, it is interpreted as poor gastric motility. And for various procedures like for lines, for imaging, for insertion of or other procedures, usually feed is held. So that is high as up to 39% of the cases. We have seen this recommended dietary allowances of carbohydrates, proteins, and lipids in these patients. And before, so the ISPN guidelines, which more or less tells us about the flow chart about how to administer, decide about your dietary formula in these patients. An important prognostic factors for decision making before initiating EN will be to understand the underlying diagnosis of a patient for which the ECMO has been started, for patients' vasopressor requirements, and of course, sedative levels also have a role on tolerance of feed, because if high doses of opioids are known to cause reduced peristalsis of the gut, and thereby there is maybe increased chances of food rejections. Similarly, along with hypotension, also low levels of oxygen also compromises with the gut functions. So it also has a bearing on the gut absorption of the feed. This is another paper which looks at the nutritional support in adult patients receiving extracorporeal membrane oxygenations. And they concluded that such patients receive inadequate nutritional support, with only 55% of their nutritional targets being achieved while receiving ECMO. It should be a major goal for these patients, and constantly measures should be there to improve nutritional delivery required. This is another paper which looks at the nutritional support in adult patients receiving extracorporeal membrane, in adult patients requiring ECMO. This is another study which looked at nutrition support in adults, patients on ECMO, and they found that a significant proportion of these patients receive inadequate nutritional support, with only 55% of them getting their nutrition targets while on ECMO. What about the incidences of bowel ischemia and bowel necrosis in this mesenteric ischemia and bowel necrosis in these patients? You can see some of the studies which have reported this, and these are extremely low, which indicates that commencing low doses of at least enteral feed for patients, if they are not extremely unsuitable, is a safe practice, and it should be started actually for a patient for extremely unstable patients after 24 to 48 hours, and see how they go and modify the regimen accordingly. Now, what about this addition of this kind of new additives, which are much talked about, is like fish oil. And now it has been discussed that fish oil enriched parenteral nutrition are shown to reduce infections and ICU and hospital length of stay in ICU critically ill patients. Increased bleeding risk has not been shown in with such use of fish oil enriched parenteral nutrition in general populations. And this is the specific relevance to patients on ECMO, because these patients are anticoagulated, and it has also been generally seen so safe to start fish oil enriched parenteral nutrition in such patients, though there are not many literature in this regard. Now, coming to the end, some of these MCQs I would like to share with you. Like question 1 is, gastric feeding while on ECMO is safe to start early? Yes or no, or true or false? Second question would be, barrier to adequate feeding on ECMO. A, holding feeds for procedures. B, high gastric residual volume. C, both A and B. So the answers are these. So it is safe to start gastric feeding for a patient while on ECMO. And barrier to adequate feeding on ECMO includes both holding feeds for procedures and high gastric residual volume time to time. Coming to MCQ3, to estimate energy needs while on ECMO, we need to do the following: A, B, and C. A, predictive equations; B, indirect calorimetry; C is indirect calorimetry added to VO2 and VCO2 from blood draws pre or post oxygenator. Question 4 is when feeding patients on ECMO, use semi-elemental, polymeric formulas, or either formula. While using PN, while on ECMO, what is question 3? To estimate energy needs while on ECMO, one needs to do the following. When feeding patients on ECMO, you can use one of these formulas. Question 5, using parenteral nutrition while on ECMO is contraindicated, true or false. So these are the answers. Like to estimate energy needs for a patient while on ECMO, one can do both indirect calorimetry added to VO2 and VCO2 from blood draws, pre and post oxygenator. When feeding patients on ECMO, you can use either formula. Using parenteral nutrition while on ECMO is contraindicated. It is untrue, it can be considered. Nutrition support for patients on ECMO is difficult due to presence of vasoactive medicines, hemodynamic instability, and the potential risk of ischemic bowel. Nevertheless, it can be still considered in the particular context of a patient. There are no specific critical care guidelines available in this perspective, and enteral feeding can be started early according to the particular circumstances of our patients after judicious assessment. However, it may be difficult to achieve the optimal feeds and achieve the particular nutrition goals. VIS score is a helpful tool to assess maximum vasoactive agents or dosages that are safe for enteral feeding. And though it is a complicated one, but still can be taken help. But though it is not an absolute guide regarding commencement or cessation of enteral feeding. And a score of around less than equal to 14 is somehow considered safe to start feeding in this regard. I mean, we need to definitely aim for minimizing fasting for procedures, because many times it is observed that patients are kept longer, fasting longer before the procedure and after procedure also. Starting the order for commencement of feed is also gets delayed for a variety of reasons. So this is something that has to be kept in mind, especially for patients who are on ventilator. It's need to be assessed early. Indirect calorimetry and blood gases pre and post oxygenator can be utilized to assess REE, that is daily respiratory energy requirement. Indirect calorimetry and blood gases and post pre-oxygenator can be utilized to assess these. And the use of parenteral nutrition in patients on ECMO may be helpful in achieving nutritional goals. And parenteral nutrition also may be utilized to meet the nutritional goals.
We have one question from delegates for Dr. Varghese. Sir, which is superior in treating patient of HLS, either plasmapheresis or IVIG?
Okay. I have mentioned about the severity assessment. If you ask me, in severity assessment, if it is moderate or if it is persisting, start with steroids is the first option. And subsequently, it comes immunomodulation, what we call it as. Of the two, the studies or much more data is supporting use of IVIG, not plasma exchange in HLH. But both comes into the classification of salvage or alternative therapeutic strategy. Steroids comes first. And if you ask me the second line, probably IVIG. This always holds good that if you use IVIG in subsequently plasma exchange, using plasma exchange may not be possible because, of the fact that IVIG's utilization or IVIG's efficacy will come down. But IVIG is recommended ahead of plasma exchange in HLH management as of now.
Thank you, sir. Moving forward to the next session. The next session is about RRT, particularly about early RRT. We have clinical dilemmas many times in the ICU that either RRT should be started earlier or it should be postponed, or it should be started a little late. And we have a prominent speakers. Both will give their views about whether early RRT is useful or we should wait for the RRT to be started. So first speaker will tell us about early RRT is a thing of the past. We have a speaker, Dr. Kamalpreet Sodhi, who works as a consultant and director head of critical care at Deep Hospital, Ludhiana. Madam, over to you.
Good morning, friends. In this discussion on the timings of renal replacement therapy, my viewpoint is early RRT is a thing of the past. Well, we all know for life-threatening conditions, there's no debate at all. Initiate RRT as early as possible. But there's little consensus on how best to define timing related to starting RRT in patients, especially for the ICU population having AKI. Since there's no single uniform definition available, and the complexity of AKI in real-time world actually makes it difficult to come up with a consensus, which is not as if there even in any of the guidelines. And even standard RCTs, they have shown variations in defining the timing of dialysis initiation. Like what was seen in Ellen trial, the delayed initiation defined as RRT initiation within 12 hours after the diagnosis of AKI stage 3, whereas some of these patients would have been labeled as early RRT in the subsequent AKI ideal ICU or the START AKI trials. So why discard early RRT? What has been seen, the early dialysis therapy looked just best in the earlier, smaller, mostly observational and non-randomized studies. The heterogeneity among the trials was there, including varying definitions used, arbitrary biochemical cutoffs, which actually precluded the definitive conclusions. In the studies of poor quality and unable to find a mortality benefit. Yes, there are safety issues per se, since RRT is not benign, and there are well-documented complications associated with RRT, which might be because of the central venous cannulations, including the PRBSI, the puncture site hematoma, pneumothorax, or the air embolism, the problems of anticoagulation, which cannot be avoided per se, and a huge proportion of patients with severe AKI might never go on to require RRT at all. The economic issues, another major concern is RRT is not cheap. And the cost of RRT is not only in the equipment, but also in the manpower and the maintenance costs associated. The dialysis-induced renal injury may add the cost of more prolonged, potentially lifelong dialysis event. And most of the complications what have been seen, they require relatively just inexpensive, easily administered solutions. Like we can just give in calcium gluconate and reverse the associated hyperkalemia. The sodium bicarbonate can also be used for hyperkalemia reversal or even for the metabolic acidosis, and furosemide might be just the drug to be used for polyuria. The physiological issues are also there, since RRT is not a cure for AKI, it's just a supportive therapy. There occurs loss of electrolytes, the trace elements, the drugs, which might actually lead on to the sub-therapeutic levels of the vital medications. RRT per se may cause a delay in the renal recovery, and the dialysis-induced renal injury is a known complication. In some of the retained toxins of uremia may have some opportunistic benefit, like urea may act as an osmotic diuretic and may actually increase the urine output. So we need to consider all these things. And in my opinion, this is the time that we put the early RRT into the graveyard. You all will ask, where's the evidence? Yes. If we talk about the major landmark trials in the last 2 decades on the timing of renal replacement therapy, from 2002 to 2019 and even later, most of the landmark trials have shown no benefit of early therapy versus the late therapy, except for the Ellen trial, which showed that the early strategy had a lower 90-day mortality. But even the Jamal trial, published in 2013, actually showed that early therapy did delay the kidney function recovery also. So, okay, let's talk about the Allen trial. In this, the early was within 8 hours of diagnosis of Kedigo stage 2, and delayed RRT was within 12 hours of stage 3 AKI or no initiation at all. And what was seen was there was a mortality benefit, there was a better recovery of renal function with the early RRT. this trial had lots of limitations. It was a small single center trial just for 231 patients, having a very low fragility index of 3, which meant that a shift of just 3 patients here and there would have rendered the results non-significant. An early group separated from late by a period of just less than 24 hours on an average. And the LN investigators actually failed to treat the groups equally. Early group received RRT at stage 2 KDIGO guidelines, and the delayed group had to wait until they got to stage 3 before they got the dialysis done. And the use of weird biomarkers, which have actually not proven very beneficial, the ANGAL, and the unusual protocols like 7 days of RRT was continued in each group regardless of the renal performance. So it's make it difficult to use LN as an argument for early dialysis. And even the LN methodology was so much so criticized that this editorial published in the same issue of JAMA in 2016, it actually put a question mark to the publication of the trial itself, whether early to dialyze was healthy and wise. So we must go back and read this editorial. In the same year, the HICS study came, and which was a bigger trial and showing no benefit of the early versus late dialysis, but certainly more than 51% of the patients in the delayed group could be scraped off without any dialysis. And the ones which ended up being dialyzed anyway were already worse at baseline, having a higher SWIFT scores. The mortality benefit was not there. There was no increase in length of stay even with delayed dialysis, fewer catheter-associated infections in the delayed group, more RRT and mechanical ventilation free days. So on the basis of this trial, one may make a strong argument in favor of waiting for spontaneous renal recovery, wherein more than half of the patients could be spared of the dialysis. Then came 2 years later the ideal ICU trial, in which the results were almost the same as per the HICS trial, with no mortality benefit and more RRT and mechanical ventilation free days. But this RRT was more so relevant to our AKI population, since it included more patients with sepsis and septic shock. Then subsequently, START AKI published in 2020, it again showed that there was no mortality difference between the standard strategy and the accelerated therapy, but the KRT dependence was much higher with accelerated strategy and higher adverse events. So this was the last and arguably best one in this exchange, massive trial of around 3,000 patients showing no difference in outcomes. Of the delayed group, around 38% never ended up getting dialyzed. There were greater number of clinically, although trivial adverse events, especially the hypophosphatemia, and early RRT group ended up having a much higher risk of dialysis dependence at day 90, which was a significant finding and which actually raises the question that does RRT itself inflict further injury on the patient's already compromised kidney when they are especially most vulnerable. So this might induce additional dialysis-induced kidney injury. So this trial actually basically laid to rest a long-held suspicion that early initiation of RRT benefits the critically ill patients here. So it should be made to list and peace. So looking at all these major landmark trials, the RRT freedom was more, but in the delayed group, the complications were seen higher. We see a PSI in the HICS group. Higher complications were seen with the START AKI, and the continued need for KRT at 90 days in the accelerated arm was also seen with the START AKI. Not only the individual RCTs, but many a meta-analysis on timing of PRRT has shown that early initiation does not reduce mortality in patients. No significant difference in ICU length of stay, hospital length of stay has been seen. Not only this, the early initiation has been shown in various meta-analysis to increase the risk of hypotension, significantly increase the incidence of infectious events along with hypotension also. This another RCT, including this meta-analysis, including 11 RCTs, again showed that there was no significant difference in mortality, 28-day mortality with RRT dependence or recovery of renal function, but early RRT carries higher catheter-related infection risk and the higher risks of hypophosphatemia. Another meta-analysis just published few months back, it did show that most of the studies, not in the last 5 years, almost all the studies have favored late RRT. So what does the Cochrane review suggest? Published in 2022 October, enrolling 12 studies around 5,000 patients. Again, the Cochrane meta-analysis said that there's little or no difference to risk of death at day 30, no difference at day 90, no difference in patients who are free from KRT, and no difference in recovery of kidney function with early RRT. High certainty evidence showed that early KRT infusion increased the risk of hypophosphatemia, increased the risk of hypertension, cardiac rhythm disorders, and infection. So what we are going to do? Early RRT just trying to avoid or control the fluid balance, trying to avoid further metabolic disturbances, but with huge number of drawbacks, looking at the complications associated with dialysis catheter, with anticoagulation regimes, iatrogenic hemodynamic instability, exacerbating the AKI per se and impeding the further kidney repair, resulting in excess loss of unmeasured micronutrients and trace elements and loss of the vital medications leading to subtherapeutic levels, unnecessary exposure to RRT in a proportion of patients which might actually avoid RRT at all, increased bedside workload, resource use, and the direct health cost. And at the cost of hypophosphatemia, hypotension, cardiac arrhythmias, and infection. So, my dear friends, should the RRT be delayed? Yes, in the absence of serious urgency, kidneys should always be offered a chance to recover, with the opportunity for up to half of patients to get away without any RRT at all, without extending their ICU stay or hospital stay, with no difference in mortality, lesser adverse effects, with optimum hemodynamic resuscitation and biochemical correction, a proportion of patients will probably never need dialysis, and be grateful to you physicians for having pure hold in the next influence. So yes, high quality evidence certainly supports an approach of expectant management in critically ill patients with AKI where RRT might actually be deferred for up to 72 hours with a wait, watch and wait strategy may be justified unless there's a life-threatening indication. But physician's judgment still plays a central role in identifying appropriate patients for expectant management. Thank you.
Thank you, madam, for sharing your views about early RRT. But we have a speaker who is having a different thought. And Dr. Ranjit Chatterjee, who is the head of the critical care department at Swami Dayanand Hospital, he will share his views about there is still place for early RRT in critical care. Let's hear him out. Over to you, sir.
Good morning, ladies and gentlemen. First of all, my sincere gratitude to Dr. Srinivas Sharma Vedan and Dr. Ghaneshyam to give me an opportunity to interact with you on a very pertinent topic, that is whether there is still a place for early renal replacement therapy in critically ill patients that we are dealing with in our day-to-day clinical practice. So before I go to the main topic, I want to state that we have to remove this jinx from our mind that this therapy is only related to acute kidney injury. Renal replacement therapy that we are using, especially the continuous form of renal replacement therapy, is used in a variety of other situations apart from acute kidney injury. For example, it can be used for fluid management, for cerebral edema, for acute cardiogenic pulmonary edema, for acute liver failure patients, variety of electrolyte disturbances, malignant hyperthermia, toxin removal, cytokine removal, rhabdomyolysis, especially in patients of ARDS where they are accumulating carbon dioxide. The machine can be used to remove that extra carbon dioxide by doing a special maneuver known as extracorporeal CO2 removal, plasmapheresis, to name a few actually. And I have seen that, and most of you might have seen that we have to start the therapy much earlier in certain situations apart from acute kidney injury. So this therapy from renal replacement is slowly moving not only towards renal support, but towards organ support. It is supporting different other organs. So it is organ support therapy rather than a renal replacement therapy that we're discussing about. And if we start it early, we can avoid that extra volume overload that we want to avoid in most of our patients. We can take control of the complications of uremia. We can have a good control on acid-base metabolic and electrolyte disorders. And that excessive use of diuretics that can be avoided. The stability of intracranial pressure, which is so important in many of the patients who are coming to us with traumatic brain injuries, there this therapy has to be started quite a bit early. The immune regulation and the active removal of inflammatory disorders, especially in sepsis, we don't know whether if we start it early or late, is it going to help or not. We'll come to that. And obviously, we want to relieve for further injuries or burden by taking the place of damaged kidney function. So these are the situations and the advantages of starting this therapy early. So now the question comes exactly what is early? Whether it is urea, whether it is creatinine, whether it is urine output, whether it is the Rifle criteria, the Akin criteria, the KDIGO guidelines, the fusamide stress test, the newer biomarkers, which of these is going to tell us that what exactly early is? We don't know the definition of early. So we are completely confused. And one thing that we very well know, that by the time the creatinine started rising, already the damage has been done. 50% of your kidney function is gone when the creatinine started rising. So we know these things very well. But still, we are depending on creatinine as the spatial marker, as the only biomarker for the diagnosis of acute kidney injury, knowing very well there's so many pitfalls of diagnosis are there with creatinine. So a lot of situations where you can misdiagnose AKI. So there are certain drugs which interfere with the tubular secretion of creatinine. There may be reduced production of creatinine due to muscle wasting, liver disease, and in sepsis. There may be ingestion of substances which lead to increased generation of creatinine independent of the renal function. In obesity, you can overdiagnose AKI if using actual weight when applying urine output as a criteria. So there are many situations like this, and you can have an extrinsic creatinine administration as a buffer in medications. This is known as pseudo-AKI. So many times we misdiagnose AKI. We diagnose it either early or diagnose it delay. Where there is a delay in diagnosis mainly, especially with the use of creatinine as the sole biomarker. We are also using urine output. Somebody has used urea. And nowadays we are slowly and steadily moving on towards the use of biomarkers, which maybe in the future will help us in diagnosing AKI a bit appropriately in appropriate time. If I'll say that creatinine does not diagnose it appropriately, there's a misappropriation of AKI in our critically ill patients. And see the confusion. If you can see this slide, you can see the confusion that early criteria, they have started with somebody has taken urine output, somebody has taken urea of different values, 27.1 millimole, 24.2 millimoles, 28.6 millimoles. Nobody knows actually. Somebody has taken hyperkalemia as a criteria. Somebody slowly, when the Rifle classification, the Akin and the KDIGO started coming, people concentrated on those criteria and started diagnosing the stages of AKI by this KDIGO classification or the Akin or the Rifle classification. We'll come to that. Now, we should always know that this is a dynamic acute illness. The scenario is changing every minute. So, we have to be very, very, very specific and we have to be very, very vigilant. Especially, there is a difference. A patient coming by car, reading her newspaper and doing a dialysis for 3 hours versus a patient like this, surrounded by all these machines, basically fighting for his life. There's a much difference between these two. Here we can't just take a chance and say that we'll start it late, we'll start it early. Better we start it appropriately. So how can we do that basically? So this is the classification that has evolved over years from Rifle to Akin to Kedigo. Rifle came in 2004, Akin in 2007, and Kedigo in 2012. They basically, Kedigo is an amalgamation of these two. All of you know about it. I'm not going to go into the details of this. And on the basis of this, the studies started actually. So these are the earlier studies before 2010. In fact, I'll say before 2015, when they found that if they're starting it early, they're getting much better survival benefit than those if you're studying in a late stage of Rifle. Similarly, this was also taken early and late. It was found that if you start renal replacement therapy early by the Rifle criteria, you will be getting more mortality benefit than those if you start late. So they came to a comparison of early versus late initiation of renal replacement therapy in a meta-analysis, and where 15 studies were compared, where they found that early initiation of therapy was associated with significant improvement in 28-day mortality. So there was better renal recovery, reduced duration of RRT, and decreased length of ICU stay. This was basically before 2015. And on the basis of this, the Kedigo in this picture basically considered renal replacement therapy in stage 2. If you see this picture carefully, they mentioned considering renal replacement therapy in stage 2 of Kedigo classification. But this was 2012. After that, so 2015, the scenario changed a bit. The community was completely divided whether to start it early or late, and then these two main papers came. That one is the AKK, another one is the Alien. Two from two different countries. Most of these studies that came after these 5 studies, they are RCTs, except the Alien trial, which was a single center RCT mainly done on surgically ill patients. And this is the only study which started AKI at stage 2, Kedigo stage 2. And they took NGAL as a marker also to start AKI. If the AKI NGAL was more than 150 nanogram per ml, they started the patients early in that stage. And what did they found? That when they started at AKI stage 2, the mortality was 39.3%. See the mortality percentage, below 40%. Whereas at AKI stage 3, it was a huge, nearing 48, 49%. That is nearing 50%. But there are so many. Obviously, every study is not perfect. So people came out with all of the criticizing this study being a single center study. It is mainly done on surgically ill patients. So many things like this. And obviously, other studies started coming after that. And they're the Ideal ICU trial, the START AKI trial, and the AKI-2 trial. If you see the classification in this, if I've classified all these studies one by one, and if you see it carefully, only LN trial, it started in Kedigo stage 2. Whereas all the other trials, they started either in Kedigo stage 3 or AKI-2 trial went further ahead. They took the late of AKI trial as the early of AKI-2. That were too late in starting the renal replacement therapy. And not a single trial found that there is any mortality benefit if you start it early rather than if you start it late. But there are 2 points here. See the mortality range. It is nearing 49, 50. Somewhere it went up to 58%, 54%. If you start it late, it's going up quite higher when you start it at stage 3. only one study started at KDIGO 2 that showed a mortality benefit of 39.3%. Whereas all other studies which started at KDIGO 3 or rifle left or too late in KDIGO 3, they had a huge mortality of around 48, going nearing 50%, somebody crossing 54% also. One of the best studies of this is the START AKI trial. They took the appropriateness of the case and they depended on clinical equipoise of the clinicians, on the basis of which they choose their patient, whether to start it early or late. Now, clinical equipoise is a double-edged sword. The clinicians sometimes differ in their opinion regarding whether to start it early or to start it late. So they had to exclude 7,000 patients here because clinical equipoise was not reached. And they have found a mortality of around 44%, nearing 45%, 44, 45% in their patients when they started early or started late. So now the basic point comes, since 2010 till today, the RCTs that are done in critically ill patients, only 5% of them has a positive result. Because how it is possible to stamp one therapy as the surrogate marker of mortality in these critically ill patients who are heterogeneous, multiple organ involvements are there. So these are the patients where it is very difficult to do RCT. And see, if I have shown you that there was no mortality difference between early and late. In all the studies which are shown after Align trial, there is no difference. So why should I allow my patient not to have the therapy when there is no mortality difference? Why should I not give the advantage to my patient? Yes, there are certain differences between these two. For example, there was rise in some of the adverse reactions were more, and they quoted that there was unnecessary RCTs were done in certain patients. Unnecessary treatment many a times are done in many patients. We don't know about that. We don't know it before that we are doing an unnecessary treatment. When the patient becomes all right, after that, when we analyze, we find, yes, we might have done this treatment, which we would have avoided. But when we are dealing with a patient which is so critical, and I know that I have a therapy which can take care of my volume, take care of my acidosis, take care of my kidney function, take care of so many conditions. Why shouldn't I wait? Why should I wait? So that was the question that was asked by Ravindra Mehta. What are we waiting for? We should not wait here. We should find that appropriate time, exactly when to start by patient. If it a bit early, no problem. Let us go it early, but we should find that appropriate time. And if you see this study on the optimal timing of initiating continuous renal replacement therapy in septic shock patients, this was in 2009 and it came up in Nature. And they found that the time from AKI onset to CRRT initiation was compared according to the ICU mortality. It took longer to initiate CRRT in non-survivors than survivors. The cutoff time for AKI onset to CRRT initiation for ICU mortality was 16.5 hours. And the cumulative mortality rate was significantly higher in patients in whom CRRT was initiated beyond 16.5 hours after AKI onset than in those in whom CRRT was initiated within 16.5 hours. And lactate, pH, SOFA, aPH2, sodium, everything was higher in the non-survivors. So the point is, certain studies are showing that maybe if we are too late, we are doing more harm to the patient. And accordingly, so many guidelines came up. I'm not going into the details of these guidelines. Many of them, and most of them, in fact, were not sure exactly when to start it, except one of the best of it was the ADQI initiative that was taken, that this guideline asked certain questions and they answered those questions. The first question was, when should acute AKI be initiated? When should acute RRT be initiated, including AKI and non-AKI indications? Answers were, acute RRT should be considered when metabolic and fluid demands exceed total kidney capacity. So this is very important. So when exceeding the kidney capacity. Now, demand for kidney function is determined by non-renal comorbidities, the severity of the acute disease, and solute fluid burden. So now they're coming out of that chinks of acute kidney injury that created in anuria and urine output. They're coming to the other situations also where we can see the demand capacity ratio, how to find them out. Now, the total kidney function is measured using a variety of different methods. Excuse me. Changes in kidney function and duration of kidney dysfunction can be anticipated by markers of kidney damage. So now the biomarkers are slowly coming up. And the demand capacity imbalance is dynamic and should be evaluated regularly. So the demand capacity imbalance is dynamic. That I was discussing before. So we have to be very meticulous in selecting our patients. And for the patients requiring multiple type of organ support, decisions about initiating or withholding RRT should be considered together with other therapies. And once you have taken the decision, you have to start it within 3 hours. So that is the last consensus statement that they are giving. You have to start it within 3 hours when you have decided. Now, how do we know exactly my patient is progressing severe AKI or not? One of the best ones that we have today is the FST, the furosemide stress test. So we all know that we give furosemide at the rate of 1 to 1.5 milligram per kg body weight. If the patient have not received classics or received furosemide before, and in euvolemic or hypervolemic AKI stage, not in hypovolemic stage. That means after volume resuscitation, we give furosemide, we wait for 2 hours, we see the urine output. If the urine output is less than 200 ml over the 2 hours, that is 100 ml per hour, every possibility that my patient will move towards severe disease, severe acute kidney injury, maybe acute stage 3 with a sensitivity and specificity touching more or less 85 to 90%. And if I combine furosemide with the biomarkers like NGAL or nephrocheck, that is TIMP2 multiplied by IGF-PP7 in the urine, and we see there is improved severe AKI predictability. So we can predict AKI much better if I combine these biomarkers. These are still going on in the research stage. Furosemide stress test is used more or less in every ICU nowadays. So we can very well predict that whether my patient is moving towards severe kidney injury or not. We can see the renal angina index. I'm not going into the details of this. If it is more than 6 or the persistent AKI risk index, certain scores have been given. So we can assimilate these scores together and we can assess our patient. And if our patient is moving towards a severe AKI, we don't wait. So if your patient comes with an AKI, you optimize the volume, mean arterial pressure, cardiac output, intra-abdominal pressure, do all these things. Or if you have other indications like refractory fluid overload, septic shock, ARDS, hypothermia, acute liver failure, severe electrolyte imbalance, acute tumor, lysis syndrome, these are the situations you don't really start. Now, after optimizing, you see whether your patient is KDIGO stage 2 or KDIGO stage 3. In your KDIGO stage 2, if you find that your patient is worsening by doing furosemide stress test and the other biomarkers, or there is a refractory fluid overload, severe sepsis, ARDS, hypercatabolic state, don't wait. Start. This is the time to start it, whether it is KDIGO stage 2 early or KDIGO stage 3 late. If at all you consider this KDIGO stage 2 early or KDIGO stage 3 as late. If you ask me, I am already, when the patient is in KDIGO stage 2, I think my patient is already moving towards, I am quite late basically. So I start RRT when my patient is deteriorating, even if it's KDIGO stage 2. So now, ladies and gentlemen, it is up to you to decide when you have to start this RRT. I'm sure now you have got an idea about it, and you must be practicing in your own practice according to your own decisions. And I'll always say that a stitch in time saves 9, and ultimately a stitch too late, you know, it always sails your fate. So I leave it to your decision to your discretion. And thank you so much for your patient hearing. If you have any
So we have heard both the speakers put the pros and cons of early versus appropriate or late RRT or early RRT. But it's always going to be, as Dr. Anajit said and Dr. Kanwarpreet also said, it's always going to be an individualized decision making. So weighing the viewpoints expressed by both the speakers, what is the correct stand on early initiation of RRT or late initiation of RRT? What is the consensus approach to the timing of initiation of RRT? It will be dealt with by Dr. Rajesh Mishra, a senior intensivist from Ahmedabad, immediate past president of the Indian Society of Critical Care. Rajesh.
So, hello everyone. I have just to talk about the optimum timing of RRT. Talking in particular, there is no ideal optimum time when RRT can be started and when cannot be started. In last 50 years, they have struggled to find a exact timing, and none of the trial, none of the evidence tell us that when should we start renal replacement therapy. So going back to basic physiology, we need to understand why we need to start the renal replacement therapy, and then probably we will be able to know when we should start renal replacement therapy in ICU patient. Our primary goal is for renal replacement therapy is to compensate for the loss of renal function and associated sequelae. When we talk about the loss of renal function, it has to be taken in total consideration, like fluid electrolyte balance management, function for the hormonal function, endocrinological function, metabolic control, and maintaining total homeostasis. And it's a different interaction with other organs. At present, none of the extracorporeal circuit or support is able to completely replace or compensate for the loss of renal function. Apart from that, we have to also understand that when we start renal replacement therapy, there is a associated complication or associated other problem with renal replacement therapy, like a problem with putting vascular access, starting dialysis, giving repairing. So each and every patient, when there is not an absolute indication to start renal replacement therapy, when we are in borderline, we have to think multiple times when we start renal replacement therapy that is this renal replacement therapy is going to help the patient or is going to harm the patient. And each time when we wait, we find that one of the most important reasons when there's not absolute indication to start renal replacement therapy, we have to find what is the cause and why. If we start seeing the total cumulative all the trials which we have looked for the timing of renal replacement therapy and survival, it is found that either it is early or late renal replacement therapy and there is randomization. There is no significant difference in survival or total outcome, dialysis-free day, renal recovery, any of those parameters which helps either start renal replacement therapy early or in late. These are the patients where we are in borderline. These are not the patients which are having absolute indication to start renal replacement therapy. So what are the absolute indication where you have to start renal replacement therapy immediately when you come across? It is refractory hyperkalemia. Potassium is rapidly rising, not responding to medical therapy. Optimization of medical therapy, in that case, you have to start renal replacement therapy immediately as per modality. Refractory metabolic acidosis, if you are not able to manage the metabolic acidosis by optimizing hemodynamics, looking for the ventilator support, or if needed by replacing bicarb, if that does not help, and patient is worsening or acidosis is worsening or pH is going less than 7.20 or potassium is going up, they are the case where you have to start renal replacement therapy immediately. The refractory pulmonary edema, if you are not able to take care of the fluid overload or volume overload, or they are not responding to diuretic therapy, they are the patient where you have to start renal replacement therapy. Some of the symptoms of uremia, which is like bleeding, pericarditis, and encephalopathy, or some of the overdose like dialyzable toxin. These are the indications like TCA or methyl alcohol, the lithium. They have to start renal replacement therapy immediately. Apart from that, all the condition where if our homeostasis, our renal system, is able to compensate for the loss of kidney function, and if we are able to keep the patient stable and patient metabolic acidosis is not there, hyperkalemia is not there, hemolytic instability is not there, patient is able to move out good amount of urine. Urea and creatinine value should not be an indication to start renal replacement therapy, irrespective of the urea and creatinine level. This particularly START AKI trial, which has shown that early or preemptive RRT initiated did not confer any clear advantage, did not address how long RRT could be safely deferred in setting up unremitting AKI. Particularly, there are the landmark trials in 2002, which has tried to see the different aspects of different timing of renal replacement therapy. In fact, when we have to understand that in ICU, the AKI is not a standalone disease. It's a part of multi-organ dysfunction syndrome, which is a continuation of dynamic process where things start due to hemolytic instability, compensatory power of body, when compensation get decompensated, and then we have to look to that. So we have to try to be minimalistic. Less is more approach should be there, and as long as we are able to maintain hemodynamic homeostasis, acidosis, able to take control of urine output, better we should try to delay or avoid, because we know that renal replacement therapy, any form, either it is SLADE or it is conventional dialysis or CLRT, is not without side effect. It is not without excessive cost, and sometimes even it can add to the mortality if not done appropriately. So we have to be very, very careful. So all these trials, and somewhere or other, either they did not show any benefit, or some of them have shown even harm if early RRT is started. Same way here, if you see Elan, Akiki, Ideal ICU, all these trials, if you see the individually, there's no difference in mortality, not a significant difference. Some has shown, but there are not significant difference in outcome, no difference in length of ICU, no difference in recovery. In fact, some of them have even shown associated harm with starting RRT, and the benefit which was due to RRT was further offset by the harm caused by renal replacement therapy. So, which is better time for initiation strategy for renal replacement therapy? This trial tried to look to that. There was a multi-center trial, and there was a within 6 hours, and there was a delayed strategy. Delayed strategy in this trial, there is no significant difference with regard to the mortality between early and delayed strategy. Even mortality, RRT free days, mechanical ventilation free days, or even vasopressor free days. So none of them were very significant when renal replacement therapy was offered, irrespective of the being specific to the cause, being specific to the patient. So when a generalized approach was seen for starting renal replacement therapy, it did not help, and in some of the cases, it has harm. So what is my recommendation for? So if you get a patient who has acute kidney injury, there is oliguria or anuria, and compensatory power is completely offset, patient admitted in ICU. So if you have a case of absolute indication, you start renal replacement therapy immediately to avoid the death due to the acute worsening. When you are not having acute emergency, when you have time, when your body system has time to compensate, give body time to compensate, and give kidney that it can it can regain its function without support, rather than stabilizing the patient and treating the cause. So if you find the cause, if you can treat the cause, you can take care of the cause, it may be possible that you can delay or avoid unnecessary harm due to renal replacement therapy. So the first thing is, if acute kidney is there and patient admitted ICU, there's no absolute indication. If the AKI is not there, you keep the patient optimized with cardiac output and fluid state, not too much of that, not too much of that. If AKI is present after hemodynamic optimization, You assess the severity of AKI, assess continuously the compensatory power of kidney. If compensation is appropriate and patient is not going to acute life-threatening emergency, you can wait for starting. If it is severe AKI and patient is worsening, going to anuria, and patient compensatory power fails, then you can consider renal replacement therapy. Always remember, when you start first renal replacement therapy in a mild to moderate patient, always look to the osmolality, always look to the sodium. Do not change the osmolality very fast. Do not change sodium very fast. Do a short duration renal replacement therapy, but many times that this patient has altered sodium, or many times when this patient is having hypoxic injury and suddenly do renal replacement therapy and suddenly change osmolality, this can kill your patient. And this mistake happens very often, and particularly when our nephrologist friends are involved, they do not look to this part. They only try to bring down urea and creatinine, which is of no significance for us. Urea and creatinine are not that toxic for us, you have to understand. So as an intensivist, when something happening to your patient, please be very careful to bring down osmolality and sodium, or change sodium osmolality very slow. Otherwise, you end up losing your patient. If AKI is not present and potential non-renal indication to start renal replacement therapy is fluid overload, refractory septic shock, acute liver failure where you start CRRT, tumor lysis syndrome where the tumor load is too high, though this patient is passing. So even AKI is not present, there are some indication where renal replacement therapy can help, but they are again cause-specific indication. If none of them are present, AKI not present, you can monitor the patient and wait for the kidney to recover. So the approach which I follow is the cause-specific renal replacement therapy rather than offering renal replacement therapy to anybody. So first we try to optimize the patient, try to treat the treatable cause. If cardiac output is low, optimize cardiac output. If sepsis is there, treat the sepsis, control the source. RRT is next. We should give the last and least priority to offer renal replacement to unstable patients. The repeated trial has shown it very clearly that starting RRT is not going to help anyone. You can optimize, you can prevent, but once something has set in, the first is optimization of cardiac output, hemodynamics, fluid status, appropriate antibiotic. And if you find cause, treating the cause is a priority. Once you have taken care of everything of this, then you have to weigh the balance of benefit versus harm, because by offering renal replacement therapy, you're just going to take care of the urea, creatinine, some acid base and fluid. But if fluid overload is not there, if urea creatinine is not causing metabolic acidosis and hyperkalemia, just for the number's sake of high urea, high creatinine, you should not be starting renal replacement therapy. So only one message I want to give you, that when you want to start renal replacement therapy in ICU, if it is absolute indication, you start that also very carefully. In a borderline patient, continuously assess and reassess what cause you can reverse, and if reversible of the cause helps in improving compensatory power of kidney, work on that rather than offering renal replacement therapy, decompensating kidney more, and switching off the kidney completely. So that's what the approach I follow at present. Thank you. Thank you for all attention. So in conclusion, initiation should be considered degree of other organ dysfunction to support other things. Presence of hormone condition that can be modified, like acidosis or fluid overload, then only. Change of urea creatinine is not our priority, rather than change in the metabolic acidosis, homeostasis, electrolyte is our priority. You have to continuously assess the recovery of renal function, because too much of the renal replacement therapy sometimes offset the renal recovery. You have to be very, very careful if you are offering too much of the renal replacement therapy that can further decompensate. So absolute concern, just one more message I want to give you, that absolute concentration of urea and creatinine is not a decision for starting renal replacement. Thank you. Thank you for all your attention.
Thank you, Dr. Rajesh sir, for providing information about optimum time of RRT. As we don't have questions on RRT, we thank again Dr. Kamalpreet, Dr. Ranjit and Dr. Rajesh for their wonderful input for RRT. Moving forward with the program, we have a next oration from one of the very eminent speaker, Dr. Suresh Ramasubram from Apollo Hospital, Kolkata. Over to you, sir.
Good afternoon, everybody. It's a privilege to be here giving an oration for the HICS8 meeting. I'd like to thank Dr. Srinivas and Dr. Ghanshyam for providing me this august platform to pick up a topic of my own choice and to speak on it. And I chose a topic which is not core science, but about the practice of the science of medicine and intensive care medicine. What made me really choose this topic was a recent kind of a case that we came across. Let me quickly recount the case for you. It's just kind of an anecdote, let me put it this way. So it's a 45-year-old male with progressive shortness of breath, swelling of feet, puffiness of face, and chest X-ray with moderate bilateral pleural effusion, and an ultrasound with moderate ascites. So he undergoes a diagnostic thoracentesis, a paracentesis, and gets sent fluid for chemistry, proteins, ADAs, TB-PCR from all three places, and it all comes back negative, transudative, low SAG fluid. And what eventually clinches the diagnosis is basically a urine routine, which is a 4+ protein, and a 24-hour protein tells you that's 20 grams of protein going down the urine. So it's kind of, do we think we were overzealous in trying to get a diagnosis, or some people might call us unscrupulous also, but I don't think that's the issue. The issue is, are we doing the right thing for the patient? And that's why I thought, let me use this opportunity for where I'm asked to select a topic and speak on. Let me talk on this concept called diagnostic stewardship. So the question comes is, what is stewardship? Isn't it? So what is stewardship? And stewardship implies a duty to responsibly manage resources. Like right now, there's a heat wave in electricity, a heat wave in Kolkata, and everybody is asked to manage our air conditioners responsibly. So not to switch it on when we're not needed, to switch it off when we go out of the room, and so on and so forth. So it's the resources that we have, and how do we manage these resources? So most of us have heard of antimicrobial stewardship, but the fact that there's something called a diagnostic stewardship may not have been heard by us, many of us, but some people who are into antimicrobial stewardship and have attended, like in this indoor conference, we had Dr. Dhruv Chaudhary speaking on diagnostic stewardship, and you might have heard speaking of it, but this is in context of diagnostic stewardship as part of antimicrobial stewardship. I'm going to speak on diagnostic stewardship as an entity by itself in critical care medicine. The proponents of diagnostic stewardship have always emphasized there's an intimate relationship between getting a correct diagnosis and management in infectious syndromes. And does this kind of, now if we were to use this integrated model of appropriate diagnosis leads to appropriate management, and hence antibiotics would be used appropriately, can we do this and take this into other realms of critical care as a framework of qualifying appropriateness of diagnostic testing and subsequent tailoring of investigations? For example, in our CTVS ICU, we do ABGs like it's nobody's business. Blood gases are done left, right, and center. So how often? And do we react to it? No. We use that to check potassium. Is that the right way to spend money? We really don't know. Focus. You do so much of focus now, we don't know what to do with the report information that we come. So there is a lot of research and a lot of interest in saying quality work that's going on to say, can we reduce all these things and will this make a huge difference in how we go about it? So the objective of my talk here over the next 25 minutes is going to be saying, let's define diagnostic stewardship and how we are going to have a practical framework for diagnostic stewardship in the ICU, which is obviously going to be grounded in the antimicrobial stewardship program. How we can design, implement, and what is the evidence for diagnostic stewardship programs for the infectious syndrome, which are many, and then how do we apply this to non-infectious disorders in the ICU? So let me look at this and say, concerns about using appropriate lab facility to diagnose and treat infections have existed since the 1970s. And with the development of NAT technique, it has been a significant problem, a significant issue, especially in antimicrobial. The promise of these tests in tailoring antimicrobial stewardship is becoming very prominent. As I just mentioned, if you attend any antimicrobial stewardship workshop nowadays, they will talk on diagnostic stewardship. And this guideline from the World Health Organization, the GLASS, that is a Global Antimicrobial Resistance Surveillance Committee, has defined diagnostic stewardship. So I'm going to use that definition of diagnostic stewardship and let you know what is diagnostic stewardship. So diagnostic stewardship, according to WHO, is as per the GLASS manual, is a coordinated guidance and interventions to improve appropriate use of microbiological diagnostics to guide therapeutic decisions. So that means, how do we use our NATs? How do we use our PCRs? How do we use our early biocultures technique, and so on and so forth. So what it should do is, eventually when you do a diagnostic test, it should promote appropriate, timely, it should be appropriate and timely, and it's also focused on how to collect specimen, how to identify the pathogen, and how to accurately and timely report the results to guide the patient treatment. So that is how the diagnostic stewardship is defined by the World Health Organization per se. So let's talk about what is diagnostic stewardship and what is the historical concepts of diagnostic stewardship. So the history of diagnostic stewardship initially, as I said, is coming out of the branch of antimicrobial stewardship from infectious diseases, where early proponents have said very well, and we now know good data that accurate microbiological data would enhance the safety and efficiency of patient management decisions. And by diagnostic stewardship, we mean across the entire spectrum of diagnostic process, right from what is the test to be selected, whether you do a NAT, whether you do a PCR, or whether you do routine cultures, and how do you collect these specimens, how to properly do a swab. For COVID, we have always been taught how to collect blood cultures is something which we do so that we reduce the risk of contamination. We consider the epidemiological context and clinical probabilities of the disease in result interpretation, and we do this as a part of the diagnostic stewardship. So diagnostic stewardship encompasses every aspect of diagnosis from a microbiological perspective or from a testing perspective. So, and a flow diagram for this would look like this. So that means if you have a patient who comes to your health facility, the clinician makes a diagnosis, the clinical staff will collect the specimen, the clinician starts an empirical treatment, and the patient information is sent to the laboratory, where the laboratory staff will process the information to the clinician and surveillance team, and the clinical team will again interpret the result and reevaluate the patient treatment. So this interface is where there's somebody who's doing this diagnostic stewardship or antimicrobial stewardship, who's looking at this and seeing that was it indicated, was the specimen collected right, was the treatment started right, and when the lab gets a report, how do I interpret it? So the person, there's a team which is doing the coordination between all this thing, and that's probably what is the most important part of diagnostic stewardship, the antimicrobial stewardship team. However, these first iterations of diagnostic stewardship did not allay the problem of managing infectious syndromes, but created new questions like how to distinguish colonization. So you create a lot of issues. When you send a lot of RT-PCR, you've seen this in COVID, where you don't know whether the patient is getting better, is it still active or not. So say for C. diff also. So if you have a NAT positive for C. diff, is it truly a pathogen or is it a colonizer? We really don't know what's happening. So it's created a lot of issues that has happened, and that's why the stewardship have now focused not only on getting how to appropriately do the test and say, but also to appropriately guide our clinical behavior so as to reduce the unnecessary testing and therefore the false positive results. For instance, like in Clostridium difficile, we don't want you to send a stool when somebody is on lactulose already, or on a laxative. So if you're on a laxative, we should not be sending Clostridium difficile, because you might get a false positive, and that's going to put the patient onto a barrage of treatment and unnecessary create a problem of over-diagnosis and over-treatment that is going to happen. So diagnostic stewardship is no longer just focusing on when tests should be done, but is to focus on appropriate clinical behavior. The antibiotic stewards or the diagnostic stewards have have basically can add and achieve or additional goal of reducing overdiagnosis and overtreatment by running a diagnostic test on inappropriate specimens. So that means you're not going to run a test on somebody's sputum which is contaminated by oral flora. Avoiding diagnostic tests in low pretest probability setting. That means if you don't have symptoms, don't send a urine culture. A cascading test, that means perform urine culture only if the urine analysis is positive for pyuria, and or nudging the clinicians in the test ordering process through electronic order prompting. So this is one of the ways in which the concept of DS or diagnostic stewardship is moving from just antimicrobial stewardship, that means after the culture, to diagnostic stewardship to tell how the culture should be drawn, and now really guiding an appropriate clinical behavior of asking how tests should be done or when tests should be done or why tests should be done. And this has become very important for diagnostic stewardship in ICU, because the concept of this thing is of diagnostic stewardship, though born from the infectious disease or the antimicrobial stewardship program, is now spans the entire clinical medicine. If you look at this choosing wisely guidelines from ABIM and other good, you will see a phenomenal number of guidelines from so many societies. If you just look at what is the guidelines from critical care societies, and some of the examples are very standard, which we just do practice, like don't transfuse RBC if your HB is more than 7, don't order routine X-rays, routine diagnostic intervals, but either in response to a specific clinical question, do not deeply sedate mechanical ventilated patient, and so on and so forth. So like this, hundreds of societies of various subspecialties of medicine and surgery have come in together and are now saying that eventually in medicine, the golden word is that clinical context is key. That's why it's critical care medicine. It's not critical care alone or not intensive care alone. So you're talking about what is the relevance of that particular test in that particular situation to that particular patient. So clinical context is how you interpret the test, how you order the test, and how you even think about doing the test, so in the other way around. So that is what is diagnostic stewardship in the ICU. So diagnostic stewardship in the ICU can be put as saying that you should order a test based on a reasonable probability of that disease. So that means it's not like, okay, let me send this and find out what happens. You're thinking about that this could be a disease, therefore you order a test. So and then you require testing only when it directly informs time-sensitive therapeutic decision. If it's not going to make any difference, you're not going to change the outcome of the patient, or you're not going to change any therapeutics, don't order a test. Like you send a lipid profile in a patient, you're already on atorvastatin 80 milligram after a heart attack. What are you going to do about it right now? So don't bother about it. So there are certain things like these times, the therapeutic decisions that you need to do. Further, the ideal steward would consider improved patient outcomes, not just incremental changes in diagnostic confidence. We do a lot of tests just to make sure that, okay, am I going in the right direction? So that is very important, that a steward thinks about it and say that this is not the way it is going to be done, and this is what is the right way to do it. So the steward also has to understand the economic impact of testing, because it costs a certain amount of money. So a biofire costs 22,000 rupees. In most of the institution, do you really want to send this? Is it a value-based proposition? So diagnostic stewardship in the ICU, a diagnostic steward in the ICU, which most of the time is an intensivist who's rounding in the ICU, who also acts as a steward, has to answer these 3 questions. But in summary, it boils down to ordering the right test for the right patient at the right time. And then there are 2 more tenets which we will talk about at the when we go down the talk. So let's look at first how diagnostic stewardship has been used in key infectious syndromes, which is where I'm borrowing most of my talk from. In a sense, like we know that it's been used in bloodstream infection, blood cultures, UTI testing, tracheal cultures in BAP, clostridioids, colonization and infection, and CNS infection. So let's first talk about bloodstream infection and blood cultures. One of the most commonly ordered tests in hospital setting in the Western world is blood cultures. We might disagree that in our country, we hardly send blood cultures. We do more meropenem than blood cultures. And that's always been a case. But from a Western literature, blood culture is one of the most commonly ordered tests in the ICU wherever. So the indications for obtaining blood cultures are unfortunately not written in a stone. So you can order it for leukocytosis, you can order it for fever. We really don't know when to order it. So fever and increased WBC count are probably the main reason why blood cultures are ordered in the western part of the world. They do, unfortunately, even fever doesn't correlate very well with bacteremia, and the blood culture yield is only about 5 to 15% in the best of centers, and about 50% of these blood cultures may be false positive because of the, especially if you have obtained it from a central line. So yield is low as because cultures can be obtained after the antibiotics have been given. So there are a lot of issues with the blood cultures. Consequences of unnecessary blood cultures is that you get a false positive, you're going to have more antibiotics, you're going to have more stay, and so on. So the Infectious Disease Society has come up with certain guidelines on how to do the blood cultures nowadays. So if you are thinking that that if you have patient in severe sepsis or septic shock or you have infective endocarditis, then yes, blood culture is recommended, and you have to do 2 peripheral sets and 3 peripheral sets in case of IE and so on and so forth. But then if you're not in severe sepsis or septic shock or in suspecting infective endocarditis, then you got to ask this question of what is the pre-test probability of bacteremia. If it is high, for example, you're suspecting catheter-related bloodstream infection, epidural abscess, meningitis, septic arthritis, and so on, then you have to have blood cultures recommended. If intermediate, like pyelonephritis, cholangitis, and then if you have low, like in HAP and healthcare associated post-operative fever, then the yield of blood culture is low, so you can probably, blood culture is not recommended while, and in case of intermediate, you have to think about it, and so on and so forth. So this is kind of a guideline that IDSA has come up with for even doing blood culture. A simple thing which we are taught, like, go ahead and do blood cultures in every one of the patients. No, it's not like that. So we got to think about every test because of the chances of overdiagnosis and contamination and so on, and the problem that it creates when we order a test when we don't need it, or when we order a test without expecting what the positive results could be. All right, so let's move on to UTI testing. This is another big issue. Diagnosis of UTI generally in a non-neutropenic patient is based on symptoms of inflammation, which is generally pyuria, and a culture. However, it's not possible to say whether it's asymptomatic bacteria, sterile pyuria, UTIs. The differentiating between these three has been the focus of antimicrobial stewardship programs. And diagnostic stewardship basically involves the appropriate interpretation of these tests. That means how to distinguish UTI from asymptomatic bacteria or sterile pyuria, and extends it to the consideration of whether the initial ordering of urine studies are appropriate. That's what I'm saying. So diagnostic stewardship has now moved on from just not interpreting the test, but asking why the test was ordered in the first place. So diagnostics testing requires you to access the pre-test probability, and certain rules have to be followed. So the pre-test probability is there a chance that the patient has UTI? So if your pre-test probability is not there, don't order the test. And if it is so, then what do we do about it? So we know that COTI is a huge, there are certain rules for it. So the rules are like, do not order urine analysis and urine cultures in the absence of symptoms, particularly in the presence of a catheter, because we know that catheter colonization is a big problem. So COTI is a huge burden, but also asymptomatic bacteriuria from a catheter is going to lead to unnecessary antibiotics, unnecessary hospitalization, and prolonged stay. So this is very important that we order urine analysis and urine cultures only when there are symptoms. And second is, one of the things which has happened in the US and most of this thing is that you order a urine analysis and urine culture is only refluxed only when the urine analysis shows pyuria. If the urine analysis does not show pyuria, the lab won't run a culture. So this is one of the ways in which what is called as a conditional reflex to urine culture, which is a diagnostic stewardship intervention. And this has shown to improve outcome and does not show any change in outcomes or patients dying from sepsis or any of these things that has happened. So one of the pillars of the UTI testing now has been to what is called as conditional reflex to urine culture. And that's something which we need to adapt so as to decrease the amount of false positive urine cultures, especially with catheter-associated urinary tract infection. Moving on, the third thing that we would is basically what happened here. Sorry about that. Sometimes these things, glitches happen, and let me just move back to UTI. And so next is the tracheal cultures and VAP. If you look at tracheal cultures, it is recommended that you have to do a respiratory culture either on endobronchial secretions to diagnose VAP. If you don't do that, you cannot even diagnose VAP, because the algorithm for VAP from the American Thoracic Society asks you to do a diagnostics. But the point is that you have biofilm formation, and diagnosis of VAP, if you miss it, it's going to cause increased morbidity and mortality. So you're going to be, encouraged to send it at an endotracheal thing in cultures and secretion. But this is one of the problems, is that despite doing that, your outcomes are not better. You're going to use an overuse. So if you were to use a biomarker informed stewardship in VAP, this VAP Rapid 2 study has been done recently to look at clinical biomarkers to improve VAP. And these includes newer biomarkers, not the procalcitonin that we are looking at. So like IL-1B and IL-8. And these also have shown that there is, despite using all these things, there's no difference in antibiotic-free days or other clinically relevant outcomes. Common biomarkers like procalcitonin has been certain in the role, very uncertain role as far as diagnostic stewardship is concerned. So why have these biomarkers failed in VAP or in diagnostic stewardship, especially in VAP? And the reason is probably the clinical fear or the culture that we have in the last 25 years of mind-boggling data coming through, that if you delay in antibiotics, if you delay in diagnosing things, outcomes are poor in VAP. So we tend to look at the slightest change in oxygenation, slightest change in X-ray infiltrates, we would order a tracheal culture, and something or the other will grow, and we tend to over-treat it. So that's something which is a very big issue. All right. So what about using BioFire? Can we use that to assess diagnostic stewardship in VAP, and what is to be done? So I think that is some of the ways in which we can think of it. But again, the data on this is, as I said, still not very clear as far as how the use of BioFire is going to change your outcomes and change your antibiotic use and change the antimicrobial stewardship approach in VAP as of now. So as of now, we know that BioFire is going to give you a lot of false positive. Yes, it is going to maybe able to help you de-escalate antibiotics and so on. So this is an active area of interest, especially in VAP antimicrobial stewardship, which we need to be aware of. Moving on to C. diff, we know that the main goals of antimicrobial stewardship for many years has been reducing the incidence of C. diff colitis. Unfortunately, C. diff culture is difficult, and positive antigen and NAT testing does not even reflect true infection in many cases. So the diagnosis of C. diff again relies on a positive test results in an appropriate clinical scenario. That's why it is important again to emphasize that the diagnostic stewardship in, say, for diagnosing C. diff would ask you to send a C. diff. This is the guidelines from the IDSA, would say that you only send it if patients were not receiving laxative, 3 unexplained stools in 24 hours, and then you can send these testing a sequential algorithm or a NAT alone or a stool toxin and a multiple step algorithm. You can do any one of these, but you've got to have these clinical issues, then you have to have the diagnostic algorithm or sequential steps to do it, and that's something is the way you want to do it to understand what's happening here. So moving on to CNS infection. When to perform CSF in critically ill patients with altered mental status has always been a difficult diagnosis. We tend to say if you want to do LPs, you go ahead and order it. If you don't want to do it. And then on top of it, do you order a biofilm on that? Biofilm array on that. So this is going to be a big problem. So again, diagnostic stewardship very clearly says that we need to restrict our PCR microarray testing for patients who have CSF pleocytosis. If not, if only there are 3 cells, all lymphocytes, please do not send a BioFire on the CSF. It's going to cost you 20,000 rupees. It's not going to give you a result. You're going to have false positives. You're going to end up a lot more treatment. So this is the diagnostic stewardship in CNS infection. So the recommendation from the IDSA is to strictly prohibit the use of microarray testing only with patients with abnormal CSF profile. You can occasionally miss it even when the CSF is normal, but then the chances are so slim that it's better to, rather than to overdiagnose things when there's no specific, and you're going to miss a pathogen which is generally has no treatment anyway, so why bother? A stewardship model for microarray PCR testing should require clinicians to, you have the CSF basic profile. What's the glucose? What's the protein? What's the cell count? Before you go ahead and order these tests. You don't write all these tests 1 to 10 and build up a cost and build up a false positive and lead to overdiagnosis. But unfortunately, yes, you have to understand this is for normal patients. If you have an immunosuppressed patient, if you have a patient with active malignancy, active chemotherapy, bone marrow transplant, liver transplant, it's a completely different ballgame. Then you need to understand that the PCRs maybe they might be picking up viruses and other things which maybe not be picked up by conventional tests. All right. The other thing we have been looking at is the role of diagnostic stewardship in the pandemics. We knew that early on when the number of RT-PCR kits were limited, we would only do on very high-risk patients and not do it on others. But once the test kits were available, we started asking the other right question, how often to do it? When does a test become false positive? So we've learned a lot from the diagnostic stewardship during COVID, when we had a limited resource and as well as when we have immense, easily available 500 rupees RT-PCR to guide us as to what is to be done. So the diagnostic stewardship generally is telling us that we not only have to understand how to send tests, how to interpret tests, but also when to send tests. That's the message that I'm coming through back and again, is that this is what we have learned. So what are the lessons that we have learned in the ICU from the diagnostic stewardship model in the diagnostic stewardship model in the an AMS program? So we know that stewardship programs have improved patient outcomes by integrating team members who are capable of interpreting the laboratory results like a microbiological data and using them to guide the timely decisions. You might say that what is the big deal? Every clinician worth his salt, every intensivist this should be a part of his repertoire. How can you be a good doctor if you can't integrate all the information that is available to you? But that's the unfortunate truth, is that we are not aware of most of us. If you were to even throw and say what is the phenotype of this of this bacteria, we might not be able to understand what is the best antimicrobial for that particular. So we really have understood in antimicrobial that we need people who are specialized in doing this, who understand these things to help the clinicians in helping it. And this is something which we want to extrapolate and say, do we need this in routine clinical practice also? We know that despite this being a very essential clinical skill, the rapid proliferation of microbiological tests have rendered that we need an additional layer of scrutiny, somebody who can sift through the data and provide the information to a busy practitioner who is running through 20-25 ICU beds with appropriate ideas so that we can get the antimicrobials in control. So these are the issues that we have learned, and we have understood that. Again, I'm sorry for that. This is jumping a little bit. I really have jumped for. All right. So what we are trying to say is that what we need is a diagnostic management team. So this has basically, in certain situations like interpreting ROTEMs and tags, this has been very useful in various UK hospitals where the work has shown that these things might help us in identifying especially thrombotic and bleeding reports, and we don't know how to interpret this. So these teams are able to identify, what are the various misinterpretation of the test that can happen, improve the clinician's safety, satisfaction, and accuracy of the clinician. So diagnostic management teams have been there for certain niche tests, and we now know that if we were to use this in all the, maybe we need to expand this horizon. We now have omics like pharmacogenomics, which is seeping into ICU care. I don't think any of us can interpret these things. So we would read nearly experts who only laboratory-based consultants who now move out of the laboratory and come to us in rounds and help us in solving these problems so that we can have appropriate drug selection and dosing. So that is what it is becoming, is more and more personalized by, I'm really sorry, why is this doing this again and again? Second. All right. All right. So the other thing that we have learned from the AMS, in which we can input it into our diagnostic stewardship practice in the ICU, is the how to report results. For example, should you withhold the antimicrobial sensitivity for antimicrobial bacterials which don't work? So like, why give a report of a tetracycline in a urine infection? So that this, let's not confuse the clinician. All of us good clinicians may be aware of it, but some clinicians who are not into this, a gastroenterologist or a busy cardiologist may not be aware of it. He's just looking at the report and reacting it. And the other way around is like for a family physician and looking at echocardiography, LA diameter doesn't make sense. So you have to give reports which are appropriate to the person who's going to receive the report. So again, we need to modify. So that is one of the things which we need to learn from the AMS, and how to report things when we are when we are reporting results. All right. So what it boils down to when we are looking at diagnostic stewardship in critical care medicine is these 5 things which I want to talk about. So you need to order the right test. That means is pre-analytic or analytic. So that means, for example, if you have a computerized order entry which will prohibit you from doing a C. diff if it was done 7 days ago, in the last 7 days, it's not going to let you repeat the test by mistake also. You're going to do a urine cultures only if pyuria is present. So like this, you have to order the right test for the patient, knowing that there are certain problems with the test if you do it in a situation when it's not mandated, when it's not required. The second thing would be to do a right for the right patient. That means, is there an appropriate indication, appropriate specimen types? For example, you will order a molecular testing for CMV only in an immunosuppressed patient, or only on the recommendation of an ID physician. We don't want to order a CMV on every BAL sample or every ET secretion that we want. We want to order direct immunofluorescence for pneumocystis only on specimens obtained from BAL, not in a sputum sample. So you need to know the correct indications for various diagnostic tests, various specimen tests. We are looking at the right time. That means, for example, point of care blood gas analyzer is added to the ICU whereby utilization is high and timeliness of results are critical. So that's why most of us have an ICU ABG in our unit. Looking at microarray PCR testing tested on blood cultures from ICU to evaluate genetic markers of antimicrobial resistance rather than waiting for the traditional sensitivity to happen. So the rapid turnaround can happen. So right timing is important. And the most important thing is to have a system where the laboratory notifies the on-call intensivist with positive microarray results. Come what may, 1 o'clock at night, 3 o'clock in the morning, whatever it is the time, the people we should be called for the results, and that's going to make a huge difference in the outcome of the patient. Fourth is the right interpretation. How do you select the test? How do you selectively report the results? For example, don't report candida. Don't send the report to a primary physician who's going to interfere or who's going to not be aware, or when say, why don't ask the intensivist, pressurize the intensivist to treat it. Don't do a urinary antigen for Legionella unless you're aware of the disclaimer that it's only going to be detecting a particular epidemic serotype of it. And the last is the right treatment. That means, what is the support system for the patient? That means a clinical pathologist or hematologist assists in, say, ordering blood products, how many FFPs to give, how many cryos to give. All these things can be done to do diagnostic stewardship. That means what you want is the right test for the right patient, for the right at the right time, for a right interpretation and for a right treatment. So these are the 5 tenets of diagnostic stewardship that I want to do. To be aware of and to implement this in not only in antimicrobial stewardship but in our daily activities of how we do tests in our this thing. So the aim has been to this, but the other big aim for stewardship team is it's not to act as a diagnostic safety team, but it does act. So we know that in antimicrobial stewardship acts reduces diagnostic errors. We call this as great catches. That I was rounding on a patient on finding out what bag, I realized that this is the double gram positive is going on. Let's stop this. Hey, there is a rash. This looks like strep typhus. So things like that happens. Great catches have positively influenced the patient's clinical trajectory whenever you do a multidisciplinary antimicrobial stewardship. And diagnostic errors were 12% of the great catches. That means you were not an infectious disease, or this was a very obvious infectious disease which could have been picked up just from a new set of eyes when people are looking at analyzing the data of what is happening. And many other such studies have shown the importance of a second set of eyes. And in a busy ICU, in a patient with multiple problems, second set of eyes from the primary open. So that's one of the beauties is when you have an open ICU, we intensivists act as a second set of eyes. And if we intensivists are part of this diagnostic stewardship, even one of our other colleagues acts as a third set of eyes to a primary physician who's trying to act. Some people might say, oh, this is going to create a lot of too many cooks spoil the broth, but no, it doesn't, because, and I'll show you why it doesn't do that in a bit. So these diagnostic steward safety teams are basically an additional diagnostic security. They don't interfere with your with the treatment plan. So the stewardship team's expanded role would need to consider the clinicians' fear that there will be overburdening, over-involvement, but such fears are unfounded. Typically what happens is, even when you know that your colleagues are good, we down on our own colleagues and we'll know that, with hardly too much of recommendations we have. We only have a recommendation, a few minority. And most often they are about stopping antibiotics rather than changing. And most of these are recommended by the treating physicians in majority of the scenarios. So that's something which we know that the stewardship team has been able to achieve, at least in the Western world, with good data. And we should also be able to do that in our situation. So, but unfortunately, we don't want the stewardship team, whether diagnostic stewardship part of AMS or separately, to provide diagnostic consultation. You're not another expert clinician here. You are looking at the data that's one of your clinician has already sent and just looking at it with a second set of eyes, whether it was appropriate, whether it's false positive, whether this was not, should be interpreted in the light that it should not have been sent, and so on and so forth. So this is an important concept that we need to be aware of. The most important thing is that we understand the fundamental aim of diagnostic stewardship that I've been talking about last 20 minutes is to do the 5 tenets, the right test, the right time, the right interpretation, and so on and so forth. But it is also the most important thing is the secondary benefits, that is reduction in false positives and cases of overdiagnosis and the related phenomena. So what is that? So overdiagnosis means identification of diseases or condition that would have remained undiscovered without causing any symptoms. For example, a small subsegmental PE discovered during routine CT scans for some other. Incidental diagnosis of slightly depressed LV function with no signs of inadequate cardiac output. Diagnosis of euthyroid sick syndrome in a patient without signs or symptoms attributed to thyrotoxicosis or severe hypothyroidism. So these are the overdiagnoses. These are some few examples, but there can be many such examples where there's overdiagnosis. There is going to be what is called as disease mongering, like rumor mongering. So expansion of the boundaries of illness or disease definition in ways that do not have a clear therapeutic implication, and that may actually result in patient harm. So that means diagnosing and treating all patients who screen positive for sepsis. That means has one hypothermia, one fever, or give them 30 ml per kilogram of fluid. No. So these are the issues of disease mongering. Over detection, identification of health concerns that may ultimately be relevant but are not germane to managing clinical illness. So yeah, you might find a pulmonary nodule, but it's not going to change an outcome of the patient in the ICU who's dying of septic shock from a cellulitis of his legs. So you really don't need to order a PET CT at that particular point in time to evaluate whether this lung nodule is malignant or is what it is and worry about it. What you're worried about is at that particular point in time. So this is called, you don't want to do over detection in this group of patients. The fourth is overutilization. So practices and tests that are considered reasonable in the provision of care, but that do not improve diagnostic accuracy, do not have clear treatment implication, or do not affect patient outcome. For example, doing troponins every 2 hours in people who have a low reason for, or whom you're not going to do an invasive angiography. So why do a 2-hourly troponins? What's going to achieve? So these are the 4 concepts of overdiagnosis, disease mongering, over-detection and over-utilization, which can also be prevented with a good diagnostic stewardship program. So the solutions to over-diagnosis problems is just not because some people are unscrupulous and we all are here to make money and so on and so, or we are just overzealous where we want the best for our patients. You have to understand the intersecting causes. Basically, it's the interaction of the individual, the interpersonal, the environmental and organizational factors, which leads to an overdiagnosis or these kind of situation that we are talking about. So on an individual level, patient and clinicians are susceptible to cognitive biases that will affect your medical decisions. So most of us would always, whatever, if I'm a pulmonologist, I feel bronchoscopy is the best thing for every patient. If I'm a sleep physician, I believe everybody should get a sleep test. We believe on the advantages of the procedures that we do are more than the negative, and we underestimate the harms. So that colors our mind, and we should be aware of it when we make a diagnosis. Again, the culture of healthcare with the legal burden is that we need to be sure of a diagnosis before we do anything. So, we don't tend to open up an abdomen with the positive peritoneal signs unless we have a CT. So there is going to be a lot of prioritizing diagnostic certainty, which is going to happen here, which is going to drive overuse and things like that. The concepts where diagnostic stewardship is still not clear is the hot topic in ICU, which is subphenotyping. You heard through yesterday, and we're going to hear to tomorrow, is the concept of subphenotyping, and ARDS, sepsis, everything is being subphenotyped now. We already know direct versus indirect for many years, but now you have much better subphenotypes in ARDS and sepsis. So what is the diagnostic profile, and how are we going to have these genetic mark signatures, and how should we use the lens of diagnostic stewardship to use the subphenotyping? So for example, can I find out the best patient on whom we should use stress dose steroids in septic shock as compared to others? So there is this is where a lot of research is going to happen as far as quality improvement measures are concerned. So diagnostic stewardship and subphenotyping is something which you're going to be hearing a lot in the next few years to come. All right, so I think I have covered a very, very different topic than what normally conventionally we would be covering in one of these meetings. I'm going to summarize by saying that appropriate use of diagnostic stewardship, appropriate use of blood cultures. For you have to follow the IDSA guidelines. You have to have a high pre-test probability and proper specimen collection. And blood cultures should be obtained peripherally, not from the central line. Urine culture should be obtained in the presence of symptoms and pyuria, and not otherwise. So this is how the culture collection and how the stewardship in diagnostic in ID has an important role to play in diagnostic stewardship in the ICU also. Similarly, in C. diff, 2 cases of C. diff from false positive cases. Again, the algorithm that I showed you are helpful. The IDSA recommends what is called as electronic ordering guidance or cascade testing and clinician education for C. diff. We also, I'm sorry about that once again. We also, wait a minute. Alrighty, so let me just, what happened here? It won't let me read the summary. Alrighty, so I don't think I'll be able to read the last 2 slides, the summary slides. It's what it looks like. Let me just go back here. I don't know, this is sometimes a problem. But anyway, so the last few summary slides would just, what I would like to, let me see this. Yeah, I deleted it. But the summary, last one point on the summary slide was the fact that the 5 tenets of diagnostic, the 5 tenets of diagnostic stewardship are the right time, the right patient, the right intervention, the right therapeutics is what we want to do in this group of patients. And the main secondary benefit of diagnostic stewardship is to prevent the harm of overdiagnosis and over treatment that we are leading to in our patient. Thank you very much for your kind attention. I'm sorry for a little bit of slides that continue to jiggle and do whatever they want to, but I hope that I was able to, in my brief 25-30 minute talk, tell you about this concept of diagnostic stewardship outside of the antimicrobial stewardship. You would have heard diagnostic stewardship in that particular thing. What I wanted the audience to was to think about the fact that when we order a test, when we look, we need to not only know how well to do the test, how to interpret the test, but then to ask the important question, should I send the test? And that is the message that I really wanted to get across, is that should I send the test? If I know that I don't need to send the test, I shouldn't be doing it. And then subsequently, the interpretation has its own false positive and false negatives. So the 5 tenets are something which I hope I was able to convey. Thank you very much for your kind attention, and hope you have a wonderful conference through the rest remaining day and a half. Thank you very much.
Thank you, Suresh sir. for such a wonderful information about the diagnostic stewardship. We have one question from the delegates for Dr. Suresh. Are you available, sir?
Yeah, I'm available.
Yes, sir. So the thing is, as you mentioned, as a part of routine workup for the CSF analysis, many times if patient comes to the ICU with altered sensorium, we generally think, okay, let's take a sample at the same time we send for the PCR technique, biofire technique. As you told, that better to wait for the first primary analysis. If there are abnormal cells, then only. So are we supposed to subject the patient twice for the LP?
No, you keep it in the refrigerator. You don't need to subject the patient to this thing. You have a sample, and cell counts can be done within an hour in most of the institution, even in a government setup. If you're in a government medical college, you will do it yourself, the cell count when you get out of the unit. So it's not a problem. So I think once that thing is there, then running it is much better, because the amount of false positives that we do pick up is amazing. So what we would say is that you will not know what to react if you find a enterovirus or a CMV. Would you treat it with ganciclovir in an immunosuppressed host with something like that? And you're spending 20,000 rupees when the CSF cell count is 3 and there is no obvious infection. So that is why the importance is, if you're not going to react to a test, then don't send the test. And you should not react to a CSF viral panel in an immunocompetent host if there is no pleocytosis. There is no data to say that it's going to be. Yes, you might have a 1 in a million, but then we are not here to treat 1 in a million. We are here to make sense of what is normal in a 99% of the scenarios.
Okay. Sir, another question for you from the delegate. In case source is unknown, what is your view in sending CUE and look for the pyuria, then sending culture sensitivity? By then, patient will be already receiving any antibiotic. So.
Correct. So I think the whole idea is that you have to, this is why it's a part of the infectious disease syndromes and is part of the antimicrobial stewardship. So yes, you cannot, wait for this thing. So in the US now, we call it what is called as a reflex culture. That means you send a urine REN culture. It is the discretion of the lab to run the culture only if there is pyuria. And you can start the antibiotics as once you have sent it. And if you have sent it and there's urine, no pyuria, then the lab is not running a culture. Then you are forced to look for alternate sites or to de-escalate the antibiotics and look for other sources of infection. Urine may not be the source of infection. Patient may still have infection. You might have started some broad spectrum antibiotics, say meropenem in a hospitalized patient. It is not the urine. That's what it tells you. You might have a C. diff. You might have an abscess somewhere. You might have a decubitus ulcer which is infected. You might have a pneumonia. So it makes you start thinking about other sources and make you think of other things. So it's very important to understand that it's part of the entire spectrum of the antimicrobial stewardship and not just doing urine REN culture.
Thank you. Thank you, sir. Moving forward, we have the next session about how to identify the best hemodynamic tools. And the speaker is Dr. Jiggy Davatia. Sir, over to you.
Thank you for inviting me to speak at HICS 2023, and I will be speaking on how to identify the best hemodynamic tool. Now, the key points would be to identify the right patient for monitoring at the right time, to determine the parameters, hemodynamic parameters of interest, which would preferably be linked to a therapeutic strategy. We must then understand the principles and limitations of the technology and the equipment that we will be using. And of course, we need to use tools and techniques based on the available expertise, experience, and facilities in the intensive care unit. And we must consider economic cost, the cost of the equipment, the cost of the consumables, and also the consequences and the potential complications associated with these monitoring devices and techniques, right? So, let's start with defining shock. And we know it is a life-threatening generalized maldistribution of blood flow, which results in failure to deliver or utilize oxygen to the tissues. And that leads to tissue dysoxia or hypoxia to the tissues. And although hypotension is probably the commonest manifestation of shock, you can have shock even in the absence of hypotension. And that is characterized by organ hypoperfusion, which leads to organ dysfunction. So hypotension is extremely important, but it is not always present in patient with shock. And the key is to detect organ hypoperfusion and some marker of organ hypoperfusion. So we all know that the blood pressure is actually the mean arterial pressure depends on the cardiac output and the vascular resistance. And the cardiac output is determined by the preload, contractility, the afterload, and the heart rate, right? And if you want to optimize the cardiac output, if it is low, then you need to increase the preload. And the common way of improving the preload is by giving fluids. We can then alter or increase the contractility by giving inotropes, and the afterload or the vascular tone can be controlled by giving vasopressors, and that will increase the systemic vascular resistance and therefore the mean arterial pressure. Now, to measure the mean arterial pressure, we should have in a sick patient an arterial line. An invasive arterial pressure monitoring is extremely cost effective, it is extremely safe, it is inexpensive, and you get a continuous display of the mean systolic and diastolic blood pressures. And the mean blood pressure, the mean arterial pressure, is a very important physiological entity because the organs auto-regulate at a mean arterial pressure of about 60 to 120, and therefore many recommendations suggest that the initial target for blood pressure in a patient with shock should be a map of 65 to 70, right? Looking at the arterial waveform, eyeballing the arterial waveform also gives us very important information about the cardiovascular system, and we'll talk more about this later in the presentation. So the mean arterial pressure is extremely important, and initial target should be about 65. And then, of course, you can alter that target depending on the response of the patient to treatment and individualize the blood pressure that may be required for optimum perfusion of the organs in that patient. Now, looking at the arterial waveform, eyeballing the arterial waveform gives you extremely important information. If there is variation of the systolic pressure with mechanical ventilation, the patient is likely to be fluid responsive. The slope of the upstroke, if it's sharp, it suggests that the contractility is good. If it's a slow, sluggish upstroke, it suggests that the contractility is poor. The area under the ejection phase suggests what gives you some indication of the stroke volume. A low dicrotic notch suggests that the systemic vascular resistance is low. On the other hand, if it is high, it implies that the vascular resistance is extremely high. And also the slope of the descent will also give you some indication about the systemic vascular resistance. And many of these parameters are actually looked at in advanced monitoring by many of these monitors to give you actual numbers to some of these parameters. But just eyeballing will give you so much information about the cardiovascular system. So the arterial line is probably the number one monitor that you must have in a sick patient. Now, when we give fluids to the patient, we obviously want to restore organ perfusion and correct the hypotension. We also want to avoid the effects of fluid overload. And therefore, the key questions that we are asking is, one is, should I start infusing fluid? But probably a more important question is, will fluid loading increase the cardiac output? Because we are increasing the preload with fluid so as to increase the cardiac output. So maybe the real question we are asking is, will cardiac output increase with fluid loading? And then we need to ask the questions, how much fluid should we give? And very importantly, when should I stop giving fluid? Right? So these are the questions which hemodynamic monitoring will help you to answer in some critically ill patients. Now, the preload, is the important because as per this Frank-Starling law of the heart, an increase in preload will increase the stroke volume and cardiac output. So what is the preload? Now, in the animal experiments that we did in first MBBS, it was a stretch of the muscle. So it was a length of the muscle before it started contracting. But in the intact heart, it is the left ventricular end diastolic volume for the left ventricle. Now, we are not very good at measuring volumes. So we often measure the pressure in the chamber as a surrogate for the volume or the preload of the chamber. And in the right heart, it is the central venous pressure, the CVP. And in the left heart, it is the pulmonary artery occlusion pressure, or the pulmonary capillary wedge pressure, which you have to insert a pulmonary artery catheter. And these two give you an indicator of the preload, this of the left heart and the CVP of the right heart, but we often consider it to the preload of the left heart as well. Now, the pulmonary artery occlusion pressure is a very important pressure, unfortunately needs insertion of a pulmonary artery catheter, and it is based on several assumptions. I mean, there are several physiological assumptions that we make which we must understand if we have to interpret the pulmonary artery occlusion pressure. The first is that when we are using the pressure as a surrogate for the volume, we assume that the compliance is normal and linear. When we say that the left atrial pressure is equal to the left ventricular end diastolic pressure, we say that the left ventricular end diastolic pressure now being the preload of the left heart, we assume that the mitral valve is normal. And when we say that the pulmonary artery occlusion pressure is equivalent to the pulmonary artery diastolic pressure, we assume that the pulmonary vascular resistance is normal. And in fact, the wider the gap between the pulmonary artery occlusion pressure and the pulmonary artery diastolic pressure suggests that the pulmonary vascular resistance is increased. And when we say the CVP is equivalent to the LAP, we are assuming the right and left heart are functioning in a similar fashion. And that is sometimes a quantum leap of faith, but we use this assumption almost every day in our practice. So the pulmonary artery catheter is a very important catheter. We don't use it much nowadays. It's not largely been discarded, but even today it remains the only monitor which can measure continuously the pulmonary artery pressure. Now, when we use the CVP or the pulmonary artery occlusion pressure as a measure of the preload, we assume it, it reflects the intravascular volume status. However, it is affected by many things, including the venous tone, the compliance of the ventricle, myocardial contractility. So if the contractility is poor for the same volume, the CVP or the wedge pressure will be higher. It's affected by the afterload. And very importantly, in the ICU, it is altered by pressures which are outside the heart, especially the pericardial pressure and the pleural pressure in mechanically ventilated patients by positive pressure ventilation and positive and expiratory pressure. Okay, it is also affected by the intra-abdominal pressure and the thoracic and chest wall compliance. So there are many things which can alter or confound the measurement of a CVP and the interpretation of the CVP as an index of preload. And, so for example, if the patient is hypovolemic but has a pneumothorax, the CVP may be normal because the two forces will sort of counteract each other. And therefore, the single value of the central venous pressure or the pulmonary arterial pressure is almost of no value. The CVP must only be interpreted in the context of a fluid challenge, the response of the CVP to fluid, right? So if CVP is the only monitor that you have, please use it only in the context of fluid challenge. Do not place importance on any one single number of the CVP. So for example, you've got this patient who's got hypotension, tachycardia and a low urine output, right? And a CVP of 14. Now you should give a fluid challenge. A CVP of 14 may make you think, oh my God, it seems to be high, but you probably might think this patient may need a bit of fluid. He's already on a ventilator. Maybe that's confounding my measurement of CVP. Okay. So you should give a fluid challenge, which would be a crystalloid. You should give it at a rapid rate, which will stress the circulation and can produce a physiological effect. So you give, say, 250 mils of normal saline over 10 to 15 minutes, and you set a target heart rate. I'm sorry, this should be, a target should be a mean arterial pressure of more than 70. You can just set it, and a heart rate of less than 110. And you also set a danger limit, which is where the CVP is useful. A CVP, say, for example, more than 18. So these are your targets, and these are your danger limits. So if you give this fluid, then you see what happens to the map. If the map and the heart rate are not improved to meet your target, your target is not achieved, and your danger limit has not been crossed, then you continue to give fluid. If you've reached your therapeutic target, although you've not crossed your danger limit, because you've reached your therapeutic target, you stop giving fluid. And if you've not reached the therapeutic target, but you exceeded your danger limit, then again, you should stop giving fluid. So this is how you will use the fluid challenge in deciding whether to give or continue or stop giving fluid. So when we are giving a fluid challenge, we have to first give the fluid and then see what happens. But ideally, you should come to know even before you give fluid whether or not there's going to be an effect. So you should then be giving fluid, of course, when there is hemodynamic compromise, but only when patients are fluid responsive, if you know or if you can predict whether or not giving fluid is going to increase the cardiac output. And you should give fluids when there is little or no risk of giving fluid. So now, when we said we're going to look at the preload, we're looking at the CVP as an index of preload, but preload is not the same as preload responsiveness or fluid responsiveness, which is the property by which giving fluid will increase the cardiac output. So if you say in this patient, on this patient's Frank-Starling curve, if you increase the preload from here to here by giving fluid, there is a significant increase in stroke volume and the patient is fluid responsive. On the other hand, if the patient is in the flat part of the Frank-Starling curve here, increasing the preload to the same extent produces a negligible increase in stroke volume. So giving fluid will increase the stroke volume only if the patient is on the steep part of the curve and not if the patient is on the flat part of the curve. The CVP or the wedge pressure do not predict fluid responsiveness. So these are patients who responded by increasing the stroke volume. These are patients who did not increase the stroke volume after giving fluid. And you can see the CVP values are exactly identically distributed in both responders and non-responders. Therefore, CVP cannot be used to predict fluid responsiveness, and these are called static parameters. What you need are dynamic indices of preload responsiveness, and these are those which help you predict beforehand whether or not the stroke volume is going to increase after giving fluid. And these depend on heart-lung interactions in patients who are mechanically ventilated. So these patients need to be mechanically ventilated. And these include respiratory variation of stroke volume with of the stroke volume or the systolic pressure variation, pulse pressure variation or the stroke volume variation, right? And also the IVC diameter changes in aortic flow velocity changes and a test called the end expiratory occlusion test, and a tidal volume challenge. So these are the tests which use heart-lung interactions to predict fluid responsiveness. Or you can have another test, which is a preload challenge, the passive leg raising test. Okay. So essentially, if the stroke volume varies, right, with preload, during mechanical ventilation, with inspiration and expiration, it suggests the patient on a steep part of the curve. If there is no change in stroke volume when the patient is on the flat part of the curve, his patient is not fluid responsive. So the pulse pressure variation and the stroke volume variation are two parameters which are captured by many of our monitors. The pulse pressure variation, less than more than 13%, suggests the patient is fluid responsive. For stroke volume variation, you need a continuous cardiac output monitor, which will calculate the stroke volume and give on a beat-to-beat basis, and therefore you'll get the stroke volume variation. The pulse pressure variation is extremely useful because it does not require cardiac output monitoring. Any multi-para monitor connected to an arterial line will be able to give you the stroke volume, the pulse pressure variation. The problem with many of these, with all these parameters, is that they require the patient to be mechanically ventilated with no spontaneous ventilation. Okay, and they are also not suitable when there's arrhythmia like atrial fibrillation or if the patient is severely vasoconstricted. And very importantly, these are validated only when the tidal volume has been 8 mils per kilo predicted body weight or higher. So when unfortunately, in most sick patients in the ICU, we use lower tidal volumes. We use 6 mils per kilo ideal body weight or lower tidal volume. And therefore, these cutoffs of a PPV of 13% or a stroke volume variation of 10% are not valid in patients ventilated with a low tidal volume ventilation. And therefore, in order to overcome that limitation of low tidal volume ventilation, we have proposed and we have designed this test called the tidal volume challenge test. Okay, so here what you do is you see the pulse pressure variation and stroke volume variation when the patient is ventilated at 6 mils per kilo tidal volume, and then for 1 minute you give a tidal volume challenge, which is to increase the tidal volume from 6 mils to 8 mils per kilo. Right, at 8 mils per kilo you'll get an increase in the pulse pressure and the stroke volume variation because of the increase in tidal volume. And what you should then measure is the change or the increase in pulse pressure variation when you move from 6 mils per kilo to 8 mils per kilo. And we showed that the change in tidal volume when you move, in pulse pressure variation, when you move from 6 mils per kilo to 8 mils per kilo, best predicted fluid responsiveness, and the cutoff value was 3.5. So when you increase your tidal volume from 6 mils to 8 mils per kilo, if the increase in pulse pressure variation is more than 3.5, then it suggests that the patient is fluid responsive. And this helps unmask fluid responsiveness in patients who are ventilated with low tidal volume. And this has been validated in many other tests and in many other series now. Now, the other way of doing it is to do a passive leg raising test, which sort of pushes back the fluid from the legs into the lower part of the body into the central compartment, and that increases the cardiac output. For this, you do require a rapid response cardiac output measurement device, like for example, aortic flow velocity or PICO. But So you do need continuous cardiac output monitoring, ideally. If you do not have continuous cardiac output monitoring, you could look at the pulse pressure or the pulse pressure variation, the change in pulse pressure, and that could give you some indication, but it's not as good as looking at the cardiac output. Okay, so the pulse, the passive leg raising is also a very valuable test because it's endogenous, it's completely reversible. You don't actually give any fluid. You put the legs back down if the patient is having a problem. You can use it in spontaneously breathing patients, which is a big limitation of the heart-lung interaction-based tests. It can be used in the presence of arrhythmias. And like I mentioned, you ideally need a real-time cardiac output assessment device. The end expiratory occlusion test has also been described, and you give an end expiratory occlusion, which will result in an increase in the venous return and therefore the stroke volume. But again, the increase in cardiac index is only 5%, and therefore you need very accurate and rapid response measurement of cardiac output to detect this change, right? So again, it's something which requires continuous cardiac output monitoring. We commonly use the IVC diameter changes during mechanical ventilation to predict fluid responsiveness. These are subject to the same limitations of tidal volume as the other indices. Another parameter which we can think of is, will fluid loading increase the blood pressure, right? And that is called the dynamic arterial elastance. Preload responsiveness or fluid responsiveness tells you whether the cardiac output will increase. Dynamic arterial elastance will tell you whether the blood pressure will increase when you give fluid. And if this is a ratio of the pulse pressure variation to the stroke volume variation, and if it is more than 1.2, it suggests that the mean arterial pressure will increase if you give fluid. Okay. Now we've given the fluid, we increase the preload. What we also need to do is optimize the contractility and therefore the cardiac output, right? So we need to know whether the cardiac output has increased, and along with cardiac output, we should measure the other oxygen determinants of oxygen delivery, and these include the hemoglobin and the oxygen saturation. So with all these three, you have a measure index. You can actually calculate the oxygen delivery to the tissues, right? So cardiac output monitoring may be very useful. And how do you look at cardiac output? You can look at the heart by echocardiography. You can see whether it's pumping well, but you can also measure the cardiac output, of course, by echocardiography, but in the ICU, traditionally, it used to be measured with the pulmonary artery catheter using the thermodilution principle and analysis of the thermodilution curve. But now we have a new generation of cardiac output monitors, which can actually almost continuously measure the cardiac output without the need for a pulmonary artery catheter, with an arterial line and maybe with a central venous line. And we'll talk about the PICO, LITCO, and the flow track sort of systems, because these are commonly used in the ICU. So the PICO requires a central venous line and a arterial line in the femoral artery. Okay, so it's not as invasive with a pulmonary artery catheter, but still requires femoral arterial and central venous cannulation. Now, using the arterial waveform, it can, on a beat-to-beat basis, it can calculate the stroke volume and therefore the cardiac output. And very interestingly, this beat-to-beat cardiac output, which it derives using this sort of formula and algorithm, is calibrated by a thermodilution done by injecting cold solution into the central line and picked up by the femoral artery catheter. So it's a transpulmonary thermodilution which happens. So the cold fluid travels down the heart, lungs, back to the left side of the heart and into the aorta, and which is picked up over here. So it traverses that entire path, and that thermodilution cardiac output is used to calibrate the beat-to-beat stroke volume. So it requires calibration. On the other hand, you've got a device such as the flow track, which does not require calibration. It uses a principle that the stroke volume is proportionate to the pulse pressure, which is calculated in this, derived in this system as a standard deviation of blood pressure along thousands of points along the arterial waveform, right? And then it sort of puts that data and patient's sex, age, and the pulse pressure into an algorithm derived from a large database to calculate the cardiac output or the stroke volume. So this does not require calibration, but the accuracy, of course, depends on the validity of the algorithm and the size and the values in the database. See, but this is something which is very commonly used. Irrespective of which method you use to measure cardiac output, there are limitations. It cannot determine flow to individual organs. And what is more important is whether that cardiac output, even if it is high, whether it is adequate for the tissue's needs at that point in time. And of course, if there's maldistribution of flow as occurs in sepsis, then that even a high cardiac output probably is not very significant, right? Now, when you have a device like the PICO, like we said, it does a trans-pulmonary thermodilution. It goes through so many compartments of the heart and the lungs. You get a thermodilution curve, and sophisticated analysis of these curves helps you determine many other parameters of interest. For example, one parameter which is derived is the global end diastolic volume index, which is actually equivalent to the amount of blood in all the 4 chambers of the heart, and that is like the preload of the heart, the entire heart. Right? You also get a very interesting parameter called extravascular lung water, which is a determinant of pulmonary edema, and therefore, using the PICO system, you get lots of parameters, including the global end diastolic volume index, which is index of preload, the extravascular lung water, which is index of overload, and the pulmonary vascular permeability index. If it is high, it suggests that it's a non-cardiogenic pulmonary edema. So lots of interesting numbers that come up with the PICO. So at the end of the day, if you've got continuous cardiac output monitoring, A, you can predict fluid responsiveness, and B, after you give fluid, you can check whether or not the cardiac output has increased. Now, so far we've focused on optimizing cardiac output by giving fluids, vasopressors, inotropes, and so on, getting the blood pressure right and all these things. But sometimes, in spite of these sort of things, the patient doesn't get better. Because what we have missed out so far is assessment of organ perfusion. We need to assess whether the patient is getting better and whether the tissues are getting perfused with all our interventions. And it is extremely important to monitor tissue perfusion. And there we've got, you can look at the skin. And if your skin is cold, clammy, it suggests you're not doing well. If a capillary refill time, a very, very important tool, it suggests, if it's more than 3 seconds, it tells you that the circulation is sluggish. So mottling of the skin is a very important sign. This should actually get better when you start resuscitating. You can even have an index or a mottling score. The capillary refill time, very simple, very easy to do. And, it's now been well studied. So you can actually look at capillary refill time, and it should start improving as you resuscitate the patient. Now, we can look at shock as a condition where there's an imbalance between oxygen supply and oxygen demand. Either the supply is low, the delivery is low, or the demand is high, or the consumption is high, or both, right? And we've all focused on all these factors which control the oxygen delivery, but we also may need to do something to reduce the oxygen demand. And at the end of the day, we need to measure or decide whether or not the oxygen delivery is adequate for the needs of tissues. So we need to see the balance between oxygen supply and oxygen consumption. And there are some tests which do this, and these are what we call as a downstream sort of tests or downstream parameters. Now, all these parameters, which like the blood pressure, the cardiac output, the hemoglobin, they are all interventions which take place before the blood reaches the tissues. What we need to do is see what is the quality of the blood that has left the tissues, which will give us some idea of the tissue perfusion, tissue oxygenation. And these are the oxygen, central venous, the mixed venous oxygen saturation in the pulmonary artery, the central venous oxygen saturation in the superior vena cava. And recently we described the veno-arterial CO2 gradient. So these tell you something about what is happening at the tissue level, right? Now, the mixed venous oxygen saturation in the pulmonary artery is very important, because if the tissues are extracting more oxygen, either because they've got less delivery or because they are consuming it very rapidly, the returning venous blood will have less oxygen. So normally the central venous oxygen saturation, or the mixed venous, should be 75%. And the lower and lower the mixed venous saturation goes down, the worse is the imbalance between oxygen delivery and oxygen consumption. But this requires insertion of pulmonary artery catheter. And therefore, in order to overcome this limitation, we use a central venous oxygen saturation, or SCVO2. And although it's the superior vena cava distribution blood, it still changes in the SCVO2 track are parallel to the changes in the SVO2. And therefore, we can use, and we do use, the central venous oxygen saturation as a surrogate for the SVO2. And a SCVO2 of 70% suggests, okay, everything is okay. Lower the SCVO2, the worse is the patient's problem. The other important tool is the lactate level, and the increasing lactate suggests anaerobic metabolism in most sort of situations. It suggests anaerobic metabolism, and even the surviving sepsis guidelines suggest that you should use the decrease in serum lactate as a marker of efficient resuscitation. very interestingly, the capillary refill time is also an excellent marker of tissue perfusion. And especially from the recent Andromeda shock study, we have seen that in some ways the capillary refill time, it tracks resuscitation better than lactate. So, for example, the response of capillary refill time to fluid resuscitation is much faster than that of lactate. In other words, you give fluid, you'll see the capillary refill time improving rapidly if it is, because the lactate will take some more time to change. And of course, capillary refill time doesn't require any equipment. It's so completely inexpensive and very fast dynamics of recovery. So it's an extremely important tool, which we've been using it clinically, but we now have data to show that, it's been scientifically studied and shown that it is actually a very good marker of tissue perfusion and the response to fluid resuscitation. So at the end of the day, you have to integrate all these findings. So we need to monitor blood pressure to see what's happening to the blood pressure. We also need to see, optimize our preload, and not just preload, we need to see it fluid responsiveness, right? So to decide whether to give fluids. Then you optimize the cardiac output and other oxygen delivery variables. And at the end of the day, we should be able to determine whether or not this optimization is actually helping tissue perfusion by looking at the downstream parameters like the SCVO2 or the lactate or the tissue perfusion by looking at the capillary refill time. Please remember, if you want to look at the right side of the heart, the pulmonary artery catheter is the only tool which continuously measures the pulmonary artery pressure. And of course, there must be a clinical improvement in the patient. What sort of equipment should you use? Because many different monitors do the same thing. So which sort of things you could try? One important consideration would be invasiveness. And of course, the pulmonary artery catheter is the most invasive. The next in line would be equipment which use the arterial and central lines like the PICO, right? Or something like a flow track which only uses an existing arterial line is less invasive, right? And the others are not used so much in the ICU as in the operation theater, but then these are they just require esophageal probes to be put in, or nothing at all. Ease of setup is again something which might be a consideration. The PAC, of course, requires a lot of expertise, experience, and of course, it's most invasive and the most complications, especially like a pulmonary infarct, can occur with this sort of thing. With the PICO versus the flow track, like these are two sort of semi-invasive tools that we have. The PICO is slightly more invasive because it requires a central line. This flow track does not. Flow track doesn't require much experience except that of putting the arterial line in. And because this also requires central line, the flow track setup is faster, less complications. X-ray probably required to look at the central line and all these sort of things. So, however, you also need to see what information you're getting out of the monitor, right? So the pulmonary artery pressure, like I said, is the only one that tells you the pulmonary artery pressure. All of them give you some idea of the preload, but not the flow track. It does not give you any idea of preload. The PICO gives you the global end diastolic volume index. The pulmonary artery catheter has no index of fluid responsiveness, but these two give you some indices of fluid responsiveness. These are extremely useful. All give you some index of contractility or the stroke volume or the measurement of stroke volume. Only the PICO gives you extravascular lung water. Okay. And all give you a calculated SVR where you have to feed in the CVP and the mean arterial pressure and cardiac output are taken from the monitor. Okay, so these are the sort of considerations which you will take into account as to what monitor you want to apply, but that will depend on what parameters you want to monitor. So at the end of the day, there are going to be lots and lots of things which you are going to be able to measure and monitor. For example, even the microcirculation or the regional circulation can be looked at. There are many things which we don't know about, right? Which may have been important and which we are missing out on looking at. So at the end of the day, this is the conundrum of hemodynamic monitoring: is not everything that counts can be counted, and not everything that can be counted counts. So that's the problem that we are left with even today. So thank you very much for listening, and I'll be happy to answer any questions. And thank you once again for the invitation.
Thank you, Dr. Jigidevajaya, sir. One question from the delegates. If the IC is not equipped with the flow track kind of devices, what should be the best tool for the fluid responsiveness?
So you can use if you have an arterial line,
you use the pulse pressure variation if the patient is mechanically ventilated. So that is all that you need. You need a multi-para monitor. And if it's not enabled, you just need to enable that parameter in the multi-para monitor and connect it to your arterial line. And then if your patient is ventilated, is on a ventilator, then you look at the pulse pressure variation. If he's on low tidal volume, you will give the tidal volume challenge. You can also do, so that's about it. You can do passive leg raising and look at the increase in pulse pressure, but that is not as accurate as when you measure the cardiac output directly. But if you don't have cardiac output monitoring with like flow track, you can do a passive leg raise and look at the increase in pulse pressure.
Okay. Right.
And of course, your IVC diameter and all that you can do in ventilated patients.
Okay. Thank you. Thank you, sir, for your information about best hemodynamic tools in the ICU. Moving forward to the next session, we will have a two next unplugged session, and I'll invite Dr. Yash Javeri for his view on extracorporeal organ support. Over to you, sir. Dr. Yash Javeri, sir.
Hello, everyone. I'm going to present my views on multi-organ support therapy in ICU. At the onset, I'd like to thank Dr. Srinivas, Dr. Ghanshyam, and the HICS team for the 8th edition invitation. No conflict of interest. The views expressed are my own, no financial or ethical conflict of interest. To set the ball rolling, we must understand why do we need organ support in ICU and what is the need for multi-organ support therapy. Organ dysfunction is common in ICU. Multi-organ dysfunction is central to many of the pathologies in ICU. We understand that organ failure is time function. So earlier we intervene, better are the outcomes. The aim of intensive care in terms of organ failure is threesome. First is to support the failing organs, give them time to regenerate. How do we do that? By supporting the failing organs. We avoid the new organ dysfunctions, we avoid AKI, we avoid hemodynamics perturbations, we tend to avoid new organ dysfunction in terms of liver dysfunction and other organs. And we also help the organs to regenerate by giving them good homeostasis. So organ failure is important and organ support is equally important. And we understand organ behavior is time function. So whenever an organ is dysfunctional, we need to provide the support at the earliest and give a milieu which is conducive for organ regeneration. Intensive care is basically supporting till the time the organ regenerates and starts doing its own. ICU care is like attaining homeostasis. Multi-organ support therapy helps attain homeostasis in terms of metabolic homeostasis, immunohomeostasis, if we talk about sepsis and many other diseases in ICU, electrolyte homeostasis, thermal homeostasis, and many other things. Multi-organ dysfunction is the leading cause of mortality in critical ill patients. Huge expenditure, huge cost, and increased length of stay. Since the probability of death is directly correlated with the number of failing organs. Beyond the kidney and the degree of physiological derailment, a clinical sensible approach is to broaden the spectrum of physiological endpoints targeted by these multi-organ support therapy. Most of it is extracorporeal therapy. Going on to blood first. Blood is the vital element that regulates all body systems for cellular to organ level. All crosstalks happen through blood. So CRRT has direct access to blood and thus to all other organ systems. The evolution of CRRT from single replacement, renal replacement to multi-organ support therapy is logical and should be the goal of extracorporeal blood purification and support techniques in the ICU. My talk will explain why most represents the most logical, future, conceptual and practical evolution of CRRT and other extracorporeal therapy. Illustrating the biological rationale, we'll discuss about some clinical evidence, whatever we have, and how to make it better and easy. So multiple organ support therapy is must. We all understand the clinical rationale. A hemofilter can perform RRT supporting one organ. while a more complex extracorporeal support system with a multitasking machine platform and additional devices could perform most. The common ground for this approach is modulation of the composition of blood, thermal, metabolic, electrolyte, immune homeostasis, whatever we call it. Thus, the final effect would be the reduction in physiological disorders derived from multiple organ failure, and at the same time, a return to the internal milieu, facilitating the recovery of organ functions. Is it easy to apply? The answer is no. When we talk about multi-organ support therapy, we look at many things. Blood purification and renal support most common, temperature control, acid-base control, fluid balance control, cardiac support, protective lung support, brain protection, bone marrow protection, blood detoxification, liver support, therapy for sepsis, immunomodulation, and endothelial support. If we talk about AKI, it is a well-established entity. We are not going to discuss anything new, or we are not going to dwell much into it. Blood purification, renal support, extracorporeal therapies have traditionally been used to replace lost renal function in AKI. This is definitely the most common use of CRRT in the ICU. In the last, say, 20 years, evidence has accumulated to support the concept that CRRT is efficient, safe, and well tolerated. Now, progress from arteriovenous circulation to veno-venous pump systems have further improved efficiencies, biocompatibility has improved, the circuits have improved, the safety has improved hugely. Now, disregarding for a moment the concept that dose and outcome are correlated, the end result of an efficient therapy such as CRRT is blood purification, which is similar to that obtained by the native kidney. This is a huge statement. Thermal energy balance can also be achieved if the receiver hyperthermia or hypothermia. The extracorporeal circulation can be a potent modulator of body temperature and overall thermal balance. So this can modulate the disease response, especially if we talk about severe traumatic brain injury, severe hyperpyrexia for any cause, hypothermia which has to be reversed, hyperthermia which has to be corrected. So CVVH and CVVHD is generally used for these techniques. They are dedicated cannulas which are available. So this thermal homeostasis contribute to modulate the immune and inflammatory response as well as the oxygen demand in the central organs, with the possibility of using such a mechanism for specific clinical target. The evidence is vague for most of it, but at least thermal homeostasis can be achieved. Next is homeostatic equilibrium. When disorders are life-threatening, the electrolytes or metabolic, or refractory to medical corrections, extracorporeal therapy becomes the treatment of choice. A final solute and electrolyte balance can be achieved according to the desired goals and according to a desired rate. The advantage of such a system in comparison to the use of diuretics, say for hyponatremia, is the possibility of disassociating the removal of water from that of sodium or other electrolytes. Because of the slow and gentle rate of fluid exchange, the treated blood operates in continuous equilibrium with the peripheral tissues, and the entire human body benefits from a rapid and effective restoration of water, sodium, and other electrolyte homeostasis. So this restoration of homeostasis is particularly true for acid-base control, as admission of bicarb can easily be titrated, or intracellular extracellular potassium and phosphate and water fluxes between various body compartments. Fluid balance and cardiac support. Myocardial dysfunction is common in critical ill patients. There are many mechanisms to it. In most cases, cardiac support can be achieved by the optimization of fluid balance, the reduction of organ edema, and the distribution of desirable levels of preload and afterload. Several reports have shown that myocardial elastance can be improved after hemofiltration. And in such conditions, extracorporeal therapies allow remarkable cardiovascular stability and recovery, with maintenance of various hemodynamics parameters including MAP, heart rate, and SVR. Such stability which is achieved through slow, continuous ultrafiltration and continuous refilling of intravascular volume from the interstitium, allows stability of the circulating blood volume and preservation of vital organ perfusion. Next important part is protective lung support. The possibility of correction of hypercarbia from the circulating blood by means of extracorporeal methods have been in use for the last 15 years now. Today, the idea of using a special CO2 removing cartridge in series with hemofilter is used selectively. This gives us a chance to reduce the requirement of invasive mechanical ventilation, especially in some subset of patients like, say, ILD. Special membranes are used and are under evaluation, where a dry wet gas exchange process leads to significant values of CO2 clearance in the extracorporeal circuit. Such systems have been in vogue for last 15 years now. They have produced the mortality and morbidity from ALI, and future has to see greater evidence on this. Furthermore, by optimizing the patient's volume state and offering the ability to remove interstitial fluid, these therapy may offer additional support to the failing lung. Thus, although still far away from an ideal system, protective lung support is an important level of extracorporeal multi-organ support therapy, which is already being used in many of the centers. Brain protection. Cerebral edema is a consequence of rapid solute movement during intermittent hemodialysis. The arrival of CRT has eliminated this risk. The accumulation of uremic toxins from inadequate blood purification is a known cause of encephalopathy. The use of CRRT in the ICU has eliminated this risk. The development of hypotension leads to secondary brain injury. The use of CRRT with its associated hemodynamic stability has decreased this risk. The accumulation of amino acid derivatives may be responsible for encephalopathy of sepsis. And CRT, by removing such derivatives and decreasing imbalances between various amino acids, again have a beneficial effect on encephalopathy of sepsis. Thus, although still a long way from the ideal, a significant degree of brain protection is already being provided by various multi-organ support therapies. Bone marrow, rarely discussed for multi-organ support therapy. Bone marrow function is depressed by sepsis, uremia, critical illness, and other causes of bone marrow suppression drugs. Red cell protection and platelet function are affected by accumulation of uremic toxins and other toxins in liver failure. Although other important events affect bone marrow function, the removal of uremic toxins is an important way where extracorporeal therapy give a multi-organ support in ICU. Going on to liver support, again, in acute liver failure or acute or chronic liver failure, most of these extracorporeal therapies are in vogue. Commonly used CRRT or other dedicated liver support systems like MARS. A complete liver support system should include a detoxification component and a secretory component, possibly capable of metabolic activity. While the first component, which is detoxification component, can be accomplished by an inert mechanical system, the second one can only be performed by a hybrid artificial organ containing a mixture of synthetic materials and living hepatocytes, bioartificial liver. Still not commonly used, at least commercially, but some centers have been doing it on research ground. Nevertheless, the first detoxifying component can be sufficient to provide liver support and to bridge the patient towards recovery of native organ or to transplant. To perform such a task, different systems are now available for liver support. Some of them use a hemoperfusion technique, applying direct contact between the blood and adsorbent material. Whereas other techniques like MARS, which include cascade, plasmapheresis and molecular adsorbent recirculating system. Again, a dedicated extracorporeal liver support aiming at removing albumin-bound toxin molecules. Based on this albumin dialysis principle, the dialysis membranes used are impermeable to albumin but able to clear toxic substances bound to albumin when an albumin-rich dialysate is. So, albumin-bound toxins are removed preferentially by mass. The dialysate also contains electrolytes and bicarbonate and is regenerated by passage to an N-exchange resin, charcoal absorption, and sequential hemodialysis. Going on to sepsis, my favorite. The sepsis treatment, we call it a trident approach: antimicrobials, immunomodulation, and multi-organ support therapy. You have to support the failing organs. The rationale of adjunctive and extracorporeal therapies, they are indicated in profound severe sepsis, indicated by high vasopressor requirement or sequential organ failure, no improvement within a few hours after commencement of one vasoactive agent, PCT levels remaining high or increasing, and there is clinical deterioration. We have to select patients very, very judiciously. We talk about multimodal individualized therapy for sepsis and for most of these multi-organ support therapy. When we say multimodal approach, we mean that several clinical and biochemical parameters are taken into account simultaneously, not just based on PCT, not just based on PF index or on hemodynamic parameters. Whereas individualized refers to interpretation of changes or kinetics of certain parameters, such as procalcitonin, rather than taking a fixed value. Look at these parameters dynamically. There is a lot of confusion about sepsis. Cerebral sepsis is out, septic shock is in. So most of the septic shock patients are at high risk of death. And these patients might be selected judiciously for such multi-organ support therapy. It is still difficult to know for sure in which patients we should commence this adjuvant therapy. Still, it is based on physician's gut feeling rather than objective parameters. So again, we have to look at multiple parameters, multimodal and individualized approach. Initially, the thought was these extracorporeal therapies are only for the SARS phase, but our understanding has improved on immunopathology. We understand organ failure happens in subsequent CARS phase also. So these therapies have been used in both SARS and CARS phase. What should we expect from these extracorporeal therapies and multi-organ support therapies, specifically in sepsis? Sepsis care, as critical care, is comprehensive, multidisciplinary, multi-organ support. No therapy can save life alone, but improvement in hemodynamics, PF ratio, and decreased new organ failure is commonly seen. Immunohomeostasis should be achieved. If we talk about sepsis, immunomodulation is essential. These extracorporeal therapies have a firm physiological rationale. We must understand when, what, and how to use, but judicious patient selection is must, and our endpoints have to be revised. Our endpoints cannot be 6-month mortality. Going on to toxicology. Critical care toxicology is very, very rewarding. Each toxic has a different toxicokinetics. We need desperate measures for desperate situations. There is no ceiling dose of vasoactive agent. There is no ceiling dose of therapies, if I say in critical care toxicology. We need to have an all-out approach. So compassionate use of novel therapy, especially multi-organ support therapy, is widely being done in critical care toxicology. And even small case report and case series count as a big evidence for multi-organ support therapy in toxicology. The increased rate of hemodialysis is being used, which is reflective of a number of real and confounding. Earlier, hemoperfusion was commonly used, but now hemodialysis is being preferred therapy. It is possible that the severity of poisoning has increased, necessitating more aggressive interventions. They live longer, AKI is more in toxicology patients. What are the indications of RRT in toxicology? Removable by extracorporeal therapy. If there is no antidote, do Google it out. And the patient is critical, you can use some of these therapies depending on toxicokinetics. Refractory shock as a supportive therapy, pulmonary edema, uremic complications, non-renal indications, acidosis, temperature homeostasis, usual renal replacement therapy indications, progressive deterioration despite standard therapies. A lot of compassionate indications creep in this critical care toxicology segments. Some of the poisonings like methanol, salicylate, severe valproic acid, metformin, and lithium RRT should be strongly considered. The role of RRT and other pharmacological toxicities should always be explored, especially if situation demands so. Hemodialysis is commonly used for methanol, ethylene glycol, salicylate, lithium, not helium, charcoal hemoperfusion for phenobarbital, phenytoin, carbamazepine, theophylline. We have to watch for complications like thrombocytopenia, hemolysis, hypothermia, charcoal emboli, hypoglycemia, as with other extracorporeal therapies. What is the future of this multi-organ support therapy has with us? We need simpler devices, easy to do, single platform, biocompatible, less labor intensive. Nanotechnology can decrease the size. Biocompatibility should be there. Theranostics, you look at the levels, do the intervention. There should be clinical as well as levels should improve. It should be self-driven based on computational data, based on AI. Multi-organ support therapy in evidence medicine era have a very difficult task to prove themselves. Most of these interventions are done when the mortality is huge, 80-90%. So many times single sector or small study shows some therapeutic benefit, but the bigger data contradict the smaller studies. Nevertheless, from a pathophysiological point of view, multi-organ support therapy has a firm physiological rationale. If these multi-organ support therapies have a clinically relevant effect, once the technology and the doses are right and the appropriate large trials have been completed, such effect will be better appreciated in clinical outcomes, I would say. Theranostic circuit devices consist of extracorporeal circulation and the use of inline imaging system with the therapeutic cartridge component. So whatever intervention you do, to keep the endpoints, I want to decrease the methanol level from 700 to 300. The circuit will automatically do the thing, and there will be a therapeutic cartridge which complements it. Future is bright, and we have a lot of expectations from multi-organ support therapy. It is true that acute patients require a dedicated series of devices and machines, and the concept of multi-organ support therapy perfectly fits this description. But one cannot expect technology for extracorporeal therapies to be entirely separate for each and every case, each and every organ, and each and every phase of disease, acute or chronic. The future should simplify it, single multifunctional machine with a very user-friendly interface and flexibility. The question of who should be using such machines will be answered by the simplicity of the interface and the operating characteristics. Maybe someday these machines will go in the wards, or you will use these machines in the home. In the same way that the personal computers today do not require computer experts to perform complex tasks. So this new generations of machines, multi-organ support therapy, should be very, very user-friendly. In the meantime, an intermediate series of machines already exists. We have to improve the safety. We have to learn from the machines and learn from our mistakes, but we have to have a good learning curve. They can perform different treatments and tasks, but they still require specific programming and dedicated disposables. Given my view of multi-organ support therapy, the machine will be a platform with different options and easy to use interface. Nanotherapeutics will creep in and decrease the size, magnetic separation of pathogenic components from body fluids. We will have a capsule of extracorporeal therapy which will be injected, and it will remove the toxins and do the required good. Theranostics will be decisive in giving personalized medicine, especially for multi-organ support therapy. Dynamic clinical biomedical correlation will be there. As with any other therapy, there are many, many drawbacks. Most of the trials are happy ending trials. Extracorporeal therapies have its own risk, hemolysis, bleeding, cannulation related events, organ crosstalk between native and artificial organs, and many other complications, secondary infections, treatment costs, clinical benefit, risk-benefit ratio. Is it overrated? When to use it? We are still learning. When to use it in time? Evidence has to be stronger. Biocompatibility has to come in. Overall, available literature has not definitely established the ideal timing of these interventions. And whether early implementation impacts organ recovery and optimizes resource utilization is still a matter of open debate. It is possible that future research will be devoted to identify patient groups that may benefit from short and long-term multiple organ support therapy. My final view is, rather than trying to classify primary and secondary organ dysfunction, it may be better to identify the presence of unifying mechanisms of crosstalk that could be targeted for interventions. We must learn from history. We must not neglect the adverse effects of our therapy. If any lessons have to be drawn from last 40 years of critical care research, it is that targeting a specific physiological parameter is rarely beneficial and more often harmful. And that in the treatment of critically ill, most often less is more. As mechanisms of organ dysfunction are complex and we are unlikely to fully understand any patient's illness, we should resist the temptation to invoke therapies with limited evidence in non-compassionate situations. Use where evidence is strong. When evidence is weak, build up the evidence. Be very, very judicious in patient selection. Thank you. I'll welcome any questions and comments.
Thank you, sir, for detailed information about extracurricular therapy in ICU. Moving to the second session of Critical Care Unplugged part. The topic is it the time to redefine ARDS? Speaker is Dr. Prashant Nasa from NMC Specialty Hospital, Dubai. Over to you, sir.
Hello friends, I'm Prashant Nasa. I'm working as an intensivist at NMC Specialty Hospital, Dubai. Thank you, Dr. Srinivas and Dr. Ghanshyam, for giving me an opportunity to present at Hyderabad Intensive Care Symposium. Today, I'm going to speak about a very important, topic which is very close to my heart and also area of my interest. Shall we define or rather redefine ARDS? Is it time to redefine the definition? So we'll start with conflict of interest. Though I really like this guy, or I should say, at least his philosophy that whenever we say we do not have a conflict of interest, we do a lot of conflict of interest in the work which we are doing daily in and out in our ICU. Let's start with a case, a 42-year-old gentleman, morbidly obese. Patient was known chronic smoker and came with cough and breathlessness, and on testing with PCR of SARS-CoV-2, it was found out to be positive. Patient was hypoxic on room air in ER and was immediately started on high flow nasal oxygen with 60 liter and a FiO2 of 70%. ABG was done, which was showing a PF ratio of 100 to 51. So how do you think, does this patient meet the definition of ARDS, the current definition, which is Berlin definition? So is he meeting the definition of ARDS or not? So we'll be talking about all this in subsequent few minutes. What will be outlined for today is evolution of the definition of ARDS, how Berlin definition came into the picture, what is the issue with the Berlin definition, what is evidence of heterogeneity of ARDS. As we know, ARDS is a syndrome, precision-based management for ARDS, and finally, what is the future course when we talk about the definitions or phenotypic management of ARDS. We know the pathophysiology of ARDS very well now. There is a lot of inflammatory exudate which are produced either directly to the injury of a lung or due to extrapulmonary injury from systemic injury, either due to sepsis or pancreatitis or maybe even burns. So there is a lot of intense inflammation which happens in multiple organs, and in which lung predominantly produce inflammatory exudates, which ultimately leads to alveolar flooding and thereby producing syndrome which is known as acute respiratory distress syndrome or ARDS. And we also know that, as what we talk about the inflammatory response, there is both alveolar and pulmonary increased permeability, which leads to atelectasis and shunt. And there is an intense hypoxemia, which is a hypoxemic respiratory failure. And when we start mechanical ventilation or even non-invasive ventilation for these patients, there is a risk of ventilator-induced lung injury, which adds to the trauma which is already happening. And this trauma could be because of atlector trauma or even volutrauma or, the shear biotrauma, which can happen with repeated opening and closure of the alveoli, leading to further exacerbation of the inflammatory response, which is ongoing in these alveoli and ultimately leads to this vicious cycle of worsening of ARDS. So talking about the evolution of definition of ARDS, we have seen, definitions from quite some time since we know about the ARDS, and one of the oldest definition which came from Eschbach in 1967, where he tries to identify this particular syndrome of refractory cyanosis, decreased compliance, and diffuse infiltrates on chest X-ray. And with that pathology, they found that it has a very, very high mortality. In 1988, first of the definition which came as by Murray, who basically tries to identify the lung injury through 4-point scoring using PF ratio, lung compliance, and degree of infiltrates. We still use Murray classification for identification of the patients with severe ARDS and patients who require some sort of extracorporeal support, especially the ECMO, VV ECMO, which is standard of care for these patients. Followed by there is another which consensus meeting in 1994, which tries to identify syndrome into much more generalized terms. So to use these definitions into research, according to American European consensus classification, the ARDS was defined as acute onset with bilateral infiltrates and evidence of no left ventricular failure. Unfortunately, or fortunately, the prevalence was a use of a PA catheter at that time, and LV failure was actually identified through a PA catheter, and also PF ratio, which became popular by this time. We know that progressively these definitions ultimately give to Berlin classification, which is the current classification which we know about Berlin definition. So it came into 2012, where Berlin definition tries to identify the duration, the timing of the onset of the syndrome, which is 1 week from the known clinical insult, which could be either pulmonary or extrapulmonary. It should have a bilateral opacities which match to non-cardiogenic pulmonary edema, can be identified by either a chest X-ray or a CT scan. And these opacities could not be explained by the known pathologies like pleural effusion, lobar collapse, lung collapse, or even pulmonary nodules. And then a degree of moderate to severe impairment of oxygenation, which we nowadays calculate using a PF ratio. So it was further classified from, acute lung injury and ARDS. This definition changed primarily into ARDS as mild, moderate, and severe ARDS, depending upon the PF ratio from less than 300 to less than 200 in moderate to less than 100 in severe ARDS. What was also much more important was there was no requirement of use of a PA catheter to exclude left ventricular failure. And the other important thing, which was a pitfall for earlier definition, especially the American European consensus definition, which was use of not requirement of a PEEP or CPAP. So this was also added into Berlin definition. So a PEEP of at least 5 or a CPAP of at least 5 centimeter was required to further subclassify patients of ARDS into mild, moderate, and severe ARDS. So that becomes a diagnostic criteria to define ARDS. So, that brings a very important question, why we need these definitions. We understand they have a different etiology. They have a wide spectrum of etiology, which is producing this syndrome. So that's why it's important to classify these patients early. And that's why it will help, to early start of these institution of standardized clinical care, as we know that, the only evidence-based therapy which has shown a mortality benefit, which was a lung protective ventilation or even a prone ventilation for these patients. So one can start these therapies by using a low tidal volume as if you diagnose these patients early. So it was important for a bedside diagnosis to early start of these standard of care therapies, which have been found, outcome benefit for such patients, but also to ultimately, we know that there is heterogeneous, etiology. So at the same time, if we try to, fix up patients into different etiologies, it will be very difficult to do randomized control trials to compare different clinical trials involving different type of etiology-based reason of hypoxemic respiratory failure. So it was very much important to have a standard definition so that patient recruitment can be easier, and the comparison of one RCT to another RCT can be, apple to apple rather than, comparing it with a apple to orange. Finally, it was very much important to outcome prognostication and also to have a common language of communication between, different bedside clinicians or even researchers. But what were the pitfalls of, or rather I should say, what are the pitfalls of Berlin definition? As we know, the ultrasound has become a standard of care to diagnose various pulmonary pathology and has, taken over from chest X-ray. So these days we diagnose ARDS much more oftenly using an ultrasound rather than on a chest X-ray. And that's which was missing in the Berlin definition. What was much more important, the case which we discussed a couple of minutes back, patient was started on these non-invasive respiratory support like high frequency nasal oxygen, where we cannot say that patient is on this much amount of PEEP. So how will you define this patient as ARDS or not? And that what, was missing in the Berlin definition. There have been tries to, identify these pitfalls and to try to correct these pitfalls. So Lancet Respiratory Medicine, this nice review which came in 2021 was actually, one of the proposed definition of Berlin, or rather I should say an extended definition of Berlin definition to identify or to, subclassify the patients of ARDS by using high frequency nasal oxygen. So a patient on HFNO with at least 30 liters of minutes or, having other criteria like bilateral infiltrates and PF ratio less than 300, classify that patient as having an ARDS, and that what, help to identify these patients early as what we were doing for other patients. Now, talking about, heterogeneity, as we know that ARDS is not a disease itself, it's a syndrome, or it's one way of presentation of multiple reasons of etiology. It could be a pneumonia, which has happened directly to the lung, to an extrapulmonary pathology like patients with acute pancreatitis. And that is the main reason, with the current definition, we do not know or we do not subclassify these patients into pulmonary pathology and to a non-pulmonary pathology. We know that these patients have different way of management when we talk about the different regions of etiology. As the patients with non-pulmonary causes will have a different way of response to treatments like recruitment maneuver or proning, while patients with pulmonary pathology, we see there is less requirement or less recruitability as compared to patients with extrapulmonary causes. So etiology is important, which was missing in the Berlin definition, and that is one reason. But another reason which we need a newer definition probably. Coming to the other thing is heterogeneity. As our understanding of pathophysiology is growing up about ARDS, we know that it's important to identify these different phenotypes. We cannot manage the patients with inflammatory pathology like hyperinflammation, producing a lot of these inflammatory markers at what we have seen with COVID-19, presence of an interleukin 6. So other hyperinflammatory therapies will require different immunomodulation as compared to the patients which has a hypoinflammatory phenotype. Similarly, patients with comorbidities like hypertension, diabetes, obesity, they definitely behave differently as compared to patients who are otherwise healthy. Finally, the age, that what is really important, we have seen the outcomes are completely different, and even the response to the therapy is different as in the patients who are elderly as compared to the patients who are young. And that's why it's very important to identify these phenotypes, which is again missing up in the Berlin definition. So what is exactly when we talk about phenotypes? Its phenotype is, this particular slide tries to look at these different definitions which are coming up for identification of these subgroups or, these phenotypes which are there, not just in ARDS, like similarly what we are seeing these days in sepsis, and we are trying to identify these phenotypes or phenotypes. So it's basically a trait where the impact of the PERSI, the disease, is evaluated by the genotype of the patient and also by the environmental exposure. So we know that the inflammation which will be very high in patients with comorbidities like obesity and patients with hypertension, as what we saw in COVID-19. These patients were very much prone to have a very severe presentation as compared to the other patients who do not have these comorbidities. So the patient own genotype, but also environmental exposure adds into these pathology, and that could be one of the reasons we see different type of presentations of ARDS into different regions. Similarly, subgroup of phenotypes. When we say, when we try to identify these phenotypes into using a particular variable, a single variable, as like what we tries to, the Berlin definition tries to subclassify the patients of ARDS into mild, moderate, and severe depending upon the PF ratio. So that is known as subgroup. So a phenotype is further using an arbitrary cutoff like PF ratio. In this case, we can define them into subgroups. Similarly, there is another way of defining phenotypes as subphenotypes by using degree of inflammatory markers like hyperinflammatory or hypoinflammatory, depending upon these inflammatory variables which are there. Finally, there are endotypes which are, depending upon these pathobiological mechanisms. We can further subdivide into these phenotypes into endotypes or subphenotypes into endotypes. And there are studies which are going on to target certain therapies looking at these endotypes which behave differently. And there is, the evidence which is pooling up about the heterogeneity, as this particular paper which was published in Pulmonary Medicine BMC 2021, which tries to use the etiology as, subphenotype of pneumonia or extrapulmonary cause of ARDS. And there was definitely the outcomes of pulmonary organ dysfunction or PF ratio, which were different between two different regions of etiology. And that's what I tried to explain earlier also. The mechanism is of inflammation or the degree of inflammation, and finally the response of therapies are also different depending upon the etiology of ARDS. And that's what we also, see if we try to do a reanalysis of our older trials. We found that patients with severe ARDS do respond to certain therapies better, as like a PEEP or maybe a recruitment maneuvers, as compared to mild and moderate degree of hypoxemia or mild to moderate degree of ARDS. And that's what we see also in the management of these patients, like immediately even prone ventilation. Now, how this will ultimately help? If we try to identify these patients by phenotypes, what we can do is something known as prognostic enrichment, where we identify the patients who behave differently or their prognosis will be different. And when we try to identify these patients, we can use certain type of therapies by doing a predictive enrichment by certain type of therapies like what we saw, the statins or anti-inflammatory drugs into these patients. And to use these, instead of taking all patients of ARDS, we can take selective group of patients with have a different phenotypic pattern, and that can be used to identify certain therapies which may be beneficial for certain group of patients and may not be beneficial for all patients. And that's why it's important to identify these phenotypes, and they may behave differently with certain type of therapies. And we also try to look at this aspect in our, consensus recommendation which we gave for COVID-19 management of acute respiratory failure, that we cannot have all therapies given for all patients, and non-invasive and invasive ventilation can behave differently. And there is a need of personalization of the of care which we need to understand. And just H and L phenotype that I will be talking a little bit more about, as what was given by Professor Gettinoni, is not the only answer to manage these patients. Now, coming to the precision-based management, as we are understanding, ARDS is not the only pathology where we need to do individualization, but many other reasons or many other patients in intensive care where, as we understand, the single one-size-fits-all does not work, and we need to identify our patients depending upon their pathophysiology and try to customize the management as per the pathophysiology rather than using a same stick for everyone. So baby lung, we know this pathophysiology of ARDS, that lung becomes a baby lung, so overall volume of the lung becomes less. So it's important to use a low tidal volume and to use and to make sure that lung injury is not happening because of our own ventilation, which is a ventilator-induced lung injury. And the various way to identify this ventilator-induced lung injury is either using a measuring a plateau pressure or a driving pressure, or even mechanical power of the ventilation. And it's very much important to titrate the tidal volume or PEEP according to the lung volume and understanding the physiology behind the mechanical ventilation. And this is not only true for mechanical ventilation, but for other therapies which we use for these patients, like fluid therapy. So it's not, we can dichotomize a low risk fluid for everyone. There are certain patients, depending upon whether the patient phase and also the disease phase, whether it's early adequate or early conservative, or late conservative to late liberal, and that way we can identify further phenotypes even in the fluid management of these patients. And we know that, Professor Gettinoni in the start of the pandemic actually gave these phenotypes of low phenotype, where he tried to propose that there are certain subgroup of patients who continue to have a good compliance lung in the initial phase of the ARDS, where it's good enough to give 7 to 8 ml per kg of idle body weight instead of standard 6 ml or less of idle body weight of tidal volume. Even these patients may not respond to proning and equipment maneuver as what he proposed, and also use of a lower PEEP is beneficial for these patients. While the other patients in the progressive phase of ARDS ultimately develop a classical ARDS, that what Professor tried to propose, and he also proposed that standard lung protective ventilation will be only beneficial for these patients. Though unfortunately, or the evidence does not support that. And subsequently, many large, prospective studies and observational studies, they found there is not much difference, and that's what we also proposed in our consensus meeting, in our consensus paper, that there is no difference. Most of the experts agreed that there is no difference between, COVID-19 ARDS or non-COVID-19 ARDS, and management of low tidal volume is a standard for most of these patients. But also, it was very much important to use other therapies depending upon the individual response to these therapies, and most important, understanding the individual pathophysiology. Again, coming to the ARDS phenotypes in terms of hyper or hypoinflammatory. So this particular paper in 2020, tries to identify this particular phenotype from hyper, where we have a lot of inflammation like IL-6 and IL-8, or hyperinflammatory or hypoinflammatory, where there are low markers of these inflammation. And they also tried to find out that mechanism of mortality and the degree of mortality was much higher in the patients with hyperinflammatory, and even lower ventilator free days were there. And these are the patients probably where anti-inflammatory or immunomodulator therapies may have some role, and that's what future studies try to look into these patients rather than for every patient of ARDS. And there are further evidence which was proposed, like as we saw, using a PEEP, high versus low PEEP. Definitely a high PEEP is not recommended for all patients of ARDS. It's only moderate to severe ARDS which try to only get some benefit by using a higher PEEP, while most other patients of mild to moderate ARDS, a low or a standard PEEP is good enough. And again, it needs to be individualized depending upon the pathophysiology of the patient. Finally, talking about the conservative versus liberal fluid strategy. Again, this is something we should look into. Not every patient requires a conservative fluid strategy, and that's what they try to find out. In patients with hypo and hyperinflammatory, the fluid management will also be different. And even these statins, which are used as immunomodulators, which were studied into all patients of ARDS and found to be a negative study. But if we look at the hyperinflammatory subphenotype, they tried to do repeat analysis. They could find out there was improved survival by using these statins as an inflammatory agent in the subphenotype of hyperinflammatory. And then there are this further evidence which is growing up even in the COVID-19 subphenotypes, where use of other therapies like convalescent plasma, which was not found effective for most of the patients in ARDS. But if patients with a hyperinflammatory pathophysiology, if the use of these therapies can, change outcomes. And it's really important to identify these subphenotypes which have otherwise a worse outcome, and use of therapies like convalescent plasma can change the outcome of these patients. So again, and a very beautiful example of identifying the phenotypes which are definitely missing in the current definition of Berlin. So it's really important that we should change our management from a standard ARDS syndrome into patient phenotypes, and that what will be the future, where we talk about the individualized therapies by looking at the different phenotypes, and not only looking at the phenotype into, the patient may not behave with the same phenotype. It also will change depending upon the, the duration of the disease, also looking at the response of the initial therapy. So we need to keep on managing these patients, individualizing our therapies, and then only we can change outcome of these patients into such severe, high morbidity and mortality disease. So finally, what is the future course? I leave you with this particular, pro and con debate, which was published in Criticare 2021, and actually they pro was about whether we should modify the definition or we should leave completely ARDS definition. Again, a paper very beautifully written by Professor Gettinoni, where he proposed that yes, there are definitely advantage of using an ARDS definition as what I proposed. We are able to diagnose these patients early. We can provide them standard of care, And it's very important to include them into RCTs by having a standard definition, and then only we can compare one trial with another. But at the same time, when we take these patients which have been having a different pathophysiology, especially with the different etiology of the ARDS, there is the treatment which need to be customized, individualized, and that's what is missing in the current definition. It's very important to have these cohorts of heterogeneous etiologies to further phenotype or subphenotype, and to use them into or test them into RCTs for different etiologies rather than using the etiology for all patients of ARDS. So that's, I think, is missing in the current definition, and guidelines approach which is written for all patients of ARDS ultimately fail for these patients because we are not giving a room for individualization. But at the same time, shall we abandon the definition? There are advantages. You are actually moving towards a personalized medicine, which is, I think, an important aspect, especially if you have a team which can manage high-end care for these patients. We can definitely look into individualization, and that can only improve our outcomes and improve our understanding. But the problem is in the vast majority of the intensive care unit, which is available and which is required in the wider part of the world and wider part of even our own country, it's important to have some sort of standard of care. If we do not use this definition, they are very likely that we may not start these therapies, or we may delay these patients going into requiring certain therapies like even need of mechanical ventilation. We try to not identify these patients on time. They are likely you will abandon these or delay these therapies, definitive therapy, which have shown to change the outcome. And also it will be difficult to perform a research because they will be, again, as I said, heterogeneous etiologies again will be labeled rather than ARDS. So we cannot compare one trial with another one. So it's important to understand the bedside physiology, and then only we should decide what type of management we need to do. But at the same time, this should not be the reason of identifying or identifying every patient under a common syndrome of ARDS. Thank you for listening. I invite you all to write to me if you want a slide deck or any other question for me. Thank you, Dr. Srinivas.
Thank you, Prashant sir. Question for you from the delegate. Before COVID, generally we have not used IL-6 and CRP as much. But now, after the COVID, is it mandatory to decide the subphenotype by sending these markers to label it as whether it is a pro-inflammatory or hyperinflammatory subtype?
Okay, I think Dr. Mithilesh, it's a very good topic, and it's ongoing debate to identify these phenotypes. So we are understanding the importance of these phenotypes or subphenotypes and how we can use them to individualize the treatment. As what we have seen, keeping same management for every of these patients, especially understanding that ARDS is a syndrome rather than a single disease. So we need to individualize, and when we say individualize, how to do that? I think phenotypic approach is one way of doing that. By identifying these inflammatory markers is one way to say whether patient has a hyperinflammation phase or a or hypoinflammation phase. And that's what we have seen, giving IL-6 inhibitors to everyone also lead to harm or may not produce a good outcome. But identifying these subset of patients may be useful. At present, have we reached to that place? Not, definitely not. It's ongoing debate. There are ongoing trials which probably will give us these answers. But yes, like, if we talk about a specific disease, talking about COVID-19, which you asked me, there are now good amount of evidence to use dexamethasone, especially in patients who are on oxygen, and use of IL-6 if they are already on dexamethasone and continues to deteriorate. I think these are also identifying a subphenotype. So oxygen is a phenotype. You are identifying a patient without oxygen and versus oxygen, while a patient who is further worsening in oxygen is like using a biological indicator, which is an oxygen in this case. So this is not the only inflammatory marker which can be used as a phenotypic identification, but there are other ways to identify these phenotypes.
Thank you, Dr. Prashant. Moving forward to the next session, we have a very interesting topic. How close are we to personalized critical care? And the speaker is Dr. Sumit Ray from Holy Family Hospital, Delhi. Over to you, sir.
Good afternoon, ladies and gentlemen. As always, a pleasure to be part of the Hyderabad Intensive Care Symposium. 8th edition. I think I've been there from the first edition onwards. Thank you, Srinivas. Thank you, Ghanshyam, and the others for inviting me. So I'll be talking about how close are we to personalized critical care. So personalized medicine or precision medicine are kind of spoken in the same breath, and the definition that we have is the best definition that I could find is the US FDA and the NIH definition, which says that precision medicine, sometimes known as personalized medicine, is an innovative approach to tailoring disease prevention and treatment that takes into account differences in people's genes, environments, and lifestyle. The goal of precision medicine is to target the right treatments to the right patients at the right time. That, I think, is supposed to be what we should be doing, but we'll take a look at how precision medicine is going to be different from what we are already doing. And I'll be using the term more precision medicine rather than personalized medicine, because that's the term which is used more, precision medicine. And that would be what I would be using. So the early advances in precision medicine have largely occurred in oncology, because oncology is conducive to a large extent, many of the cancers, to genomics for diagnosis and targeted therapy. But unfortunately for critical care, it's such a complex disease process. I mean, the disease process and critical care are so complex, particularly the two biggest killers probably in ICU, sepsis and ARDS, that it will take more than one genetic marker or a genomic diagnostic criteria or treatment criteria to resolve the problems that we face. So what I'll be looking at are the possibilities that are there, that are already being worked upon, the challenges in those possibilities, and finally the concerns when we develop more and more of precision medicine. So before we go further, basically we need to know a few of the key terms. Many of you would know that, but just to re-emphasize, precision medicine, as I said, treatments optimized for genetics, lifestyle, and environment. The groupings could be, strata or phenotypes. Phenotypes being the most commonly used term, which are basically, as all of you know, clinical features or traits that characterize a group of patients within a disease or syndrome, including genetics, environmental factors, and other clinically observed characteristics. Then we have the subgroups, which are the endotypes. Within the phenotypes, you have the endotypes, which are the biological subtypes defined by distinct pathophysiological mechanisms within a phenotype. And a subphenotype is similar to an endotype, but without necessarily showing a causality or a mechanism, right? And then you have the phenotypic categories, which are the, what defines the phenotype: prognostic, predictive, drug responsive, device responsive. Another important concept is the heterogeneity of treatment effects. That means the difference in treatment responses in a group due to variability in drug response phenotype within that group. And enrichment is basically a methodology, a prospective strategy to address this heterogeneity of treatment effect by reducing heterogeneity of a sample population or increasing representation of patients with similar risk profile, so that we can study treatment modalities in that subset of patients. The possibilities obviously are being looked at in not only critical care medicine, but across specialties in medicine, cardiology, respiratory medicine. As you can see, these studies, allergic diseases, psychiatry, population health, and of course, critical care, particularly for sepsis and ARDS. So to look at how we can target, precision medicine, we have to look at, we have to look at, data from the strategies that we need to use would be that we have to gather data about patients and disease processes by genomics, epigenomics, transcriptomics, metabolomics, proteomics. These are called the omics of precision medicine. While there would be a lot of bioinformatics, that means a lot of data which needs to be collected, gathered, analyzed. So genomics, as all of you know, is a study of genes and their functions, and different clinical presentations and prognosis of sepsis patients. This was an article on sepsis, has been associated with different genetic variants, partly true of ARDS also now. Various polymorphisms have been described in the genes that encode pro-inflammatory and anti-inflammatory cytokines, cytokine receptors, cellular recognition pathways, intracellular signaling pathways, and hemostasis molecules. And based on this, the severity of illness and risk of mortality can also be defined and prognosticated. Epigenomics is the study of additional changes that alter gene expression without changing DNA sequence. These can be epigenetic modifications, can respond to environmental stimuli. They include basically studying DNA methylation, non-coding, what are called ncRNAs, histone variants, etc., etc. So the early studies in the early 20th century, 21st century happened with one of these being Wong's group, which studied sepsis in pediatric patients. They looked at the genome-wide expression of RNAs from 98 children with septic shock, and they divided them, subclassified them into 3 classes, A, B, C, and class C. Subclass A, was at the highest severity and mortality. So many of the studies which have happened in for precision medicine to analyze these data of genomics, etc., or epigenomics have been, or transcriptomics also, are basically have defined different subgroups which respond differently. Treatment modalities are going to be defined and designed more and more in the future, starting to be done, but more in the future. Transcriptomics is a transcription. The transcriptome is a set of mRNAs, nuclear molecules in a specific cell or tissue. Basically, transcriptomics is the study of the transcriptome of a particular cell or tissue in a specific circumstance based on the analysis of gene expression profiles. It aims at monitoring gene activity and regulation. Transcriptomics has made possible the characterization of different gene expression profiles in the critically ill. Sweeney et al. Did a study in the early 2000s where they looked at 700 sepsis patients with from 14 data sets and basically described 3 transcriptomic subtypes: the adaptive subtype, the coagulopathic subtype, and the inflammatory subtype, with different kinds of severity and mortality. So metabolomics is the study of the metabolome, which is a collection of small molecules produced by cells at any given point, and critical illness alters this metabolomic profile. And this is used in identification of biomarkers, drug activities, or drug-induced toxicity and metabolism. Metabolomic studies in sepsis particularly try to discriminate in patients with sepsis or non-infectious SIRS, identified prognostic factors, recognize response to treatment. All these parameters are being looked at, and we are doing metabolomics at this present moment. Proteomics is the part of omics that is responsible for the study of the proteome. The proteome is basically the set of all proteins expressed by the genome of a cell or tissue or an organism at a given time under certain conditions and certain conditions and certain environments. So all these are the omics, but what is also going to be very important at this present moment, particularly the focus would be bioinformatics, because of 2-3 reasons. One is omics-based tests are too slow at this present moment to be useful for ICU clinical decision making. In the ICU, we need quicker data to analyze quickly that what intervention we will do. And for this, we need to look at other source of data that can be rapidly collected and analyzed, and that is basically information from multiple sources which are gathered in bioinformatics. And as they say, the path to precision medicine critical care will run through large swaths of data. And these large data sets are going to be derived from genomic platforms, physiological information, the waveforms, the monitoring that you do, the data from electronic medical or health records, from RCTs, etc. This would give us new insights, are already giving us new insight into the pathophysiology of critical illness, and we'll look into some of the studies which have been done, enabling identification of distinct endotypes and subtypes, subphenotypes, which will furnish an infrastructure upon which to generate and test new hypotheses and treatments. And very important for the success of precision medicine is going to be open source electronic data capture tools and the data sharing. Already it has started that open source data is being used, is being gathered, is being shared. One of the examples is MIMIX3, which is basically a open access critical care database of the patients admitted to Beth Israel Deaconess Deaconess Medical Center in Boston. And this is widely accessible to researchers internationally under a data use agreement. It's the open nature of the data allows clinical studies to be reproduced and improved. And it has been widely used and is being widely used in academics, industrial research, quality improvement initiatives, and education coursework. So what happens is data, which is the bedside monitoring data, all of this data, tests, laboratory tests, echocardiography, etc., orders written by doctors, billing data, demographics, or notes, all these things are archived in a data, de-identified, data is sifted through, and it's put in the MIMIC database, which can be used by everybody. And they give feedbacks and corrections to the data, and it is improved upon. So there was a meeting of the American Thoracic Society for precision medicine in sepsis and ARDS, and they produced a research statement. And the first recommendation that they made was to create large, richly phenotyped, harmonized knowledge networks of clinical, imaging, multi-analyte molecular data from patients with sepsis and ARDS. There are already networks which are working for ARDS, that is the NHLBI network, for sepsis, the phenomes, which is for pediatric sepsis, IBBJ. Then there for COVID, there are multiple networks, as all of you know, international networks. Then recommendation 2 was to implement novel trial designs to identify precision medicine strategies that can be used in sepsis and ARDS. So adaptive trial designs, adaptive enrichment. So what it means is the modification of eligibility criteria. What are the adaptive trials? To target participants who are likely to benefit and or exclude participants unlikely to benefit. As the trial goes on, it adapts from interim analysis to see which patients would possibly, which subset would possibly respond, and they would adapt the trial to that. Then the same adapting can be done with biomarker guidance or biomarker threshold targets could be used, or response adaptive randomization could be done. Then there are the platform trials where multiple interventions are tested within a single trial framework against single control arm for a single condition. And therapeutic arms are added or dropped from the trial based on interim analysis. With classic examples, you saw the recovery, remap cap, solidarity, and ISPI and COVID. Recovery being a great success. Also, remap cap to a certain extent and solidarity. Then you have seamless phase 2 to 3 trials that seamlessly go from phase 2 to from safety to actually outcomes. Perpetual trial, continuously trials on a certain disease process or a certain, with the same platform using different interventions, perpetually in trial mode. And integration of EHR is important. And the third recommendation was advance of data science and engineering approach to facilitate precision medicine and develop tools necessary for real-time application. As I said, real-time is very, very important for decision making. So based on this, they gave a conceptual model for the path forward, as they say, for precision medicine. And they said, and the model says that, you have a knowledge network which is built from the data which is collected from the environmental data, clinical and electronic health records, imaging data, and all the omics data. Then data from randomized controlled trials or good observational studies are put into a knowledge network. Phenotypic identification could be done. Inference studies could be done. Detection of heterogeneity of treatment effect could be gathered from this knowledge network. Exploration of biomarkers and targets could be identified. Candidates subgroups could be teased out, which could be potential trials of therapy could be done based on that. If there's a low certainty, then the design would be different from a moderate certainty trial or a high certainty trial. Recovery was a classic example of a successful platform adaptive trial where, different with a single arm of the same control patients on one arm. There were different therapies which were tried and the outcomes were looked at were similar, but they could do it because the NHS, this was from the NHS, and NHS had a tremendous amount of data they had collected centrally through a period of many years, which they could use in this setting. And they're like hospital data sets, mortality data sets, disease specific data sets, critical care data sets, COVID data sets. And that was why it was such a success. And that's why it needs an integrated healthcare delivery system, particularly a large integrated public health system or integrated network of hospitals in a region or in a country, etc. So this was further what, if you see, let's say the convalescent plasma for antibody-based therapy, convalescent plasma versus or monoclonal antibodies versus usual care. And not only did, the study with the recovery platform looked at the convalescent plasma, showed no benefit, but there were a lot of talk about that those patients benefit. The subgroup which benefits is those which do not have antibodies. They tested all that. And found that it was not very useful in COVID, even with patients who do not have antibodies. So, even the subphenotype targets were looked at. So there, as I said, there are studies in phenotyping of sepsis based on multiple modalities. This was a large data analysis done by Seymour et al., looking at patients who were admitted with sepsis 3 criteria from 12 Pennsylvania hospitals. And they had a derivation cohort of 20,000 and a validation cohort of 43,000. The derivation cohort, basically they used the sepsis endotype in emergency care, the Seneca study, and they used genetic and inflammatory markers from the GENIMS study. And then what they did is they tried to tease out, and they found 4 phenotypes, and I'll come to that. And they also looked at 3 trials, the ACCESS trial, which is erythroran in severe sepsis, the activated protein C, the PROVESS trial, and the PROCESS trial, to see if different phenotypes would have behaved differently if one trial was done on one phenotype. So the data that they gathered was huge amounts of data, which were clinical data, vital marker, parameters, lab parameters, data from ventilators, monitors, etc. And from that, they did a chord diagram, and they basically analyzed that. And this chord diagram shows basically the 4 phenotypes that they found. The alpha phenotype is one which had patients with lowest administration of vasopressors. Beta phenotype is one which had older patients with more chronic illness and renal dysfunction. Gamma phenotype was patients who had more inflammation and pulmonary dysfunction. Delta phenotype of patients had more liver dysfunction and septic shock. If you see the chord diagram, you see the delta phenotype. If you see the hepatic effect is high in that, no other phenotype has that much. Then inflammatory is also there. Cardiovascular is also there. So different, the gamma phenotype is a different profile, more inflammatory, no hepatic, some hematological, so different subset. And they actually, these subset phenotypes, these were devised from the data sets, and then they were analyzed for outcomes, right? The 4 phenotypes behaved very differently in terms of outcomes. The outcomes were mechanical ventilation, administration of vasopressors, admission to ICU, and in-hospital mortality. As you can see on this side, the gamma subgroup had the highest amount of mechanically ventilated days. Administration of vasopressors was lowest in the alpha phenotype. And in-hospital mortality was highest in the delta and the gamma, with liver dysfunction, inflammation more, and here pulmonary and inflammation more. These 2 died the most subgroups, while the least was in the alpha subgroup. So the response, they teased out the phenotypes through the data that they collected, and the response to treatment also varied based on the phenotype. This was also the analysis that they did, which was basically looking at patients in alpha and delta phenotype, the least mortality, highest mortality. In this, if there were 0% patients of this phenotype, or 100%, and in between 24 and 46%, and they looked at the trial, the ACCESS trial, erythroran. So they found that if erythroran was used in the alpha phenotype, if it was 0%, so the chance of harm was minimal, but there's no chance of benefit. Mostly it was neutral. If in the delta subgroup, if there was more delta patient subphenotype patient, the harm would be higher with use of erythroran. For PROCESS trial here at the bottom, for if the alpha phenotype was 100%, then there would be more benefit. For lower percentage, there would be more harm in the process. If there was a delta subtype, then more delta, more harm. For the process, for dotrigoren alpha, right? So for that, well, if you see that everything shows benefit, which I'm a little doubtful about, but we'll not go into that. It's just we are analyzing. Obviously, there are conflicts of interest which could be there in precision medicine too. Now looking at another study, which was they did about nearly 350 patients in emergency room and ICU for sepsis patients versus 44 healthy controls. Basically, they did the blood RNA sequencing, looking at the gene expression profiles. And what they found is that the gene expression analysis that they did fitted into biological patterns with discrete pathways, specific pathways, and sometimes overlapping pathways. And they found they could stratify sepsis patients based on this on 5 groups. One was they called the neutrophilic suppressive NPS group, the inflammatory INF group, the innate host defense IHD group, the interferon group, and the adaptive group. And they found these subsets, and this was a 4 gene classification tool that they used with an accuracy of 96%. And they found that these subgroups behave differently. They could make the subphenotypes from the genomic patterns and epigenomic patterns, but they could also see that the outcomes were also different in this. We have seen this in more simpler analysis of the latent class analysis that Carolyn Calfee's group does from California, and this is the the two for ARDS patients. They analyzed ARMA and the alveoli trial, okay, which is a low tidal volume and low plateau pressure, and alveoli, which is high versus low peak. And they analyzed the biomarkers, and they found that there were 2 phenotypes. The hyperinflammatory phenotype was phenotype 2, and the low inflammatory phenotype was phenotype 1. And the hyperinflammatory one had a higher incidence of shock, acidosis, and higher concentration of inflammatory biomarkers. 8 biomarkers they could find that which were significant. And they found that the outcomes were totally different, even for the ARMA cohort and the alveoli cohort, depending on the phenotype, the mortality, not just by the tidal volumes used or the plateau pressure used or the PEEP used. It was the mortality was also dependent on the phenotype. The phenotype 2 had the hyperinflammatory had much higher mortality as compared to phenotype 1, and also more ventilator days and organ failure days. For PEEP, low versus high PEEP in the alveoli trial, they found that the phenotype 2 with the hyperinflammatory one did better with high PEEP, while the phenotype 1, the less inflammatory, did better with low PEEP. So they were the subphenotypes that they analyzed, and they worked towards more analysis in a newer trial, which they could reduce the number of data they could analyze and they needed to gather. And they found that by just 3 variable models, interleukin 8, TNF receptor 1, and BiCARB, they could define the phenotype 2. And they found that for ARDS patients, for the FACT trial, all patients did not behave similarly. The subphenotype 2, the pro-inflammatory phenotype, hyperinflammatory phenotype, actually did better with conservative fluid therapy, but the subphenotype 1, the less inflammatory one, did better with a more liberal fluid strategy. So this was the phenotypes that they found. So what are going to be the challenges? These were the possibilities. What are going to be the challenges in precision medicine and critical care? One would be the finding discrete groups and subgroups, and the problems could be of 3 types. There would be 3 types of uncertainty, as they would call missingness. That means failure to measure what is needed, either because we do not know what to measure or we are unable to do so. Continuity, inability to determine a breakpoint on the distribution which would trigger a response. That means, suppose procalcitonin. What is in the spectrum of procalcitonin levels, which is the cutoff which will tell us exactly that, okay, this is bacterial sepsis and you need to give antibiotics, and this is not, right? And just a simple example, right? So like that, multiplicity. Multiplicity is that you have many dimensions, and multiple domains of interest for us in a patient, sick patient. And we gather huge amounts of data. The data comes through, we can understand disease processes better, but can that help us to make us separately tease out subgroups, little subgroups, or, which can be treated differently. So discretion, make them more discrete subgroups may be a challenge. And testing of individual therapies on smaller and smaller groups of patients means that the eligibility criteria for recruitment would be difficult. Longer recruitment times, more complex, more expensive to do clinical trials. Next is incorporating multi-morbidity in clinical trial, another challenge, right? So critical care has not just the acute illness that the patient is presented with, but more than a third of the patients have pre-existing comorbidities. How these comorbidities interact with the acute illness, how the interactions, the pathways cross between the acute illness and the chronic, these are also difficult to tease out. Obtaining real-time data, as I've been saying, getting data quickly enough which could be useful in an acute decision-making setting, which critical care is, right? So that is also a difficulty. Then another huge problem is managing the scale of clinical and biological data. Huge amount of data burden will be there. Just an example, right? So this is a patient who has a disease process, suppose sepsis, whose Genomic data is being collected, transcriptomic data, metabolomic data, proteomic data, right? Then you have to collect it not just from just one side of the patient, different organs, different tissues, because we don't know what data we are going to find. And then not only one patient, you have to take at one time point, you have to take it at multiple time points, and then across thousands of patients or millions of patients. Just look at the volume of data that needs to be analyzed. It's a huge burden of data. Then when you have so much data and you have to and you are sharing the data, because as I said, precision medicine can only be successful, really successful, if there is collaboration between research groups and data sharing, right? Data management becomes very important. How to share data, open science, have open science, principles of open science, while protecting sensitive health data, information of an individual patient. How do you do it? Data stewardship, allow access, but have security and accountability, create research networks, data sharing agreements, but also create research ethics protocols. So that is the data is, analyzed and shared in a certain way. The other problem that the recommendation 5 of the American Thoracic Society states is that to ensure that precision medicine advances be applicable to a broad range of patients across different healthcare delivery systems, resource rich, resource limited, racial, ethnic, socioeconomic and demographic groups, and social and environmental practices. Precision medicine should improve care for critically ill patients globally across the world and not worsen already existing healthcare inequalities. Just for example, 80% of the patient population or of the population of the world is in resource limited or developing countries, right? Patients in these countries account for 85% of the global sepsis burden. But most of the research, most of the focus is from developing countries. Most of the things developed are from developing countries. So there is a problem. And a threat to this goal is solely focusing on molecular substratification. If we have molecule which requires complex assays, applies to only highly resource quaternary medical centers, that cannot be used in resource limited settings. Critical care outcomes vary significantly by race and ethnicity and gender. And clinical trials often underrepresent minorities and socioeconomically disadvantaged groups. Difference in lifestyles, nutrition, physical activity, tobacco, alcohol, all affected. So how do we kind of work around these? The concerns are that, the potential strategies to enact an equitable and just global access to precision medicine includes what we should do, that is a just and equitable distribution of the healthcare knowledge and information and interventions that we develop from precision medicine. We should consciously include diverse stakeholders from different geographic, economic, cultural, racial, ethnic, and gender backgrounds, not only as patients here, right, for studies and trials, but also on advisory panels and peer review committees, because they have a stake in how the study is being done. They have a say in that. And also using approaches tailored for low resource settings, which include, developing cost-effective and rapid diagnostic tests which can be stored and performed easily in any healthcare setting, using surrogate models that are reliant on readily available clinical data instead of complex biological data. So bioinformatics, AI applications to leverage high dimensional clinical data with relatively low local technology, and then using the fast second winner model, which is that if some company, a niche company, develops a high-end intervention or etc. in a developed country, another company which can mass produce it and sell it at a lower cost without having to pay very high royalty to the initial company which produces the technology, and take this technology or this intervention to resource limited settings, should be promoted in certain way with controls. So those are going to be the challenges that we face for precision medicine. Huge amounts of data, analyzing data, making the data discrete, sharing data, all these are important. And to wind up, I just want to quote from an article called A Path to Precision in the ICU by Maslow et al. In Critical Care. They go on to say that precision medicine or personalized medicine defines an approach in which the clinician comes to the bedside seeking to interrogate and understand their patient's unique physiology. While the terminology may be new, this sensibility harkens back to the earliest incarnations of critical care and remains at its core today. So that's true, that when we are treating a patient, along with the broad understanding of the disease, we are also should be at least trying to look at that individual patient, and precision medicine should help us do that better. I think it can do better, but it also has to work within the limits and understandings of a more distributive justice of delivery of healthcare. And for that, I quote Rudolf Virchow, and he says that medicine is social science and politics is nothing but medicine on a grand scale. The task of medicine is therefore not merely to treat disease, but also to contribute to the health of the entire population. And the entire population is the entire world, including poorer countries, poorer people within those countries, minorities in terms of socioeconomic minorities, gender minorities, caste minorities, class minorities, everything. So if precision medicine has to take us somewhere, it should look into all these factors before we can say that precision medicine has come to stay. Thank you so much.
Chandresh?
Go ahead with the
question. Hello, Chandresh?
Yes, sir.
Yeah, so before we continue with the next session, let's answer a few questions.
Yes.
So there was one question to Dr. Divetia, sir is not online, but the question was from Dr. Hasiuddin, who said, can we monitor fluid responsiveness with left ventricular VTI via echo if done appropriately as bioreactance and PICO is positive? You can, because velocity time integral is a reflection of stroke volume, and fluid responsiveness is defined as the increase in a stroke volume in response to a fluid challenge. So if you have the technical expertise and the precision to measure the velocity time integral in a mechanically ventilated patient with variable heart rate, you can still do it, but it's a technically advanced mode of measurement, so it may not be replicable 24/7 when such person with the expertise and the training is not available in the ICU. So the decision making may swing between highly advanced VTI based assessment for again back to what we were doing, but it's a good method of assessment. The other question was for Dr. Yash Javeri from Dr. Fasil again, and how to optimize the settings even on CRRT if the hemodynamics worsen. The first response is to make sure that you're not driving out too much fluid. If your negative balance has been a little too much, your patient will be hemodynamically unstable. So the first response is to check for volume status, and if you're too negative, stop the negative balance which you're trying to remove in the ultrafiltration. Second step is to reduce the flow rates, but it's on up to a level you can reduce up to 80, below which it may be ineffective. Then of course you have to check for the other factors which can cause unresponsiveness of the vasoactive medications on the blood vessels, and that's metabolic acidosis and lactic acidosis. So you can go in that depth. Chandresh?
Right, sir. Thank you for clearing those doubts. Question asked by the delegates. Now moving forward, our next session will be on Young Investigator Lecture. The topic name is Phenotypes in COPD, and the speaker is Dr. Sumalata. She is from Mysuru, from Clear Medi Hospital. Dr. Sumalata, over to you.
Good afternoon, everyone. I am Dr. Sumalata, and today I am going to talk on phenotypes in COPD. So the outline of this talk is going to be, first we'll discuss what are phenotypes and why the identification is important. Then from what is known so far, we'll go to what is new, and then we'll discuss about the evidence about phenotypes and where the phenotype evidence about the phenotypes is generated and how to classify actually the phenotypes and what we have done so far and currently what we are working on. So what are phenotypes? The basic definition, or to put it simply, it's the external attribute of a person. If you are talking here a disease, it's an external attribute of a disease. But for this, to define it for a disease, we need an operational definition. And for COPD, thankfully, it is already defined by societies. It is basically a single or a combination of disease attributes that describes the differences among the individuals of COPD. And finally, it relates to clinically meaningful outcomes. So we all know already in our medical education, we have heard about blue bloaters, pink puffers. So these are basically the phenotypes of chronic bronchitis or emphysema, which are subsets of COPD. So the concept of phenotypes is not something that's very new. It is old, but research from a point of view of classifying patients based on phenotypes and their management started taking steam by around 2004. It was Spanish Society which first described guidelines and described 4 different phenotypes. And finally, Gold Guidelines adapted it by 2019. So why is phenotype identification important? Because mainly most of the diseases that we see as syndromes, the sepsis, the ARDS, are quite heterogeneous, and so is COPD. You have varied subpopulation of patients who differ by etiology, the causation of the disease, the pathogenesis, the development of the disease, and how it progresses over time. And patients differ based on these. The response to treatment, each subtype of patients require different kind of treatments actually, and the response to each treatment is different. And finally, it also affects the morbidity and of course mortality. So identifying patients based on phenotypes and directing treatment to a particular phenotype will lead to personalized care and better outcome. So it is a first step towards precision medicine. That's why it is important to identify patients based on phenotypes. So let's see what is known so far. By definition, phenotypes are external attributes of disease. So you can have phenotypes as much as ranging from just 2 broad classification into two diseases or to a few million. So each patient basically can be a phenotype in himself. But clinically relevant phenotypes, more than 50 has been described so far. And there are various factors or yardstick based on which these patients are categorized into different phenotypes. It may be clinical presentation, it may be the etiology causing the exacerbation of COPD, it may be the basic diagnosis or pathology that they have, it may be biomarker based COPD classification, it can be number of exacerbations the patients have in a year, or it can be presence of comorbidities. Now COPD is known to be not just a respiratory disease, but very much a systemic disease involving a lot of other comorbidities like vitamin deficiency, anxiety, depression, and association with lung cancer, cardiovascular diseases, cancers. So based on all of this, the phenotypes of patients have been described. So let's come to one each at a time. So we all know, based on clinical presentation, already in 1987 itself, Anthonyson has classified into type 1, 2, and 3 based on dyspnea, sputum volume, and sputum purulence. Type 1 patients have better outcome when treated with antibiotics because mostly they are bacterial. And clinical based classification does not add a burden on patient care because you do not need additional investigation. So that's why Anthonyson type 1 and 2 have been widely accepted. Coming to now, based on number of exacerbation, Gold Guidelines defines frequent exacerbation, frequent exacerbators based on more than 2 admissions per year due to acute exacerbation of COPD. So these patients actually are better off by giving maintenance inhaled corticosteroids. So the number of exacerbations actually come down. So this is one example of in recognizing a particular phenotype and treatment leading to a better outcome. Of course, as I told, there is a different comorbid phenotype based on comorbidities they have and emotional frailty in phenotype. Patients of COPD, some subsets are very much prone to anxiety and depression, and they have poor health-related quality of life. Not everybody develops this, and those who develop this are deemed to have an emotional frailty phenotype, and you need to tailor your treatment to attend to these emotional frail phenotypes. So next will be etiology based. This is a simple, common, bacterial, eosinophilic, viral, pauciimmune. This is bacterial and viral, we all knew, but it was Buffadal et al. Who classified into 4 different phenotypes based on the cell type and cell count in sputum and in blood. Those who have eosinophilic exacerbation respond very well to steroid. Of course, bacterial, we all knew, respond to antibiotics. And also there is a subset called pauciimmune where there aren't much inflammatory cells in the sputum. And surprisingly, there was an excellent correlation with clinical exacerbation phenotypes. And this distinct pathophysiology also has a specific biomarker signature, which I'll discuss in subsequent slides. So this is something that is very new, the bacterial, eosinophilic, viral, or pauciimmune. So next will be diagnosis-based phenotypes. We all know about this: chronic bronchitis, emphysema, asthma, COPD overlap after the NET trial. And newly coming up is the bronchiectasis and COPD overlap. This is because now CT has been widely used in most of the longitudinal cohort studies that have been conducted in large populations. And of course, pneumonia. To summarize, these are the widely accepted phenotypes: the chronic bronchitis, emphysema, ACO overlap, frequent exacerbator, whereas emerging COPD phenotypes are your pulmonary cachexia phenotype, that is, those who have nutritional deficiencies and they have severely low BMI, and upper lobe predominant emphysema. These are the patients who respond very well to lung volume reduction surgeries. And fast decliner phenotypes. Since we have large number of cohort trials longitudinally following up patients frequently, the frequent PFTs are being done, and these trials picked up a phenotype wherein the decline in PFT was very fast, and targeting additional inhaled bronchodilators and pulmonary rehabilitation techniques in them helped improve their outcomes. So we all know that some basic treatment strategy has already been established. These 4 are the classical 4 phenotypes given by the Spanish Society: the no exacerbators, the COPD asthma overlap, those with emphysema and exacerbation, and chronic bronchitis. Of course, long-acting bronchodilators are important in all of them. The chronic bronchitis, emphysema, and ACO benefit from inhaled corticosteroids, whereas the chronic bronchitis phenotype developed with mucolytics, long-term macrolides, and of course, rofamilast. This is something new that has come out of the phenotype-based approach of disease identification, subgroup identification, and treatment of COPD. And Gold, of course, has also classified into A, B, C, D, 4 different phenotypes based on MMRC, CAT score, spirometry classification, and number of exacerbations they have. And there is, with increasing grades of the disease, you need stepwise increasing treatment. So this has been already, phenotypes based treatment has already become part and parcel of COPD treatment. So next is biomarker based phenotypes. This is where most of the studies is going on. So researchers have already evaluated multiple biomarkers like CRP, inflammatory cytokines IL-6, IL-8, tumor necrosis alpha, and some patients, only a subset of them, develop inflammatory reactions with number of biomarkers being elevated. This is not seen in all of the subset, and there is much of the research that is needed, and this systemic inflammatory phenotype that is so-called because of elevation of these biomarkers is yet to be fully defined, because we do not know what mechanism drives the presence, type, and severity. Is it part of normal aging? And what are the therapeutic implications? So much research is still needed about this phenotype. After understanding all the known concepts of phenotype and where we are moving from, if you want to actually identify phenotypes in your research subgroup, How are you going to do about it? First is you have to identify groups of patients with similar outcome and then take up their history, clinical examination, symptomatology, radiology, and then move further towards biologic or molecular characterization of phenotypes based on advanced statistical analysis. And after you have grouped this patient, development of therapy based targeted to these particular phenotype. Finally, you need to develop a molecular marker to pick up these phenotypes in an external cohort, not the cohort where you have developed these, and you need external validation, and you need to have some therapeutic response to be measured in a target population. So this is basically an iterative process which is repeated multiple times to establish, phenotypes across large population. So where does the data come from? We have been talking about phenotypes. Where is all the data coming from regarding these phenotypes? All of the studies mostly have been Western trials, and large cohort studies have contributed to data so far. COPD gene is almost started in 2010, almost 10,000 patients. It studied all the genetic factors associated with COPD, and it tried to classify COPD patients based on CT chest. So whereas Caucus study was your Korean study where first time it described ACO phenotype, and giving inhaled bronchodilators in them, corticosteroids, was going to decrease morbidity and mortality. Acure study was a Chinese study. It studied comorbidities, especially diabetes, what is the outcome, and it showed that there is more obesity and higher degree of severity of COPD in this kind of subset. Whereas Eclipse study brought out a wide array of phenotypes, and it classified COPD into mild to severe and a component called systemic COPD. And it defined who is a frequent exacerbator phenotypes, that is 2 or more. And we also have Spiromic study, which is a large study on European American population, where phenotype identification is being done, and there is new ways of prognostication of COPD patient, not just your FEV1. So CHAIN was a trial where phenotype-based COPD management was studied, and whether it improved outcome of COPD patient. Yes, it showed that personalized care can be delivered to a subgroup of patients once you identify the phenotypes. NET is, of course, the one study that pointed out there is a upper lobe emphysema phenotype, and lung volume reduction surgery helps in these patients. So not just the data, how you handle the data matters. And luckily, because of AI and machine learning techniques, we can sit here and discuss about advanced analytical techniques like cluster analysis and factor analysis, which has contributed to generation of evidence. Cluster analysis is an AI-based unsupervised machine learning technique. Here it encompasses a different algorithms. It just groups patients without any a priori hypothesis, and it starts grouping and reduces the number of groups to a smaller sets or clusters. So for phenotype identification, you need to apply cluster analysis. That would be better. Whereas factor analysis helps in validation of these clusters. You have, for example, you are now out to identify the biomarkers in COPD, and you want to classify phenotypes based on biomarkers. You found 3 or 4 biomarkers like CRP, serum amyloid, interleukins. So you identify this cluster by cluster analysis. Whereas factor analysis reduces the number of key variables on which the cluster is identified, and it identifies which one variable is needed to identify a particular cluster. So when you apply factor analysis, among all the biomarkers, either it's the CRP or the IL-6 or IL-8 that you need to chase to identify a particular phenotype. This is how you use advanced analytical techniques to generate evidence regarding identification of phenotype and validating these phenotypes in an external cohort. So this is a dendrogram of cluster analysis. If you can see here, first for example, you are studying the peripheral blood neutrophils and eosinophils, and you are trying to group patients. So first 3 patients have neutrophils of just 30-40%. So not just first 3, it picks up 3 patients with 30-40%. So they are clubbed together. And the next 2 sets have 20-30%, whereas the last 2 sets have 60-70. So it starts grouping patients and start merging the clusters until there is an elbow among the cluster. If you graph the clusters, you will find an elbow point where the number of clusters rapidly increase. So rapidly decrease. So this is the time where you stop doing further clustering and you find out how many clusters you want. So this is basically, if you see, you can see 4 different clusters in this based on the cluster analysis. So this is an example of how a graph on cluster analysis looks like. Here on x-axis, you have a function that is FEV1 predicted and FEV1 by FVC ratio and age plotted at x-axis, whereas the function of IgE and sputum eosinophils in asthmatics, let's say. So each cluster analysis first identifies 4 centroids, 4 or 5, based on the number of clusters. You have to define at first how many clusters you want. So there is something called centroid. From the centroid, what you have here, how is the data dispersed? The data, you just select this data, take this triangle. The centroid that is nearest to it, so that this data will go into this cluster. So this distance is called Euclidean distance. It is nothing but your Z scores. That is mean minus standard deviation, square it and square root it is what you have learned. It's similar to something like Z score if you want to put it very simply. And based on that, each data will be clustered towards one centroid. And since you have given that you want to identify 4 clusters, each data will be clubbed into one of the individual clusters. So I'm here. So some of you might ask, why are you talking so much? What have you done on this topic? So when we went through about the studies about COPD, acute exacerbation, much of the studies were from Western world. And to be frank, all the Western world data comes from tobacco COPD, whereas worldwide, only 1/3 of patients are from tobacco COPD. Rest 2/3 are from biomass, that is burning of and biomass, your wood and other fuel are used as fuel for the daily energy needs. This is very common in LMIC countries. So we wanted to define clusters, we wanted to define phenotypes based on these acute exacerbations of COPD in LMIC country, especially our country, India, and how these predetermined 10 phenotypes we wanted to correlate these phenotypes and their clinical outcomes. We took all 10 phenotypes were based on pathology and exposure risk that has been previously shown in the studies from West. That is, based on pathology, non-bacterial, non-eosinophilic, bacterial, eosinophilic, and bacterial pneumonia, bronchiectasis, all these 6 groups we took based on pathology. Whereas we classified based on exposure risk into tobacco, biomass, both or none. So then we found out, when we correlated it to the clinical outcomes, we found out that those with bacterial infection or pneumonia had a higher mortality, and those with tobacco smoking had higher mortality after an acute exacerbation of COPD. So this was the first attempt to compare various AE-COPD known phenotypes based on pathology and exposure, their characteristics, and their clinical outcome in LMIC countries. However, our study had limitations. It was retrospective. Since it was retrospective, the data that we could collect was limited. Radiological changes, the bronchiectasis, much of it was missed out because there wasn't much CT data. Biomarkers, especially the sputum cell type and cell count, we couldn't do. Culture-based diagnosis of bacterial infection we had to accept. We don't know how much of it was colonization, how much of it was infection, and comorbidities were as listed in records. There was limited information of health-related quality of life, and additional new biomarkers which we would have tested if we had funding. We couldn't do it, and there was no data on socioeconomic status, nutritional status, and PFT was not a recent one. So seeing all this, we designed a prospective study. That's where the birth of fast COPD trial there. So this is what we are currently working on. It is basically a large prospective cohort trial of almost 1,000 patients admitted to ICU with severe and very severe COPD only. This is the first and largest study in South Asia to study all the factors that affect survival in severe and very severe COPD. And we also have the following objectives. Not only survival not only the survival that we want to study between biomass and tobacco COPD, it is also the annual exacerbation rate. And we are also studying the dysbiosis after an acute exacerbation by comparing the lung microbiome during exacerbation and a stable status. Along with this, we want to identify different phenotypes in severe and very severe patients and map their characteristics over time, that is disease progression over 2 to 3 years. And we also would like to see the nutritional assessment in these COPD patients and compare obese, normally nourished, and malnourished patients. What are their outcomes? So this is the flowchart describing our trial. Almost 1,000 subjects satisfying inclusion and exclusion criteria will be recruited, out of which already 560 subjects have been recruited. First 100 subjects will undergo the tests to identify lung dysbiosis. Since the funding is limited, we have limited the trial study on lung microbiome to only first 100 patients. So is the sputum cell type and differential count. We expect loss to follow up to almost 40% because of lack of incentives for the patient to remain in the cohort. The follow-up is basically telephonic as of now because we haven't received large-scale funding for a physical follow-up. So as like any other trial, we are collecting routine demographic data, the lab variables like CBC, RFT, liver function test, renal function test, ABG, echo, and X-ray. But there is a special focus on nutritional assessment, which will be done using, which we are doing it using BMI, sarcopenia, especially the rectus femoris cross-sectional area of the right thigh, Venetian angle. Mental health assessment is being carried out using questionnaires, either by patient himself or surrogate. Socioeconomic status is being assessed with standardized living index. Of course, exposure assessment like biomass, smoking, occupation, or air pollution, all of this will be assessed by appropriate questionnaire. We also are collecting treatment data on antibiotics, diuretics, inhaled corticosteroids, and mechanical ventilation. So apart from this, follow-up PFT will be done within the first 3 months, and calculated indices like BORD and Adobe will also be, the data will also be collected on that. During the telephonic follow-up, we ask about the number of exacerbations per year they have had, and we reassess the anxiety and depression based on questionnaires and including health-related quality of life. So this is the schedule and plan test that is being carried out. Follow-up visit is every 6 months. Since we have lacked funding, all these things is not being done. What we are doing is HAM-A-HAM-D questionnaires to assess anxiety and depression, standardized living index, and health-related quality of life. Of course, some patients do come back for physical follow-up. They will get regular PFT, echo, lung scan, and nutritional assessment based on hand grip, muscle mass, and cross-sectional area. So what are the outcomes that we have seen? Preliminary outcomes is the in-hospital mortalities, as expected, 10 to 13% across all over the world. It is similar. What is surprising is within the first follow-up, we are having very high mortality, especially in one of the university teaching hospital centers where the socioeconomic status of the patients who are getting admitted is very less. So we are planning for a verbal autopsy to find out the cause. The mortality is very high, almost 90%. Our study does has a lot of limitations. We do not have CT images on all patients, so some bronchiectasis is going to not picked up. And there is no data on environmental covariates like heavy metal poisoning, which can itself sometimes cause COPD. micronutrient assessment, especially vitamin deficiency, vitamin D, in fact. And there is no recent PFT on patients who have had in-hospital mortality, especially intubated patients who died. For those who survive, we have been able to do PFT. And lack of funding, there's been limited assessment of all your genomics, proteomics, and metabolomics. So to summarize, what we are doing is we are assessing the dysbiosis, and maybe with the help of the change in the lung microbiome, we'll be able to pinpoint as to what antibiotics is better for what phenotypes of patients. And we are also assessing the exposure risk, and based on exposure risk, we'll be able to identify how the outcomes and all the covariates that's associated with each phenotypes. And of course, genetic analysis for identification of there are any single particular genes that causes exacerbation, progression of COPD or accelerated lung function decline, which can predispose to COPD. At the protein level, we are trying to address if there are any biomarkers which can pinpoint into certain, especially the biomass COPD or systemic inflammation causing excessive cachexia or malnutrition. At the tissue or organ level, we are trying to do lung function test on almost all patients and CT imaging on limited patients. Whereas at organ level, we are assessing the respiratory failure via various indices, sarcopenia, and other organ dysfunctions, including IHT, cardiovascular diseases. So this is our team. We are a team led by young investigators, and the pillar of our team is Dr. Mahesh PA, who is a professor of respiratory medicine. And we are thankful to ISCCM for the opportunity provided at such a large stage. Thank you.
Thank you, Dr. Sumlata, for sharing the research. And we have one question for you. To keep your patient into one of the phenotype, is it necessary to for them to go on undergo HRCT every time? All the COPD patients will require HRCT?
See, ideally, HRCT all patients do not require, but if you are suspecting, very frequent exacerbation and it's not fitting into certain either your chronic bronchitis or emphysema phenotype, and you are suspecting there's bronchiectasis, that's where your CT picks up very, very well. In the sense, X-ray will not pick up all your bronchiectasis. That's one thing, and especially if you have an emphysema patient. So you want to define whether he belongs to upper lobe emphysema or you're considering lung volume reduction surgery. That's where these two phenotypes will definitely benefit from getting a CT, the bronchiectasis and the emphysema.
Thank you. So moving forward to the program, we have two panel discussion. First one is acute kidney injury and second one is ECMO. So I would like to invite a few panelists, Dr. Valentin Lobo, consultant nephrologist at King Edward Memorial Hospital in Pune, Dr. Ruchira from Nasik, Dr. Ehsan, and moderator will be Dr. Balasubramaniam from Hyderabad. So let's continue with next panel discussion on acute kidney injury.
Good evening all. At the outset, I'd like to thank Dr. Srinivas, Dr. Ghansham, and the entire HICS team for giving us this opportunity. Today with me are three eminent panelists, Dr. Ehsan Ahmed, Dr. Ruchira Kasni, and Dr. Valentin Lobo, to discuss on a very important topic, acute kidney injury. We, in the next 40-45 minutes, will be going through various important aspects of acute kidney injury. As a part of the team, we welcome you all for this academic extravaganza and wish the entire HICS team a grand success. Without wasting much time, I'd like to take forward into the present discussion. I present to you two case scenarios. The first one is a 76-year-old female diabetic and hypertensive with a history of fever and HRCT and SOP. CT chest showing a right lower lobe consolidation with a urine output about 30 ml per hour for the next 6 hours. Admission creatinine is about 1.65 milligrams per deciliter. PAN is around 34 milligrams per deciliter. She slowly progressed towards the septic shock. ABG showed composite metabolic acidosis. She was intubated in view of worsening hypoxemia. She persisted to have a septic shock requiring vasopressors, both noradrenaline. Her creatinine slowly started to creep up. On day 2, it is 2.3, and day 3, it is 3.4. And then the urine output started to dip down to 10 mils per hour with worsening ABG, showing severe metabolic acidosis, landing on to RRT and renal failure and RRT. Another 55 years male with no comorbidities with acute cerebral stroke. His baseline labs were all normal. On day 2, he was taken up for emergency decompensated for hemorrhagic transformation. On day 5, he had a VAP presented with shock. Cultures were sent. Cultures came as carbon-resistant Klebsiella. So started on colistin, Xavier and Estrona. He developed AKI on day 7 with oliguria, hyperkalemia, potassium is around 6.5, and severe metabolic acidosis, again landing up in RRT and renal failure. So we got 2 cases with 2 diseases. One presenting with AKI, and the one within the hospital over a period of time developing some secondary sepsis and developing AKI. So we got some variety of presentations around. With this background, my first question is to Dr. Ehsan Ahmed. Can you enlighten us on the changing paradigms of AKI definition and epidemiology, sir?
Thank you, Dr. Balu. So you all are aware that the AKI definition has changed from time to time. So what do we mean by AKI is acute kidney injury is abrupt cessation or decline in the function of kidney, both in the loss of function as well as the structural damage. So initially it was mostly known as ARA for acute renal failure. We used that term, but it was seen that acute renal failure means an overt organ failure of a single organ. So that was not actual scenario when you look at the broad spectrum of the disease in a critical care unit. Particularly, you see that even mild injury of kidney, both functional or structural, may lead to a fatal consequences in the future. So it does not need an acute renal failure as overt organ failure to identify to know that the consequences. So if you can identify early and if you can treat early, then the outcome is far better. So that's why these changes of this definition was thought. And if you go early in 1990s, you could see there are a lot of patients are suffering from gastroenteritis and fluid dehydration deficiency. So what happens, there is some acute renal failure occurs, but with the ORS and then better obstetric care in obstetric due to the obstetric cause, it happens that the incidence of AKI has also reduced from the single organ. And mostly in our ICU, we find mostly the sepsis as the primary cause of acute kidney. More and more research was done on the basic sciences as well as this clinical sciences. So in 2004, this ADQI or acute dialysis qualitative initiative has come with the definition of Rifle criteria to define acute kidney injury. So there was five steps in this definition. One is the risk, then injury and failure, for L for loss of function, and N for E for end-stage renal disease. So later on, it was found that even with the Rifle criteria, the early identification was difficult. So in 2007, this AKIN group, that is Acute Kidney Injury Network, they has come and they removed the GFR criteria, and they also removed the last two stages, that is the loss and the end-stage renal disease, because they said that this is a outcome change rather than this is a stage of acute kidney injury. So that's why in 2007, the AKIN criteria has come and replaced the Rifle. We made a lot of comparison between this Rifle criteria and AKIN criteria at that time. But in 2012, the KIDGO, that is the KDIGO or Kidney Disease Initiative for Global Outcome, they have come and with the Acute Kidney Injury Network, they have merged these two criteria, that is Rifle criteria and AKIN criteria, and made the KIDGO definition. So what is that? They have reduced, they have focused the definition into three criteria. That is, one is acute rise in the serum creatinine of 0.3 milligram within 48 hours. So this was the first criteria, and second criteria was 1.5 times increase in the serum creatinine within 7 days of an acute insult, or urine volume less than 0.5 ml per kg for more than 6 hours. So this is the latest definition that is going on as per the KDIGO definitions, and we at ISCCM also follow these KDIGM definitions. So these are the changes of definitions came from time to time, and in 2019 June they have come this kept the same definition, the KDIGO definitions. Regarding the epidemiology, the most of the cases of acute kidney injury occurs in the ICU. They are mostly in adult intensive care, around 30 to 60%, and above the 20% of the whole hospitalized patients. And particularly these the AKI in sepsis patients, they are in high risk of mortality. There are severe different stages like mild, moderate, or severe, and more is the severity of acute kidney injury, the more is mortality. The mortality is almost 6 times higher, and AKI also increases increases the chances of stroke and heart attack. So epidemiology wise, and this kidney failure or acute kidney injury is not a single organ dysfunction syndrome. You cannot define it like that. There are multiple factors, and probably this is the beginning of multi-organ failure. So this can be taken as a whole of a spectrum of syndrome, so which influences the ultimate outcome.
Thank you, sir. To sum it up, what I understood from what you said is the definition has evolved from the clinical to the molecular level, and the risk involved because of multitude of magnitude of cases involved with AKI, it increases the mortality. Thank you, Dr. Hassan, for beautifully explaining the definition and the epidemiology. With this background, as in our case scenarios, my second question to Dr. Ruchira. Can I predict the risk of AKI early, or can I predict the progression of AKI? Like in my first case who presented with AKI, either to a recovery or AKD or CKD. Can you explain us on biomarkers in AKI?
Yeah, thank you, doctor. Basically, biomarkers are the molecules, biological substances which are released in response to stress. And now in case of acute kidney injury, in response to the tubular epithelium. In literature, we know there are various biomarkers mentioned, like functional biomarkers, structural, and as well as inflammatory biomarkers. But still, we are in search to have an ideal biomarker which detects the acute kidney injury away prior at the time of insult. It is observed that the biomarkers which are released from the tubular epithelium, that is the site of an injury, and not the glomeruli, have a better sensitivity to diagnose the acute kidney injury. And so there is a lot of literature on the on urinary biomarkers like NGAL protein and L-fatty acid binding protein. Now, the guidelines, the recently published guidelines by Indian Journal of Critical Care Society, they have suggested to follow, to use these biomarkers, NGAL and FABP, to predict the severity and mortality and for early diagnosis. But a biomarker which is cystatin, which is another biomarker, the guideline is against using cystatin to predict the severity and the mortality in case of acute kidney injury. Then one set of biomarker which is predictor of, which is a marker of cell cycle arrest. There are two biomarkers basically. One is tissue inhibitor metalloproteinase and another is insulin-like growth factor binding protein 7. So these two biomarkers come in a kit, which in market is called as a NephroCheck. This is little more sensitive and is now recently coming up, which is FDA approved, and they have given a objective criteria. Then at a point, if the level is less than 0.3, then we can predict risk of acute kidney injury way prior, and if it is less than 0.3, then there is minimum risk of acute kidney injury for next 12 hours, and if it is more than 0.3, then there is more moderate to severe risk of acute kidney injury. Now, the novelty of this biomarker is that it is not affected by non-renal organ failures, and as well as if you see the AUC of this biomarker, then it is 0.8, which is quite good. So these are the advantage of this cell cycle arrest biomarker, these two biomarkers. Now, what the ADQI guideline is saying, that we just cannot rely on a biomarkers, but we need to clinically correlate, and with the support of biomarker, we can predict the risk of acute kidney injury. Now, in this slide also, you can see, can you show the next slide, Dr. Balu? Yeah. So these are the two biomarkers, TIMP2 and IGF-BP. You can see that at the early stage of acute risk, at the risk stage only, you can, if these biomarkers are elevated, then you can predict the risk of acute kidney injury.
Thank you, ma'am. And to sum it up, I mean, this is the area that has changed the face of AKI definition, what Dr. Aisan was also saying a couple of minutes back. And it's an evolving concept. I mean, as you said, the cystatin C and NGAL, which we have been using prior, now it has changed to IGF-B7 and TIM2 product.
Yeah.
So that gives us a slightly more better answer. Probably we need to wait and see how we use, as you said, it's newly implemented. Going forward in my both the case stories, with all the controversies around the renal replacement therapy in acute kidney injury, I request Dr. Valentine Loboso to explain us the indications and timings of RRT on my patient. Do I need to really wait for them to come down on the urine output lesser than 0.5 mils per kg per hour, or worsening acidosis? Definite indications. Any role of fuel-smart test? Kindly enlighten us on the indications and timings of RRT. Dr. Valentine Loboso.
So there are some absolute indications for renal replacement therapy. Any patient who has hyperkalemia, which the second patient has, a potassium of 6.5, both of them have severe metabolic acidosis. These are indications, absolute indications. And the third is, of course, pulmonary edema not responsive to diuretic therapy. These three are absolute indications for renal replacement therapy, and there would be no delay in starting renal replacement therapy in a patient who had any of these. There are also some relative indications. Blood urea of more than 200 is taken. Dysnatremias, a dialyzable drug toxicity when it is suspected, and also to create space sometimes in patients who have large volume requirements. So a patient who is receiving, for instance, total parenteral nutrition may get about 1.5 liters to 2 liters of fluid for that, maybe receiving blood products to combat coagulopathy, maybe getting antibiotics as infusions, and maybe getting infusion like the first patient who had community acquired pneumonia with septic shock and is on 2 inotropes, noradrenaline and vasopressin. So this patient's total requirement of fluid in the day would be pretty large, and maybe to the tune of 2 to 2.5 liters a day at least. So such a patient, for organ support, might be initiated early on renal replacement therapy. Apart from the deleterious effects of volume overload, we know that if you have an oliguric or anuric patient who gets large volumes of fluid, then on already compromised lungs, an acute lung injury is going to be worsened by volume overload in this situation. But there's also today the concept of organ crosstalk, and so there are other mechanisms by which an acute kidney injury may be affecting distant organs. Whether this is changed by renal replacement therapy, however, remains a matter of controversy. You did mention the furosemide stress test, and the furosemide stress test does help to predict the need for renal replacement therapy. Very simply, when a patient is naive to furosemide, he is given 1 milligram per kilogram of furosemide, and at 2 hours should have at least an urine output of 200 ml. Such a patient is less likely to receive renal replacement therapy, whereas a patient who does not have an output of 200 ml at 2 hours is more likely. So the test predicts that such a patient would require renal replacement therapy. Now, as far as timing is concerned, when any of the absolute indications exist, there would be no doubt about going ahead with renal replacement therapy. Fortunately, there are 4 excellent trials, all randomized controlled trials, all extremely well done, which looked at early versus a delayed or a normal start to renal replacement therapy, namely the AKI-KI2I study, the ELAINE study, the IDEAL ICU study, and the largest of them all, the START AKI study, which was twice as large as all the other 3 studies put together. Now, what 3 of these studies showed was that there was no difference in an outcome, a hard outcome of 60-day or 90-day mortality with either the group who had waited for an absolute indication or the group who was started within 8 to 12 hours of developing AKI3 without an absolute indication for renal replacement therapy. The only trial to show a benefit was the ELAINE trial, and that was a single center study. And really, the late group of the ELAINE study was the early group of all the other 3 studies. So the ELAINE was very early versus early renal replacement therapy, and it was the only one, and there has been controversy regarding the methodology of that study. But what the other 3 studies showed was that 50% of patients who were not started on early replacement therapy without an absolute indication recovered without ever needing renal replacement therapy, and there was also a higher risk of complications, hypophosphatemia, hypokalemia, and also catheter-related bloodstream infections in the patients who started renal replacement therapy early. So if I had to sum it up, some absolute indications, pulmonary edema, hyperkalemia, metabolic acidosis, especially in an anuric patient, and in other indications, maybe relative indications for as organ support where required, and these will need to be judged on a case-to-case basis.
Thank you, sir, for that excellent short summary. With that thing in the background, I'll definitely pose the next question again back to you. Can you tell me, how will be your prescription practices of various modalities of renal replacement therapies, and what will be your goals?
Yeah, thank you. I think your 2 cases illustrate this very well. The first patient we have has a community-acquired pneumonia, has developed an anuric AKI, and has severe metabolic acidosis. Now, this patient, like I said, is probably going to get at least 1.5 to 2 liters of fluids based on inotropes, antibiotic infusions, and nutrition in this patient, and the patient is anuric. So this patient is on a ventilator, and the ventilation is going to be compromised. Hypoxia is going to develop if we don't remove fluid. However, we do not want to precipitate a hypotension or a hemodynamic instability with our renal replacement therapy. So we will have to optimize removal of fluid and at the correct ultrafiltration rate without doing harm. So this is a patient in whom I would prescribe continuous renal replacement therapy. I would discuss with my entire team what is the likely amount of fluid that the patient is going to receive today and target a negative fluid balance, at the same time maintaining my ultrafiltration rate in CRRT. And that's possible to do because here the treatment is going to be 24 hours long. I would not exceed an ultrafiltration rate of 1 to 2 ml per kg per hour, which has been shown to be optimum in 2 retrospective analyses, including the one from the renal study. The second patient has severe hyperkalemia with a potassium of 6.5 and has never been oliguric. So in this patient, I would opt for an intermittent therapy because hyperkalemia will be more rapidly corrected by an intermittent or a prolonged intermittent therapy than a continuous therapy. The only concern and this patient does not require fluid removal. So perhaps I wouldn't even be choosing to ultrafilter this patient at all. I would be looking mainly at a diffusive therapy to target hyperkalemia and correct it. What I would do is perhaps to put this patient on a sustained low efficiency dialysis. I would target a blood flow of between 150 to 200 mils per minute. I would keep my dialysate flow as low as the machine can possibly go. With a 4008 series machine, that's 300 ml per minute. With a 5008 machine, one can go down to a dialysate flow of 100 ml per minute. And I would ensure that in this situation, I would check my serum potassium at around 6 hours or 6.5 hours after initiation. Make sure that it is in the target range, that is between 3 and 4 at the time of terminating my first renal replacement therapy session. The only concern about intermittent therapies in a patient like this is that this patient, albeit 7 days ago, started off with a traumatic brain injury. And there is some concern that intermittent therapies may increase intracranial pressure and worsen a traumatic brain injury. However, in a study that was done by Vincent Wu from Thailand, what they were able to show was that SLED worked almost as well as CRRT in terms of maintaining intracranial pressure and cerebral perfusion pressure. So the patient who needs more fluid removal at a gentle rate, CRRT. The patient who needs more diffusive clearance, who needs to target hyperkalemia and metabolic acidosis as larger dangers, I would go for a diffusive therapy like SLED.
Thank you, sir, for that excellent short summary on the RRT practices. As already has been illustrated by Lobo, sir, with these patients, we will be having a large amount of fluid resuscitation in their time in the ICU around. So, which will lead to a larger volumes of distribution. The protein binding will come down because of low albumin and this thing. So, we know in chronic kidney disease patients that we have to tailor the drug dose adjustments basing on what's the creatinine clearance. That's the same practice we need to do in AK. My next question to Dr. Rachira.
Yeah, thank you, doctor. Basically, the antimicrobials are obviously the essential part of any life-threatening infection, and the optimum doses of antimicrobials are concerned, especially when the patient is a case of AKI and on RRT. So there is a very complex interplay because of various factors like patient's volume status, then pharmacokinetics and pharmacodynamics, like volume distribution, then drug metabolites, bioavailability. And addition to that, as these patients are going to be on one of the modalities of renal replacement therapy, there is additional concern of like the possibility of drug removal on the circuit by either diffusion or convection or adsorption. So, as these patients are into some sort of infections, there is increased volume of distribution. So, basically the traditional, GFR calculation formula, which is based on the creatinine levels, is meant for CKD patients and not for acute kidney injury patients. So, even if our patients, both the patients are having increased creatinine, and in one of the patients is non-oliguric, in spite of increase in the creatinine, we should go ahead with the higher doses of antibiotics, considering the increased volume of distribution and the loading dose. So one should not change the loading doses. If this patient is on any of the renal replacement therapy, like for example on a hemodialysis, then post-dialysis, one should give additional dose of antibiotic. Now, if these patients are on a CRRT, it is little more complex because again, there is a possibility of loss of these drugs through the CRRT membrane and there is increase in the volume. So ideally, there should be a therapeutic drug level monitoring, but which is not possible every time. So best is to give additional doses of antibiotic and to have a optimum drug plasma concentration. And so we should treat these patients aggressively, though they have a increased creatinine levels. That is my message, that one should not use the GFR formula and modify the doses of antibiotics. Addition to that, these concerns of protein binding and molecular weight. If the protein, the antimicrobial having a more protein binding, then there is going to be a less clearance, or higher molecular weight is going to have a less clearance. So there is a lot of complex interplay when these patients on CRRT and having acute kidney. Yeah, thank you.
Thank you, Richard. As I can understand, the major concept of what you're trying to tell is the loading doses should not change, and they may have a higher volumes of distribution or higher filtration fractions depending upon the modalities of RRT. So you need to be dosing them on the thing. I mean, the best example I can take is colistin, which I think 20 years back, I mean, when we started with 1 million unit TID. Now we know that it's 4.5 BD, and in CRRT with polymyxin guidelines, it's 6.65 BD. So they increase the dose requirement based on the volumes of distribution and height.
And the loading dose is also high if the patient is on CRRT. We don't use 9. In fact, we go high on 12 million.
Yeah, 12 to 13. Yeah. Thank you. Having known this, I mean, having discussed with more general aspects of AK and RRT and the drug dosing, my next question, slightly more specific to Dr. Hassan, is in both these entities, the sepsis or AK that is called as SAK and contrast nephropathy, are there any specific measures to detect or to treat these problems early? To Dr. Hassan. Sir, you have to unmute.
So, sorry for the mute. So, first of all, we have to know whether it is a sepsis-associated AKI or the contrast-induced AKI or nephropathy. So, first we have to detect as early as possible to have a good outcome. And then our question will be how to treat early to prevent for a better outcome and prevent the severity of the injury. So regarding the detection, early detection, Dr. Ruchira has already explained about the biomarkers. So they are not much used in our clinical practice day to day. But yes, we can use those, take the help of those. But first and most important thing is that we have to know which patients, which subgroup is in the risk of developing AKI. That is very important. And you know that in sepsis, it is not a single etiology. There are multiple etiology coexist, like the sepsis itself injures the renal tubular epithelium, then ischemia, then nephrotoxins like the product of the sepsis, inflammation products, the antibiotics we give, then there the volume status of the patient. So there are so many things interrelated. So we must have to identify the risk group of patients. And secondly, we have to follow some care bundles, just like in prevention of ventilator-associated pneumonia, we use VAP bundle. So here is also we can use some acute kidney injury care bundle, AKI care bundle like that. So and we have to identify and prevent those subclinical AKI. And the care bundle includes hemodynamic monitoring and optimizations. I request all listeners to follow the ICCM guidelines on AKI and RRT that is published last year in the ICCM. They're very good guidelines ready to use in hand. So hemodynamic monitoring and optimization, what will be the hemodynamic goals? Like in normotensive patient, it is 70 to 75 millimeter of mean arterial pressure. For patient of chronic hypertension, it is 80 to 85 millimeter of mercury of hypertension of MAF. So these are all mentioned in these guidelines we can use. Then volume optimization is very important. How much fluid you will give. Obviously, it will not be same for each patient, each type of patient, like someone with ejection fraction of 20%, someone with a normal ejection fraction. So you have to individualize the volume, but you have to give a euvolemic status and also what fluid you will use. Just like in this guideline, it's clearly mentioned that don't use starch or gelatin or dextran for increasing the volume. Just use crystalloids, preferably a balanced salt solution. If it is not available, you can use simple normal saline. So that are the component of an acute care bundle like of things. Then avoid hyperglycemia because it was found to be associated with more injury. If something starts acute kidney injury, whether it's a structural damage or a very early functional dysfunction, we have to prevent in that way. So we have to prevent hyperglycemia because it was seen that hyperglycemia is associated with more severe injury of the acute kidney, of the kidney. And then avoid all sorts of nephrotoxins. If you have to use colistin, if you have to use aminoglycoside, you may decrease the dose or you may increase the interval. So there are lots of optimization. So if you involve some clinical pharmacologist in your ICU, then they will give you an idea of which drug can be avoided. How can you avoid nephrotoxicity with even known drug which are causing it? And then prevention of perioperative AKI, there are lots of paper regarding use of statin and other things, vitamin C, to prevent those perioperative AKI. So there are no robust evidence, but they are sometimes used, and we find and there is some. And regarding this contrast-induced nephropathy, as you all know, that is whether it is a CI and contrast-induced nephropathy or it's a contrast-associated AKI. The change of definition varies from time to time, and there is a lot of debate regarding whether the contrast was direct injury or is associated with AKI due to some various reasons. And there are different type of contrast, that iodine contrast, non-iodinate contrast, then the gadolinium, which causes nephrogenic systemic sclerosis. So we have to keep all in mind. There are a lot of studies, small studies. Then there are debate whether you have to use sodium bicarbonate based fluid or a normal saline simply. Then how much fluid, whether it's a 1 ml per kg of body weight or more than that. Then there are a lot of debate. There are micro study, and there are meta-analysis, and there are rather meta-analysis or meta-confusion. The confusion is still not clear. So these are the things. There are studies that like this amazing trial, and lastly PRESERVE trial is a large multi-center trial which showed that no additional benefit of giving bicarbonate therapy. But obviously, volume optimization is very important. So only one evidence that is sure grade 1A evidence, if you think, it is the volume expansion for prevention of the contrast-induced AKI. But there is no role of prophylactic RRT in contrast-induced AKI. There are still debate whether arterial injection of this contrast is more detrimental than transvenous injection or not. So these areas are still under debate. We need probably a lot of studies with more number of patients, more number of centers. But for the time being, it is said that early use less dose of contrast, pre-optimize the fluid before giving the contrast. So these are the two things that have been shown to improve the outcome after the contrast-induced AKI.
Thank you, Dr. Esther, sir. I think you have excellently concluded both the things. It was just for the sake of students. All the green, all the things that are marked in the green are said to be beneficial. All the things that are in yellow, doubtful. The NSL system also, again, it goes with the same principle as what sir was saying around. Other than volume expansion, there are nothing in the contrast to the AKI. Such as the AKI, as what sir is saying, across when you look at the damages to molecular patterns or pathogenesis molecular patterns, they are the main convicts for the major things. The reason for that biomarker TIM2 and IGF-B7, as what Ruchira was also saying prior, is it induces the cell cycle arrest. This is where it comes from. So that's one of the major marker at the earlier part, so you can pick up a risk, the area under the cover 0.8, what she's mentioning in this thing. So I think we have covered significant amount of things. I thank all the panelists for sharing their valid thoughts on this very important topics. Any of the three panelists, do you want to share anything more, sir? It's open for everything. Any other conclusion things that you want to tell the students, sir?
Thank you, Balasubramanian sir, for moderating this session. And almost majority of the questions were answered by the panelists. So moving forward to the next session, next panel discussion, which is on ECMO. So I would like to invite Dr. Gopal Rawal, Dr. Niranjan Manigrahi, Dr. Arpan Chakraborty, and moderator will be Dr. Sambit Sahu. Let's begin the second panel discussion.
Good afternoon, dear panelists, and welcome to the 8th edition of Hyderabad Intensive Care Symposium. We have an interesting panel today, interesting topic of discussion, that's ECMO, which has come into vogue post-COVID. And we have with us very accomplished panelists. We have Dr. Arpan Chakraborty, who's a senior consultant and head of ECMO team in Apollo Hospital, Kolkata. And he's been a pioneer of sorts when it comes to ECMO and introducing ECMO all over India. And he's also chaired, he's a very enthusiastic member of the ECMO Society. And on second, we have Dr. Gopal Rawal, who's a consultant pulmonologist, critical care and sleep disorder from Sterling Hospital, Ahmedabad. And we have a young enthusiast, Dr. Niranjan Panigrai, who's also a consultant critical care and head ECMO team in Apollo Hospitals, Jubilee Hills. And we'll try and take this discussion on ECMO, on what are the current dilemmas that ECMO centers and ECMO doctors face. Because a lot of centers now are able to initiate ECMO, but the challenge begins once you maintain them on ECMO. And we'll divide this discussion, and the themes of this discussion would be primarily on infections, anticoagulation in ECMO, weaning and when to call off ECMO, because that also involves a lot of ethical dilemmas. So welcome panelists, and let's start with the first question to Dr. Gopal. So Dr. Gopal, what are the challenges you face in detecting sepsis when a patient is on ECMO? Because there are a lot of confounding factors because of ECMO as a circuit, and when it comes to diagnosing sepsis or for a patient on ECMO.
Though our center is now we have started, we are doing ECMO for last 4-5 years, but the number of patients we have less. But as our hospital, we see that to diagnose sepsis on when the patient is on ECMO is very challenging, and you have to keep the high index of suspicious for diagnosis of sepsis, because there are multiple lines are there, invasive procedures are going on, and then already the patient's the status of the immunity is also low, and the patient has already taken so many antibiotics and the things, and sometimes the symptoms are competing with the inflammatory response also. So you have, and sometimes the patients are not able to have a classical signs and symptoms of the sepsis, septic shock. So we have to keep a very high index of suspicion for diagnosis of sepsis. We have to send the cultures, tracheal cultures, blood cultures. If the patient having urinary catheters, then catheter related is infected. That kind of things we have to send.
Yeah. Dr. Arpan, would you like to add something to it? You're on mute, Dr. Arpan.
So diagnosing sepsis is in ECMO is a very, I would say it's an art rather than a science, because all the manifestations of sepsis which we found in non-ECMO patients, like fever, like patient is perspiring, and all the features are not very much prominent in ECMO. So the dilemma starts when whether it's a sepsis or it is the deterioration of the primary organ function. That's a problem. In long-term patients where the ECMO run is more than 10 days, 14 days, what we look out for, is there any rising lactate? So that is the first signs many a times shows that your lactate is started rising suddenly. Second one is the sudden fluid shift. The patient was doing fine throughout for last 2 weeks, and suddenly he has started having some fluctuating flows. You need to give 1 liter of fluid suddenly within next 2 to 3 hours. Sudden changes of this peripheral vasodilatation, so that the fluid shifts happening. Another one is many a times this happens suddenly. There is a gradual decrease in the platelet count, which has to be taken in, particularly in pediatric patients. Even in adults, it is many a times it is the manifestation of sepsis. Always or not may not be the hypotension or rising vasopressors may not be associated with that, but these are the indirect parameters, and we have seen increasing sodium for initial 48 to 72 hours is also manifestation as having landing up in slow sepsis or a kind of a septic thing is happening. So these are the things you have to keep in mind. And other things in pediatric patients particularly, features of peripheral embolization, small digital ischemias. These are also shows that some sepsis is happening somewhere. You have to rule it out.
Yeah. Well, I think there is some connection issue, but yeah, now it's clear. Yeah, you were right that we need to look at the subtle signs of sepsis and not the traditional and the conventional signs of sepsis, because they can be very confounding. I would just like to add that sometimes you also have indirect markers, the sugars jumping. And then you also have a sudden rise in the PT, APTT. And these all would be also indirect markers of start of sepsis. Now, my second question would be with respect to how do you diagnose infections? On ECMO, do you still need to use the conventional methods, or we have evolved or can we adopt some newer methods? And Dr. Niranjan, could you shed some light on this?
Yeah, thank you, sir, for such a nice introduction and nice elaboration. Now, coming to the topic, so diagnosing sepsis in an ECMO patient, I fully agree with Dr. Arpan Chakraborty, sir. Now, it is more of a art than with a little bit of science, definitely. Now, there are a lot of research going on, and there are a lot of debate on the conventional methods of diagnosing an infection, diagnosing a sepsis versus the newer world. The new world is coming with so many techniques. Now, let's start with the conventional methods. And of course, it has its own fallacies. Now, conventional methods of source may be the heart rate, respiratory rate, temperature, and leukocyte. Now, there are various other causes in a ECMO patients, non-infectious causes, which can explain a heart rate to go up or low, a respiratory rate or a temperature to fluctuate. Many a times, because of this extracorporeal circuit, which loses an enormous amount of heat, our patient may not mount a proper temperature, proper fever to document as infection. Now, but again, there are some conventional markers. It starts with again lactate. Many a times, a simple desaturation. If a patient struggle to breathe on an ECMO, also sometimes indicate, okay, maybe probably the patient is developing some infection somewhere, may not be the lung, it may be somewhere. That's the reason the oxygen utilization or the catabolic state has settled in. That's the reason the patient's oxygen requirement is going up. In that sense, again, we sometimes keep on seeing the pre-membrane saturations particularly. So like there are so many centers and there are some studies also, they correlate the pre-membrane the saturations with the hypercatabolic state. It may be infection, maybe some other states as well. Now coming to the newer methodology. So the world has evolved from simple CBC or simple culture methods to various newer techniques. Now it starts with the multiplex PCR based diagnostic modalities. So if it is a bloodstream infection or a VAP or a like any other site infections, so we can collect the sample and run our sample against the reserve plate or the multiplex PCR plate, and it is easier and a rapid method of diagnosis. But there are some problems with it. The problem is, so it detects the genome, even colonization or contamination, infection, even a dead bacteria also can be. So it can pick up the genomic material of those things. So the sensitivity is very, very high of these tests, but we need to again correlate precisely with the patient's condition, if it is actually infection and where is exactly the site. So the interpretation matters, then the result itself, of RT-PCR. The next generation comes the metagenomic assay. Okay, so what recently, even the Biomerics, the biggest the company who comes with the microbiology products in all kits and other things. Now Biomerics is doing one study. Now, according to them, they want to predict the genomic. Now, there is a flow chart. Now, they run according to the days on ECMO, according to the patient's profile, the ethnicity comes from hospital versus community. So, we need to enter all the data, immune compromised versus immune suppressed. Now, that a pre-test prediction modality. followed by a test running, that's a genomic analysis. So that gives the probability that probably this patient on 10th day of ECMO, probably if developing some infection, then there is some X percentage of this infection, Y percentage of this infection. That is a predictive modality. But again, to be very precisely to use in patients, it may take some years, or maybe after 5 to 10 years, probably that will be the important modality to use that thing. But there are a lot of research going on, especially immunocompromised patients and ECMO patients and various other patients. So that is one more modality. So these are the two newer techniques which probably can find out some solution to this dilemma in future.
Yeah. I think these predictive models will keep on changing as the algorithm changes. But even we have seen, and I'm sure Dr. Arpan and others would agree that that the infections in ECMO, they also follow some kind of pattern. Initially, it would start off with a more or less partly sensitive gram negative, and then MDR negative, and then they would come into escape bugs, and then fungal adds in, some kind of pattern. It's not, I wouldn't call it is absolutely correct sequence, but some pattern. Now, Dr. Arpan, how do you plan for the ECMO, the type of ECMO to be used in a patient who's in septic shock? And what are the considerations for that? Whether you have to right away go for you want to initially try a VV ECMO, or when do you want to go for a VAV, or you want to go for VA right away? So how do you plan this?
So up till 2017, I used to consider septic shock as a contraindication for ECMO. After that, as our experiences went up, we gathered some amount of courage to intervene into the septic shock situations, which are multiple in our ITUs, and probably the most common indication of ECMO if we could put and give good results. And we burned our finger after that, because we ventured out into the septic shocks and they have not given a good outcome. After that, we started studying things where are the places actually the septic shock ECMO are doing great. So if you have a septic shock and if you have a bad LV, your ejection fraction is 20%. If you have a septic myocarditis, patient is having a blood pressure of 40/20 with a your ECMO. But the patients who are having septic shock with a preserved LV and they have a very hypercontractile your hemodynamics, your ejection fraction is probably more than 75%, and they are losing the volume from the capillaries. They are not the candidate who are going to do great with the ECMO, because ECMO can support your lung, ECMO can support your heart, but ECMO is not to support your capillaries. So the sepsis with capillary leak with good LV is not a candidate for an ECMO. But a septic shock with a myocarditis, with a bad ejection fraction is a candidate for ECMO, however, how bad they are. Now, what we give, either we give a VV first or VA first or VAV direct, that will depend on what is the presentations. Sometimes the septic shock with ARDS is the predominant feature where the saturation is also down. So you can start with VV. If they are not settling, go to VAV. Sometimes the hypotension is the main cause. You have a septic myocarditis is the cause. You first start with VA, stabilize the patient, and if you have a harlequin after that, and then you go for a VAV. For your VAV from the as a primary VAV. So my idea of treating it is absolutely clear. Septic shock with bad LV is a candidate for ECMO. Septic shock with good LV, go with the caution. If you can come out septic shock with good LV with ARDS with VV ECMO, it is better. Many a times VV ECMO with some amount of vasopressors will be the better choice. Don't go for VA ECMO. That is not going to give good results in that situations.
Absolutely. I agree with you. And we'll come to this because we have Dr. Niranjan who will be sharing his experience also later on this capillary leaks in sepsis and dengue and how to do it, how to go about ECMO and what would be the likely outcomes. Now, with respect to treating infections for patients on ECMO, we have a dual challenge. On one hand, we give them antibiotics. When do you intervene for circuits? When do you intervene with the circuits? So maybe we can first take from Dr. Niranjan on what are the antibiotic strategies to optimally treat the patient with respect to the drugs, the duration, or loading initially. And then we come to Dr. Arpan, who can shed some light on how to tackle the circuit when it comes to infection and when to tackle the circuit. So Dr. Niranjan, if you could shed some.
Yeah. So now, whether it's an ECMO patient or non-ECMO patient, now the basic principles what are taught in the pharmacology class remains the same. Now we need to extrapolate those informations here as well. Now the basic physiology says the volume of distribution and the so the loading dose and the maintenance. There are the two dosing for antibiotics. The loading dose depends upon the volume of distribution. Second, maintenance dose depends upon the clearance. It is same anywhere. So let's start with the loading dose. There are two kinds of antibiotic. One is either it's a lipophilic antibiotic or second is a hydrophilic antibiotics. In hydrophilic antibiotic category, it's either cephalosporins, carbapenems, or all those antibiotics. The volume of distribution matters. The reason is body has some fixed percentage of water. It's determined like 60% of water is there in the body. In a sepsis patients, when they come to our emergency, so we load them with some 2 liter, 3 liter of extra saline. That means it is the water content of the body, which goes disproportionately high, not the lipid content. Now, whenever we start with antibiotics, so that aspect should be taken care. Now, the blood, which was near about some 4 liter, 5 liter, right now we have added another 3 liter of fluid. So the antibiotics should be considered accordingly in a hydrophilic category. Now, coming to the ECMO patients, again, ECMO adds to the volume of distributions. The circuit adds to some amount of, again, the aquatic person. So aquasoluble antibiotics, whenever it is initiated, the volume of distribution is high, especially if the patient is in sepsis, if we have resuscitated, if we have given some priming fluids or a blood, and we have filled the fluid compartment of the body. By rule, all aquasoluble antibiotic must be given with a loading dose. Now, without a loading dose and with a loading dose, the therapeutic concentration, which ideally it is expected to with between 4 to 6 half-lives or the dosings, that will be like extended to 6 to 9 half-lives. So this is a well like studied phenomena. So this is clear regarding the aquasoluble antibiotics. Now coming to the maintenance dose of aquasoluble antibiotics again. So patients may have some limitation in terms of the clearance because of again two factors. First, there might be some renal issue. Usually ECMO patients, they are sick patients. They might be having renal hypoperfusion or they might have in AKI. So the dosing should be adjusted as for the creatinine clearance of a patient. Now, second, coming to the lipophilic antibiotics, volume of distribution usually doesn't increase in case of the lipophilic antibiotics, but the maintenance dose is expected to be altered. The reason, because of two reasons again. Now, first, because the whole of the circuit, which is expected to sequester, the proper word is used to sequester the lipophilic antibiotics, including the membrane. Okay, it can decrease the efficacy of the lipophilic antibiotics. First, second thing, in some cases, the renal phenomena can again affect the clearance of the lipophilic antibiotics. So now there are some recommendations. There is a table for which kind of antibiotics to be how to be used. Now I will try to highlight specifically the common antibiotics which we use. Now let's start with the meropenem. Whenever meropenem is used, a loading dose of at least 2 grams should be given if we are starting in a patient whom we have initiated ECMO, is in shock, we have dumped maybe some 2.5 or 3 liter of fluid. A loading dose is must. That comes as per the recommendations. Next comes to colistin. Again, one more most commonly used or misused antibiotic, whatever we may tell here. So the loading again, so various centers they use variably. Now our team, sometimes we prefer to go up to 12 million units. So like some centers, even I came across, they're using 15 million units of loading dose of colistin. I would like to listen from other panelists here. But the loading dose, it's like right now we are using a 12 million unit. And the maintenance dose also, it's the same, around some 9 to 12, depending upon the patient status. If patient is having a very good renal function, then my team, usually they go up to 4.5 TID dose, which equivalent to up to 12 to 12.5 million unit per day. Of course, it's a supra therapeutic dose, but in a patient with ECMO, so there are some studies, they have recommended to go with little high volume. Then for other antibiotics like vancomycin, gram-positive coverage, teicoplanin also, they have recommended to go for like higher dose because of the distribution again. So whenever initiating, like unlike a non-ECMO patients, antibiotic prescription, loading and maintenance should be equated with the patient's volume distribution as well as the clearance.
Yeah, I think so thank you, Niranjan. So, I mean, if you can just summarize, so, you know, the way to go about is the best way is there are enough research and enough evidence available and which are very published, and we can have a chart fixed in the ECMO besides the patient and just follow it. But I'm sure that depending on the lipophilicity and hydrophilicity of the drug, we would have to strategize whether we need to go higher on the initial loading dose and the maintenance dose. But again, more important is when do you intervene? Because traditionally we have been taught that if you have a bloodstream infection, you have to change lines. Now here you cannot change lines. So, but when you intervene, if not to change lines, to change the circuit, what would be the triggers to at least make us start giving it a thought? Dr. Arpan, if you could elaborate on it.
Sir, the recent studies, though I forgot the name, they have shown that it is the commonest, the CVP line is the commonest source of infection in the ECMO patients. So line changing is absolutely mandatory. If you're getting a bloodstream infection, you have to change the central line. That is the sacrosanct what we do. Changing the circuit is always a very optional thing and may not be, the option is always available to you because of the cost, because of the logistics, because of the patient is so much dependent on the circuit and all these things. Patient might arrest in between. You are not in a center where you can change it within 7 to 10 seconds. So this is a difficult situation. So my take on changing circuit is a bit reserved. And whenever I am pretty sure that after changing the necklines, it is the circuit, infection is not coming down, and you have the features of circuit DIC, you have features of severe thrombocytopenia is happening, you are with your coagulation profile also, and that is contributing because of the circuit DIC. You have new clots which are there in the circuit. You can see the oxygenator. So these are the indications where I'll change the circuit. If not, the circuit has passed well of its 21 days of mark or a month of mark, which is another parameter of changing the circuit. So circuit change is probably the secondary, and it has to be done judiciously and to keep the safety of the patient. But neckline and CVP line has to be changed immediately and has to be changed. Many a times we have changed, removed the neckline, and we have ran the peripheral cannulas also because of the areas are not very much to put the lines, next line also. But you have to remove the central line because this it has been proved that central line is the commonest cause of infection in this kind of patients. And you don't, many a times you don't have the options of the changing the circuit or your cannulas.
Yeah, even that has been our experience that it should be, at least for infection, it should be the last thing to consider because it's easier said than done. And since you brought up logistics and finances as a big consideration when we go for this, so prevention is always better. So if I may ask Dr. Gopal, so how do we prevent infections? I mean, what are the strategies you use to actually not land up the patient in such with devastating infections and its complications?
Yeah, that we see that if the infection occurs and when the patient is on ECMO and already non-ECMO, the mortality and the morbidity is increasing. So always when we plan for ECMO, so we go for a proper sterile conditions. When we are cannulating the patients, preferably with proper hands, and even if possible, do with the ultrasound guided, and the proper maintaining of that cannulations and the line, and the drugs and the IV fluid should be given in a separate peripheral line. The properly, as Dr. Arpanis mentioned, if I'm comfortable with the wide bore peripheral needles, then we used to give the drugs with the peripheral cannula, and the preparations properly. Nowadays, studies showing that chlorhexidine is better than the alcohol plus betadine, so preparation should be there. And the most important thing is when the patient is on ECMO, then the patient should maintain the reverse isolations. So patient of ECMO should be kept in that way that the chances of hospital-acquired infection should be avoided, and proper one type of barrier nursing should be maintained to prevent the development of the infection. Because once the infection occurs in a ECMO patient, then you will have all the challenges and logistic come in front of you to explain the patients regarding it. So that's the most important thing, the reverse isolations, and take all that infection control measures should be taken properly to prevent the infection.
Yeah, so this is, I absolutely agree with you. And we had done an observational study and we found that at least 60% of the patient cost goes behind antibiotics on a patient on long run of ECMO. And that is, and that sometimes adds up so much burden on the patient family that they even give it a thought to call off ECMO. So infection would play a very crucial part.
Yeah, can I add a few points?
Yeah, please.
So, so some of the specific measures, we adopted. Of course, we learned from our mistakes from the previous, during the COVID and after COVID time. Now, what we observed, so no one makes a mistake during cannulation. Everyone follows the strict aseptic protocols. Even the sisters maintaining the line and other things, that's fine. Now, what we observed, the three aspects of a ECMO patient which we thought need to be addressed in terms of infection control. The first thing is the environment. Environment means the bed sheet, the blanket, the linen, the pillow cover, so the cozy sheets, and even the mop sheet which comes for the mopping of the patients. So nowhere it comes from the hospital laundry, but it's not a guarantee that they will not harbor any resistant bugs. So what we made a policy for at least ECMO patient, unlike our other patient, ECMO patient will stay for a month together. Now, even they can harbor, even if in the quantity of infection or the quantity of the contamination is less. So we asked our CSSD to issue all these materials. So unlike other patients, all ECMO patients, blanket, linen, whatever is using, that will come from the CSSD. That's one area. Now the second thing, the water in which we clean our hand. So that's regularly we practice, we always think that probably the overhead tank is being regularly cleaned, or the municipality water, it's not necessarily always true. So we practiced two steps. We told them, okay, you have to do the way you are doing the hand washing. Okay, then not like the sterilant, by using the soap. Okay, so that anyone and everyone, irrespective of they are going for any procedure, any person going to the patient area, maybe a physician, maybe a pulmonologist going to examine also, they are mandatory to do their hand washing and clean their hand, and they have to go. Then third thing, of course, this is not with proper evidence. We have kept cap, mask and gown. That is to make sure that unnecessary people will not enter the ECMO patient's area. Now, so these are the specific things we have tried, and we are collecting some data on the infection in ECMO patients. So probably our result can tell whether these interventions, small interventions, are helping or not.
Yeah, thank you, Dr. Ranjan. So, yeah, as well said, I mean, these are few learning things about the CSST thing that you mentioned. Maybe we should try that. Makes some sense there. So if we can now move to the second theme, and which is also very challenging, a shift in the way people are practicing, is with respect to the anticoagulation strategies. I mean, traditionally, we all have used lots of heparin during anticoagulation, but I can see a shift happening from heparin to bivalirudin. So, Dr. Arpan, if you could tell us, I mean, why are people moving from heparin to bivalirudin? What are the advantages, and what other new drugs or circuit changes are there now to reduce the usage of heparin and its consequences?
See, bivalirudin is getting very much popular in the pediatric population particularly, and a lot of publications are coming out in the form of the lesser bleeding, surgically placed cannulas, open chest. These conditions are better managed with bivalirudin, and obviously you can remove the chances of heparin, any chance of heparin-induced thrombocytopenia is or not. But if you personally, if I can personally tell that we have not yet shifted, and we are still at the heparin, and heparin-induced thrombocytopenia is a very rare condition as we thought it. Most probably the thrombocytopenia is because of the reason of sepsis or some other causes, then the heparin is the culprit. So most probably in the ground reality, people have not shifted from heparin to bivalirudin. But obviously in pediatric patients and cases of HIT, which is proved, people are using bivalirudin. And personally, I am not in a state to tell that how bivalirudin is better than heparin, because my usage is only related to two patients. One was the heat, a patient with a heat with a cannula thrombosis around the clot around the neck cannula, and another patient we have used in case of low platelet count was there, and we have used bivalirudin. But it didn't found much great of this thing. The availability is a factor, cost is a factor, and heparin is well taken in my practice. So probably it is not yet shifted by bivalirudin, but obviously in pediatric population it is getting popular, and in open chest scenarios, in the patient surgical cannulation cases, people are using bivalirudin like anything.
And Dr. Niranjan, how would you monitor anticoagulation? If you make a compare and contrast of the conventional methods or the point of care, what extra do you get by a point of care? And is it only with the ACT, or you use TEG and ROTEM very regularly? And where do you see the benefits of point of care compared to the traditional or conventional methods of monitoring coagulation?
Actually, neither of them is the gold standard, what I believe. So now coming to the point of care, the easily available and the cheaper one is of course the ACT, what everybody uses once they are using the heparin. Now, apart from that thing, and at least alternate day or some centers even monitor a daily once APTT once they put the patient on heparin because of various things. So ACT has its sensitivity and specificity. Sensitivity in the range of around 70, 80 to 80, and specificity again in the even lesser than that. So many times, even the ACT value remaining a very high, it's maybe 170, 180. There are cases of thrombosis, it happens, and everybody would have encountered. Many times we have encountered a filter clot on third day with a very well precisely maintaining ACT and all coagulation. We were happy. On day 3, we saw a surge in the transmembrane pressure, and we realized then, so alternate day, at least alternate day, APTT we keep on monitoring for these patients first. Second, coming to the TEG, unless the patient is having some unexpected bleeding or thrombocytopenia, okay, our center, we don't use regularly a TEG or ROTEM. We have a TEG machine. So we use for other things, especially for the liver transplant patient maintaining the coagulopathy, they regularly use. For our patients, only few cases, I believe 2 or 3 patients I have used. Yes, in specific situations when I'm confused about whether to target the ACT, I know the ACT I'm maintaining, still the patient is having some bleeding manifestation or thrombotic manifestation. So that time as a crude guide, that time we can use. I like to listen from other panelists, but our experience in ROTEM and TEG is limited.
Yeah, Dr. Arpan, if you could add anything to this with your experience. Being a cardiac anesthetist, you have used a lot of point of care.
Yes, the point of care, see, ACT is the gold standard. We use ACT for first 24 hours of ECMO run. But for after that, we have shifted to APTT because in or the lower heparin dosage, what we are using, that is more sensitive test. So we have shifted from ACT to APTT after 24 hours. TEG we have used when there is disproportionate bleeding is happening in spite of correcting everything. We have used TEG and we have found a lot of things like fibrinogen deficiency in the latter part of the ECMO run, which we have corrected by giving cryoprecipitate. And other things like low platelet and all these things you can see from your regular things. TEG and this ROTEM I have not used. The platelet function assays we have not used, and mostly my anticoagulation strategy is based on the APTT management because that gives a very good for this background of using is a lower heparin infusion, easily titrable with that APTT thing. Only problem, it is not a point care. The report comes after say probably an hour or 2 hours. But I did it at least 8 to 12 hourly to maintain a good APTT, and that suffices the thing.
Yeah, so my take here would be that if the patient is in some sort of equilibrium, then we can use the conventional methods. But if things are not correlating, patient is having it, is in some kind of turmoil of whether it is infection, bleeding, circuit thrombus or membrane thrombus, or those specks that appear in the membrane, and then that's when you want to be 100% sure, or you want to be not 100% but more sure of what exactly is happening. Maybe to reconfirm and reaffirm your thoughts, you can start using TEG and ROTEM. Yeah, so now since Dr. Arpan had already mentioned regarding HIT, and so what is your take, Dr. Gopal? Is it a overhyped diagnosis? And what are the other mimics of this heparin-induced thrombotic thrombocytopenia?
Yeah, as we see that heparin is commonly used as anticoagulation, and heparin-coated circuits are using for ECMO. And when the patient is developing thrombocytopenia, then those you have to keep the high index of suspicious. Sometimes it's overhype also, but we have to consider the other cause of the thrombocytopenia, like the severe sepsis itself, the infection like bacterial or fungal infection, then certain medication which responsible for thrombocytopenia. So that things you have to keep in the mind for the diagnosis of HIT. And its prevalence is 0.1 to I think 5% of prevalence, and more common in the adult group of ECMO patients, and even it is less in pediatric. But when the patient developed the thrombocytopenia, always we trying to blame the heparin is the culprit for that. So rather than that, you have to confirm that this patient having the HIT, and then you have to stop the heparin. That's the best strategy, what I feel.
Yeah, even I would agree that it is often fashionable to label everything as any for a patient on ECMO on heparin, but our experience has shown that it is not so. We do not encounter, and it's mostly an overdiagnosed thing, but a high index of suspicion always has to be there when you're dealing with thrombotic thrombocytopenia. Now,
yeah, can I add one point?
Yes.
So, like one peculiar, I like to share here a peculiar case. Now, we had a patient was typically fitting into the time frame of the thrombocytopenia to tell it is a HIT. Exactly on, I think, some day 6, day 7, platelet started falling straight from 1.6 lakhs to 1.1. The next day it becomes around 70,000. So now my young resident, then immediately then the next day morning round, immediately jumped and told, sir, it's without any doubt, it's HITs. Okay, just I told, okay, cool down, we'll see. So he showed, sir, there is no other cause of thrombocytopenia. So patient is fitting, and before I came, he has already written a HIT antibody test, the PF4 antibody, and it came positive also. So then even for some time I got biased. I thought it's a HIT we had like encountering. Then we switched to bivalirudin. Now the platelet never improved. Even after putting on bivalirudin of 4 days, the platelets were 60,000. In fact, sometime it went to 40,000. Then again we went back. We searched. So I saw the HIT antibody sensitivity is around 90%, but the specificity is only 36%. I was really shocked.
That is another problem.
So that means there's such a false positivity of such a high value. So it's only in 36% cases it can rule in. It cannot rule. So in near about 70% cases it can come as a false positive. So then some recommendations they do right. So they asked to do it 2 times. So I couldn't understand the rationale. Again I changed to heparin, and after starting heparin, after 3 days the platelets started improving. So many times we are getting even fooled with these tests also.
Yeah.
Nice.
That was a good learning, isn't it? So now let's move on to the transfusion practices, the transfusion triggers, and component transfusion practices. Dr. Arpan, if you could share, when do you actually start replacing products?
I think, all of us has probably going through the serial changes of our transfusion practices, because when we started ECMO, it was the also thing that hemoglobin has to be more than 12, your platelet has to be more than 1.5 lakhs, you have to maintain less than 1.5 your PT. But we have taken it back with our regular day-to-day practices. So now what we do for first 48 hours of our ECMO run, we try to maintain an hemoglobin of around 10, giving transfusions. But after that, my transfusion threshold comes down to below 8. And many times for the long runs, we tend to not to transfuse if it is stable at around 7 grams of hemoglobin over a period of time. And so to prevent the number of transfusions, because the increasing transfusions will only increase the infection, as we have seen in our COVID days. Second one is the platelet. Initially, we are so much enthusiastic to put the platelet count more than 1 lakh. But for the long run, it has always been seen the platelet is always at 70,000, 80,000. It is resting over there. And initially, we have transfused SDPs on 70,000 platelets, but now we have stopped. Even we are accepting a 40,000 of platelets. If there is no overt bleeding, we can tell relatives that this is a platelet. If it comes down below 20,000, we need to transfuse. But at the level of 40,000, if the other reasons are not matching with that thing, we need not to transfuse. So we have decreased our transfusion threshold to that level. And obviously, these two are the most indications, the blood and the platelets. This causes a lot of problems. So across the practice, if I tell that hemoglobin of 8 for a chronic ECMO run, for a stable ECMO run is acceptable, and don't transfuse if it is not below 7, and platelet accept 50,000 as the cutoff. Less than 50,000, start thinking of transfusing or prepare it. But if it is again stable, just wait for this thing. But more than don't target it more than a lakh for every ECMO run, which is obviously the fall of platelet is important. If it is 2.5, suddenly came down to 30,000, something is happening, some bleeding point is there, your cannula site is bleeding, you have a GI bleed, then you can transfuse. Otherwise, it is not wise to transfuse, because you keep on transfusing, and the transfusing platelets half-life is only 24 hours. After some time, it will lead to only another transfusion, nothing else.
Yeah, that's true. Now, I would also like to ask all the panelists here. Now, as Dr. Arpan said that, with experience, we learn to expand the indications. We also have learned how to decrease our threshold of transfusing. But we keep on, and also over time, we have also learned how to increase the complexities of patients on ECMO. Initially, now we are routinely facing patients or having to deal on ECMO. We add a CRRT into it. We sometimes add a TP, plasmapheresis filter into it. A lot of them must have started using routinely for if you want to remove bilirubin, maybe a plasma, some hemadsorption into it. Now, all these complexities to an already complex patient, now that needs a very finer balance and understanding of anticoagulation and transfusion. So I would just like all of you to share and what is the learning points and how often do you have to monitor, how often and how do you want to monitor patients who are on increasing complexities of ECMO? Dr. Arpan, Dr. Niranja, anyone who has had these experiences can.
Increasing complexities means when you are attaching CRRT or something.
Exactly.
So obviously this use of filters or any kind of CRRT or any kind of dialysis is going to add on your complexities. And for CRRT and other your dialysis and all this thing, our anticoagulation strategy we bit robust, because we have seen a lot of times you try to avoid heparin when you are using this kind of circuits because of the patient is not doing well and there is a chance of bleeding somewhere, so you don't want to anticoagulate too much, but it results in a lot of clotting inside your CRRT circuit, and probably the circuit half-life also comes down. So that is the way we use a lot of heparin when you use the CRRT or the dialysis circuit in the ECMO circuit. Because I always think of the clot in the smaller circuits is more dangerous than it's a bigger one. I can run an heparin-free ECMO with the bigger cannulas, but I'm afraid of using CRRT without heparin for a longer time. So my take on this, if we are using this complexity, if you are using the cytosorb, the efficacy of the cytosorb also comes down if you are not using heparin. So your actual the effect of cytosol you will not get if you are not adequately heparinizing the circuit and the filters. So I do use robust or liberal anticoagulation when we are using this thing if my condition permits.
Okay, Dr. Niranjan, now we are also expanding the indications of ECMO, and you have also, my understanding is that you have treated patients of dengue on ECMO. So how do you manage when the basic pathophysiology of the disease itself has to do something with the coagulation, and then you have to anticoagulate this patient? So how do you manage these patients?
Yeah. So regarding the dengue patient which we successfully managed here, so I tell ki probably it was a unknown graveyard which we crossed, and once we crossed, then we came to know ki probably it was a graveyard. Now to start with the case, so young lady comes to us with fever, some 4-5 days, was diagnosed with dengue. Now came, there was thrombocytopenia, around 70,000 platelet, and a cardiac arrest. Now the call came to me for ECPR. Okay, so the CPR was going on. It is 25-year lady. Now we had no option. Then I don't know, probably had I known it is a dengue or elective case, I would have thought, but it was a ECPR. I had no other ways. So to initiate ECMO then and there. Now we calculated VA. So initiated there, then successfully we were running in the middle of like the ECMO initiation. We started. Now somebody told, sir, have you noticed the platelet is 70,000? So then I told, when we didn't get time to notice that, you called for a CPR, ECPR, and we calculated. Then probably by that time we were in the middle of the river. Then we had to sail. There is no other way. Now then we went back and we checked. Of course, we contacted few people. Okay, those who were doing high volume cases. So then we asked, boss, we are in the middle of the some issue. Then how to come out? Then they told, okay, probably there are few case reports are there, ECMO in dengue or ECMO in other cases of thrombocytopenia. Rather than dengue, there are studies on ECMO in thrombocytopenia patients. So the target, as Dr. Arponsa told, like the 50,000 and probably 70,000 is the 70 to 75,000 is the cutoff to stop the anticoagulants. Now, as because it was 70,000 and we had already given heparin, then our fingers were crossed. Already, my perfusionist has given 5,000 unit heparin without consulting because they are used to give it whenever the ECMO initiation happens. Then we were fortunate not to have bleeding anywhere. So there was no bleeding, but yes, we noticed after we deconvoluted the patients, the patient had for minimum for 1 week, there was some leak from the arterial site. So that was a major problem. Rather, subsequently, there was some problem with the leak. Then again, patient went back to the OT. We have to put some surgery. Then again, a graft, bypass graft we have to place. So some problem happened because of the bleeding in the cannulation site subsequent to the ECMO. But we were fortunate to manage the patient. During ECMO, fortunately, no problem happened. And usually dengue patients, thrombocytopenia, rarely they do cause a bleeding. Unless otherwise the platelet falls to below 10 or 20,000. Our patients' platelets remained around 55 to 75,000. So that is the case with us, and it was a learning for us as well.
Well, that was heroic is what also I would comment on. Okay. Now, Dr. Gopal, as a pulmonologist, my question is, when do you involve a destination team? Generally, ECMO is a bridge. If not for not a VV ECMO, may not be a bridge always for indications when it's for shorter duration. But if it is a long duration ECMO, or so when do you involve the transplant team who can come in and decide on the destination therapy?
Yeah, we come across with one or two patients during the COVID era that the patients are putting on an ECMO proper, that the time initiation of ECMO at a proper time and everything, but they are taking at least 3-4 weeks. Then we think that, so if we think that if the patient having only isolated lung problem is the culprit and the patient is on ECMO, and with that going off ECMO of 2 to 3 weeks, the patient is not improving, and we think that patient is otherwise fit for the transplant, then we consult the transplant team to see the patient, and if we can do a transplant and we can come out from the ECMO also. So at that time, we call the transplant team and have a visit and see the patients and think for that whether they can go for a transplant or not.
Yeah, Dr. Arpan, could you share your experiences on this?
So number one question, that whether you have a destination team or not, that is one. Every center doesn't have a destination team. So that differs with your thing. And the second one is the question when to refer. So for heart, we take around 14 days time to say anything to them, whether this heart is improving or not. But for the lung, for classical ARDS in COVID times, we have seen that there are a lot of patients came back even after 2 months or 3 months. So we kept a cutoff of around 2 months for before this referring them for the transplant team, and then we can take off this thing. And if there is an obvious changes of honeycombing in the serial CT scan, that is also an indication where you refer the thing. So there are two indications that non-improvement within a long period of time, probably 2 months cutoff will be the better, because why I'm telling you 2 months, because if you refer them on second 2 months, probably the thing will materialize after a month. So probably the 3 months time is going to be. And I've spoken to one of our US friends. Their thing is probably the 100 days of ECMO, then they take for transplant and all this. If there are other neuromuscular recovery and all these things are fine. And UK strategy is again more robust. They want the patients to move around on ECMO, then they can go for transplant. For the lung, I'm telling you. But for us, probably the 2 months will be a good cutoff. For the heart, you have to take an early call, because 14 days is a good time to call them, to involve them, if they can do something.
I think if you remember that we have sent one patient to your, I think KIMS, the patient was shifted from Surat to anesthetic doctor who was on ECMO, and we sent him for a transplant, and then you people continue on ECMO, and now he's doing his practice also. But that our threshold is very, because the experience of ECMO here in Gujarat is now day by day, as Samir is doing a lot of ECMO, but we were impatient, and that all the logistics that make us too imperative to send the patient for the transplant.
Yeah. I would have a slight difference, maybe because we have the luxury of a destination team. But after a certain period of time, it's better to have some communication going on with the transplant team and the family involved. So everyone is in sync of where exactly and how the doctors are dealing with the problem. And if there's a window of opportunity where we can push in the patient for transplant, and that is how the stakeholders involved, like the family, the pulmonologists, the intensivists, it's always better to have some communication going on, and that helps in better decision making rather than having timelines. And that's been our our understanding and the practice also. Now let's move on to something more generic, out of the theme, but where I would like to hear comments from all the panelists of where do you see the ECMO program and how do you see the ECMO program evolving? It has taken a quantum jump after COVID, where every center is trying to practice ECMO and initiate ECMO, and a lot of enthusiasm among the younger colleagues to take up ECMO. But how do you see, and what is the right way? Should it be every center practicing ECMO in bits and pieces, or should we go the center of excellence way? I know the Indian healthcare does not allow for things, but just your on this. Who would like to take it first? I think both the Apollo guys are smiling, so Arpan.
See, as your Indian healthcare is there, we have started our program because our neighbor has started. So that is the most common indication of starting a program everywhere it is. So now it is a time where you have probably more than 300 centers in India who is doing ECMO. Out of that, probably 50 centers who are doing a good number of ECMO, probably 20 per year, probably their number. So, and obviously the papers came out that more the numbers center perform, so the outcome starts getting better. So there are a bit of rationalization is necessary, but the problem is the country is so huge and it is almost reaching 140 crores of population. Where you will get the center of excellence and the timing of the ECMO, how you transport them to the center of excellence, that's the problem. So probably a basic level of ECMO services should be available in all tier 2 cities, tier 3 cities. And we are getting calls now from the smaller nursing of the smaller districts also, because ECMO has penetrated to the masses. So masses are coming, and rather than doctors that probably the ECMO kind of some help, I'm in trouble in some, I got few cases of drowning also, which are referred for ECMO. So that's a good sign, and probably we need more centers, but with caution that outcome in the first 2 or 3 years might not be as favorable as when you are crossing your 5 years things and you have a destination team associated with that. But like poisoning ECMOs, which are rampant in the western part of the country, in Gujarat, probably in Rajasthan, probably in other parts of Delhi and all this, they have to develop their centers at every stage, because that is giving a very good outcome, and you can't wait for them to refer for the center of excellence. But for the patients who are longer ECMO runs, for the bad ARDAs, those requiring a transplant, or maybe probably they can be shifted to the higher volume centers, in my opinion.
Agreed. Even I firmly believe that ECMO should percolate to every center, and everyone should at least offer patients ECMO services, so the secondary collateral damage to other organs don't happen, and we buy some time, and then we can consult others and take more better decisions and give the patient a better chance. I firmly believe that. So it was very nice. So I think we are going short on time now, and I thank all the panelists for this wonderful discussion we had. Thank you, Dr. Arpan, Niranjan, and Dr. Gopal. And I hope all of us take home something we have learned from each other. I've learned one thing, to do CSSD on patients. I'm going to try that now, because infection has been a constant, a perennial problem with us. And let me see how it goes. Thank you all.
Thank you. Thank you, Dr. Samit Sahu, sir, for moderating such a good panel discussion on ECMO and ICU. And I thank all panelists for giving their own experiences. With this, we'll conclude today's sessions, and tomorrow we'll be back with an ongoing program. Very good evening.